دكتورة حصة. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good morning everyone and welcome in the third day of second حائل International Lifestyle Medicine Conference, Food is Medicine. We will start our educational program with the first session. Let me introduce you to our moderator. He is Associated Professor, College of Nursing in Jof University. Please welcome Dr. Abdelkarim Al-Sharari.
شكرا منى. Thank you for the introduction. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. رحب فيكم جميعا. Welcome all and good morning. Our morning session will have 9 presentations from our speakers today. Before we will have the morning break inshallah at 10 or 10:15 inshallah ta'ala. So our first speaker for this session is Dr. Hussa Al-Husseini. She will be presenting a topic on the pediatric diet. Dr. Hussa is a consultant in clinical nutrition who is interested in lifestyle medicine, and she's a former director of the Balanced Food and Physical Activity Program at the General Directorate of Health Programs and Chronic Diseases at the Ministry of Health. Please welcome Dr. Hussa Al-Husseini.
السلام عليكم ورحمة الله وبركاته. صباح الخير جميعا. I would like to thank you all for presenting early this morning. I would like to thank Dr. Farhan and Dr. Saleh Al-Raji for inviting me to this conference. And you are all welcome. I will start early to finish before there is 9 presentation in front of me. My presentation about family approach to pediatric nutrition. I will talk about it as brief as I can. You know that family approach is very important. Can you move the picture how family approach is very important for family gathering. We see this picture how family gathering is very important. How are they happy with gathering? This is my content. We will talk about how important is family planning. How will this affect the family planning or food planning on healthy children and healthy choices and healthy food. Nutrition requirements, I will talk a little bit about it, factors affecting the diet, and at the end, the conclusions and the recommendations. My introduction here is about the pediatric is a branch of medicine, usually between from birth to the 18, some countries to 15 years of age. And the taste of the children usually start or establish taste preferences and food habits as early as 2 years of age. They are man-made. They are man-made epidemic, and this is epidemic the food choices for pediatric or for pediatrics. Early nutritional environment also involves the develop effect late onset of disease. So we should be aware of family approach. We should be aware of family habits, family education of our children. Diet and nutrition play a key role in both the development of teeth or bone or health of the children, difficulty to make and sustain healthy changes. And this is what we are mostly faced on is healthy habits, healthy choices. Usually we have difficulty to make and sustain these healthy choices and healthy habits. Also, food as medicine is defined as a therapeutic method in which food and nutrition is used for the prevention and treatment. Usually, it's true that food is medicine. Food as a preventive measure, and I saw a lot of lectures before me talking about food as medicine, and they, mashallah, talked a lot. As a specialist, we committed to raising the level of and competency in food for all health care professionals. Competency is very, very important. We fully recognize the healthful eating patterns not only impact disease progression, but only influencing the patient's success in other lifestyle pillars. We know that our lifestyle will improve our quality of life. A family approach to pediatric diet can help to ensure that children receive the right nutrients, whether it's vitamins or minerals or energy requirements. I would like here the biggest and most influenced in our family and our children, the most influence is the mass media or advertising, and how will it affect our children. This small film will show this child, 6 years old child, how will he play with his father's mobile, and how will he spend money loosely in fast food.
Needing the
$1,000
phone
is the
to
cost.
play, and I wasn't paying attention. I was watching my show. Pizzas and rice and chili cheese fries.
How many did you order? How many chili cheese fries? Do you remember?
Like more than 12.
I looked out the window and he popped up and said, "Who's here? Who's here?" And cars are coming in the driveway while cars are leaving the driveway. Looked down at my phone and it said, "Chase fraud alert, $439 for pizzas." And then he tipped 25% on every single order.
Also tips.
How much money did you have in your piggy bank?
115.
And how much do you have now?
1 cent.
$1, 1 cent. They took my money.
This is my lesson, first and foremost, and hopefully parents out there see and learn from this.
So we should pay attention to our children and not just be busy. Even if we are busy, we should pay attention to these things. Family approach to healthy food, the rule of taste preferences begins as early as 2 years. And we know that the only taste preference we are born with is mother's milk. All other tastes are learned. We can teach them to our children. Early flavor experience build the foundation for lifelong taste preferences. We teach children how to prefer high fat, high sugar. We give them as gifts since they are born. We give them candies. Our children, we give them all the sweets, soft drinks, juices, sugary drinks. We can teach them the opposite. The importance of family meals goes behind the nutrition. Parents, carriers should take care of that. Family approach to healthy food. Also, we share the planning of the family. You should share your child with the planning. Be a role model. You are a role model for your child. And keep the healthy snacks with you. Usually they need the things that are accessible. They can view it. Serve healthy food, share grocery shop, and avoid battles over food. Usually our guidelines, whether it's OD guidelines, USDA guidelines, they actually lack some nutrients. In US, they lack calcium, potassium, fiber, and vitamin D. In Saudi, usually iron and vitamin D. Family and social influences. Children are more likely to eat food that are available and easily accessible. They tend to be, when you provide greater quantities, they will eat the quantity more than the quality. also factors such as education, time constraints will affect their choices. Meal time is very important. TV viewing is very important. Source of the food is very important. A systemic review, 1980 to 2014, undertaking suggests complementary nutrition interventions are needed to build the supplement for healthy eating generally. So vitamins and minerals are very important. Patients, unusually from food that are fresh food. Patients are too busy to talk with the providers. I mean, parents are busy to talk to the providers or their housemates or their children. So time constraints is very important. We should take care of that. The plan or healthy eating plan, we should eat lots of plant food, adequate protein, minimal processed food, limited saturated fat, added sugar, and sodium. And usually, our saturated fat shouldn't be more than 10%. The salt shouldn't be not more than 1 teaspoon, and the sugar 10% also. In children, we do stress the breast milk at least up to 6 months. Low fat should be provided from 2 years. This schedule is very important. I did it by myself, the guidelines. We know that age is very important, that sex is very important. It's the calories, the protein, the fruit, the vegetables, and the grains, usually with cups or grams, and the dairy products of how much. And the source is putting here, Mayo Clinic source. Impact of children nutrition. The children, children nutrition will affect chronic diseases. One of the chronic diseases is cancer. Less fruit will make us, less fruit consumption will make more constipation, less total plant fiber, more meat consumption, red meat, overweight will affect the cancer, higher calorie intake, taller stature, or early puberty will affect, or the age, or rapid growth will affect the cancer onset. This is just some of the reasons about cancer. Here, processed meat is very important to stress here. I will stress here the processed meat. It's very dangerous to eat processed meat or processed food, or even red meat very occasionally. Obesity, it can come as young as 8 years and cuts about 20 years of our life expectancy. And we are now about 60%. Pakistan and Egypt are the most countries with the highest number of diabetes. Global burden study 2017 using collected 1990 to 2017 from 195 countries, and healthy diet are low vegetables and fruits, whole grains are the most reason for the NCD disease.
5 minutes.
Learning how to make valuable skills to learn to make food at home. We see this picture, how the changes in obesity within 32 years in the same place, the same school. Pediatric asthma has also a rule with our diet and our healthy food. Constipation is very important. Heart disease also can come as early as 10 years. This is our requirements about sugar. We like to be as much as 5%, which is not more than 6 teaspoons, not tablespoons, 6 teaspoons, which is 25 grams. So this is the balanced diet. We should eat fruits, vegetables, at least 5 servings a day of fruits, vegetables, which is about 400 grams a day. Legumes, grains, healthy food, and minimize the beverages of food, ultra-processed food, processed meats, food high in salt, or bad oils. قاعدة الثلث أو ثلث لطعامك ثلث لشرابك. Oxygen, food and water is very important. Good quality food is very important. Small quantities for important. Nutrient dense. Don't drink your calories. So قاعدة الثلث أوصانا فيها الرسول صلى الله عليه وسلم: ثلث لطعامك ثلث لشرابك ثلث لنفسك. هذه لو طبقناها بس هي كل المحاضرة يعني. Breast milk is very important. We know that. We know the composition is balanced. We know that more whey protein. And here the breast milk is less saturated and more unsaturated. It's a balanced milk. Here the study, the result indicate that children who were bottle fed are more were shorter than the children who were breastfed. And this was one of the studies to 2020. And this is a study in US about junk food. The result increased the number of obese children. Factors affecting pediatric diet. We know that the growth and development of the children, it's affected with diet. Culture, our culture is very important. Here I see the tea, they give the tea with sugar. The sugar is inside the tea. We are all in Kingdom Saudi Arabia, but in Riyadh, we serve the tea without sugar. The sugar is outside. The sugar is your choice. Here, I don't have the choice. You give me the tea with the sugar. So we should, this is our culture, but we should, as educated, give the tea with no sugar. And leave the sugar as a choice for the customer or for your visitor. Cultural and religious beliefs, for instance, some they don't eat animal, they are plant food. Personal preferences is very important. You should take, as a patient or a 0-year-old child, you should take his preference or her preference. Factors affecting the diet also, advertising, as we just see in the film, advertising is very important to avoid not eating over while sitting or while using programs, electronic programs. Food allergies is very important. You should notice your child if he has allergy or not. Introduce the food gradually to the child. Notice the nausea, vomiting, and diarrhea. My conclusion here is the family approach it's a holistic approach. We should all participate in our child diet. Energy and nutrition needs vary depending on the age or the child stage of development, the sex, or the activity. Family approach is for improving the health outcomes. Why are we concerned about it? Because it's the health outcomes of the child. Providing healthy choices, proper family nutrition takes time and effort, but it's worth it. This will take time from you as early as you can, but it's worth it. The data gathered 2023 review calls immediate action for breastfeeding. This is also for breastfeeding. So it's your choice to choose your food. My recommendation here is to do longitudinal studies for sustainability of these habits. Our habits, we should know what to cover and what to quit. Study of cultural and socio-economic factors are very important. Investigate the effectiveness and interventions aimed at increasing family improvement. Healthy eating means more than just looking recipes. It's just not recipes or and the latest diet fads. What diet should I follow? It's not the diet you follow. You can do a healthy diet without following a diet. It's just portion size. You need to concentrate in your portion size. As long as you concentrate in your portion size, then you don't need a diet. It's just you need fruits, vegetables, portion size, and fiber. Here, change the habit instead of by practicing lifestyle and just not using the medication. Here, I will show some picture how people will eat all the food and then take diet, Pepsi or diet. Here also, the difference between the one active and the one eating on the bed. Here, how we go in our hospitals with all the food with us. Also, making exercise and eating at the same time. Making walking and eating. Sleeping with all the food in the bed. Take quick eating and eating so much. So change and quit bad habits as much as you can. Fast food, soft drinks, and that's it for today. I hope, and thank you for all.
Thank you very much, Dr. Hossa, for your informative and educational content. I really very much like the pictures, the contradicting lifestyle habits. Really, at the end, very informative. Thank you. Our second speaker for this session is Dr. Samia Al-Mahmadi. Dr. Samia is a family medicine consultant and a lifestyle medicine specialist. She is a member of the organizing and scientific committee of the Second Lifestyle International حائل Conference. Dr. Hossa is also the deputy chair for the Healthy Lifestyle Society. Dr. Samia will talk about lifestyle medicine as a model of care. Please welcome Dr. Samia.
السلام عليكم. في البداية أحب أرحب بالجميع الحضور. حقيقة أنا سعيدة اليوم بنجاح المؤتمر، مؤتمر حائل الدولي لطب طب نمط الحياة، وسعيدة بجميع الناس اللي لبوا دعوة الحضور as a speaker. حقيقي مشاعري يعني مختلطة الصراحة اليوم، وأنا أشوف نجاح هذا المؤتمر فعلا يعني بدأت ثماره تظهر، يعني بدأت نجاحاته تظهر. طبعا في البداية my talk today I will talk today about lifestyle medicine and model of care. All we know the vision of 2030. Now it's concentrating about the model of care, and all we know the model of care contains 6 pathways. One of these pathway and one of the important pathway, it's keep well pathway. So today I will link about how it's lifestyle medicine. It's very strong to be one part of our model of care. Our objective for today, it's overview of a clinical practice in lifestyle medicine, correlation of the model care and lifestyle medicine. How is the community-based wellness program, it's have relation with lifestyle medicine model. Overview of the community collaboration model and community engaged lifestyle medicine model. Virtual setting in lifestyle medicine practice. And also we will talk about the lifestyle medicine solution care model and effectiveness. Overview of the SHIP and effectivity of this SHIP program to decrease the cardiovascular risk. Implementation of the lifestyle medicine practice model in primary health care, and also we'll talk finally the fact of the lifestyle medicine practice in Saudi Arabia. The American College of Lifestyle Medicine, it's defined the lifestyle medicine as a medical specialty that using the lifestyle medicine intervention to treat the chronic disease and their implication. As we see here in this picture, this is the 6th area of the lifestyle medicine. It's caring about the healthy eating, physical activity, manage the stress, maintain the relationship, and improve your sleep, and also avoid the risky substance. The physicians specialized in lifestyle medicine, they are trained to apply the standard to change the lifestyle medicine based on the evidence and scientific evidence, and applying 6 axes of the lifestyle medicine. And now, our question for today: how lifestyle medicine is succeed in the model of care? Do you think it's lifestyle medicine, it's important to practice in our daily basis in primary health care? As we see here in this figure, this is the model of care. We see this 6 pathway. One of the important pathway, it's keep well. Keep well pathway, it's only focusing on the people health and how they take care of their health, and also how to decrease the risk of chronic disease such as diabetes, hypertension, and obesity. And if we see the 6th layer of the surfaces, so we will start by activated person. So we will start by activate the person through the health promotion, and also healthy communities and virtual care. And we will see how to practice family medicine through only the first 3 layers before we start introduce it in the primary health care. So keep well pathway, it's focusing on empowering the people, supporting them that necessary tool to activate them to take care of their health, and will begin by enforcing public policy that decrease the risk, and also creating communities and environment that promoting will begin, developing education and behavioral programs that raise the awareness and encourage people to practicing lifestyle and healthy lifestyle. As we see this in this big figure, we see here, this is the keep well structure. It's containing 5 areas, and also we contain 7 programs until now. We will see here healthy healthcare provider. One of the program is community-based program, wellness program, and healthy food promotion. Also the neighborhood communities promoting the Saudi CDC. Also the school wellness program. We have a health coach program, and we have workplace wellness program, and also health entertainment program. What do you think the function of keep well pathway? It's keep well pathway, it's designing the program to keep the community well, and also monitor the implementation of keep well intervention, coordination and collaboration with community institute, develop KPIs and collect data related to the keep well initiatives, and also coordinate to upskill and train the staff according to the need of keep well intervention. So we'll see how this function of this keep well program, it's linked with lifestyle medicine model. So we'll start with the first program. It's community-based wellness program, and we have 2 models of the community-based wellness program. We have 2 models of lifestyle medicine. So we'll start by community-engaged lifestyle medicine. So if we want to start to practice the family medicine, we need to start by our community. So we need to start to practicing the community-engaged lifestyle medicine. It's engaged all the high-risk communities, member and stakeholders. This need to build reliable long-term health equity and engage the population in the lifestyle medicine clinic. And also we have another model. It's called community collaboration model. It's very simple model. It's only need 1 clinician and 1 administrative, and also it's need only small space in your clinic, not more than 30 to 60 minutes for consultation. The more advantage, it's low cost, and build lifestyle medicine consultation in the primary health care. So we will see the second program. We see it in the Keep Well pathway. It's health entertainment program. We have one of the model. It's also linked this program with lifestyle medicine model. We have lifestyle medicine solution care model. It's one of the primary care practice model. It's regarding to the new care delivery model of lifestyle medicine foundation through using phone, email, and through texting message. And also it's need also a team-based approach, depend on the provider, health coach, medical assistant, and practice manager, and also multiple contracting provider such as dietitian, personal trainer, counselor, and life coach. In a study of 2010 about mobile phone-based care model of outpatient cardiac rehabilitation, they integrate the mobile phone and web services into comprehensive home-based care model for outpatient rehabilitation. The program, it's only 6-week program with weekly session focusing on lifestyle medicine. So all we have our phone today, we can just have an application and you give this patient or a cardiac patient this application, and they are registered the daily blood pressure, smoking, exercise, and daily steps, and the sleep hour and weight. So they find it's very effective for self-management for cardiac rehabilitation patient. Also, we'll talk about the Complete Health Improvement Program. This, it's called, it's very famous by SHIP program. It's intensive lifestyle medicine intervention. It's focusing on the patient with diabetes, heart disease, hypertension, reducing overweight and obesity, and also reducing the risk of cancer and osteoporosis. Using the whole planet-based food, physical activity through 18 sessions. So it's community-based program, contain video lecture and class discussion for 45 minutes. So this is this SHIP program. It's designed program. Just you can practice it to your patient. There is a lot of a study. They showed this type of a practice. It's very effective to decrease the weight and decrease the high blood pressure. We see this study, cohort study between 2007 to 2009. It's regarding to the 284 patients. Just they are complete 30 days of SHIP program, and they show significant lowering of the BMI, blood pressure, and total cholesterol and triglyceride. The conclusion, how the SHIP's lifestyle intervention, it's improve and maintain the biomarker for the patient more than 3 years. Also, there is recent study regarding to the SHIP program. It's regarding to, they evaluate 73 patients, pre and post program biomarkers, and they applied 18 structure session over 12 week time, and they found significant decrease in the blood glucose and weight, and also they found this, it's very effective to treat the hypertension and diabetic patient. Now, we will ask about how we achieve the maintaining of lifestyle medicine for our patient practice. The job of caring patient and providing guidance and how to adopt and sustain long-term healthy habits. So I think this is our challenge for today. I think we need to start how to achieve this goal. Collaboration with the patient, I think it's very important, collaboration with the patient and families to develop action plan for lifestyle medicine practice. And also it's need interdisciplinary team. And also we need to implement the lifestyle medicine practice in our primary health care. It's one of the main block in our healthcare system. Lifestyle medicine practice model in the primary healthcare. Do you think we are practicing lifestyle medicine? It's easy to practice it? I think yes. We can practice and implement lifestyle medicine practice. I think it's a big challenge, but we can do it with collaboration team. Also, they find in the cross-sectional study about implementation of the lifestyle medicine promotion in the primary health care, it's very significant, more positive toward the effectiveness of the practicing. If we talk about the lifestyle medicine practice in Saudi Arabia, I think our vision today, 2030, it's need to practice lifestyle medicine in our daily basis in the primary health care. This is very important to decrease non-communicable disease and also to promote health through the wellness pathway. Since Vision 2030, the Kingdom of Saudi Arabia now they need to achieve this healthy society and goal to increase the life expectancy of 80 years in terms to reducing chronic disease and complication leading to cardiovascular disease. And also we need to achieve this goal through the introducing the lifestyle medicine today with the Keep Well pathway. Our health care system, it's under umbrella of new healthcare model. I think we can operate and we can succeed to practice it. As we see here, طبعا أنا خادم الحرمين الشريفين وولي عهده الأمين حرصوا جدا على ممارسة نمط الحياة الصحي وبدأوا في إضافة التشريعات منذ عام 2017 كان في تشريع يوافق على تبني أن تكون الصحة العامة سياسة أو أولوية وجميع الأنظمة والتشريعات لمكافحة الأمراض والوقاية منها. شكرا لكم يعطيكم العافية.
Thank you, Dr. Sami Al-Mahmadi, really very informative and on time. So our next speaker for this session is Dr. Saleh Al-Ghamdi. He is a clinical genetic research and health strategy consultant. He's the Director of Applied and Clinical Research Administration Research Center in Riyadh, the second cluster. He's also the president of the Saudi Society of Medical Genetics. Dr. Saleh will talk about the epigenetics and nutrition. Please welcome Dr. Saleh Al-Ghamdi.
Assalamu alaikum. Good morning. Thank you, Dr. Abdullah, for a nice introduction. Can I have the slide, please? I think you have heard epigenetics too much in this conference. And this is really, for me, it's a good sign that we are moving toward more deeper of information. So I will pass through very quickly over some information which has been mentioned by my colleagues yesterday and the day before, and we will go to the final things, which is the final conclusion, which we need to discuss it and we need to dig more in it. Epigenetics and nutrition. You know epigenetic by having more than 3 lectures mentioning and discussing the epigenetics. Nutrition, we are talking about nutrition all days, all those 3 days. So I think I should end up my lecture here that the epigenetics is really nutrition and the nutrition is epigenetic. So we have to admit that the relation is very strong and we will see the evidence there. The epigenetic, that's the changes which is involved, alteration in the DNA sequencing, and the epigenetic is involving changing and affecting gene activity and expression, and there is a lot of information about epigenetic which has been mentioned over the 2 days. I will not be repeating those informations. But to know that the epigenetics is part of making the chromatin, which is the main part in the nucleus or the nucleus formation. And this is the scheme which shows where is the structure of the DNA or structure of the chromosome, that at the end of the DNA, you will see the DNA helix, which is moving across the, making the helix arrangement, using and supported by epigenetics, and also affected by epigenetics in functioning. And most of the literature mention about the importance of the histones and nucleosomes, which is really play a major role in the functionality of the genes within the nucleus and within any function. The chromatin structure, I think this has been passed through several times. So, but just to know that this is the the structure which is really the functional structure. The functional structure which is will end up by having, as I mentioned, the helix rounding across the histones and also the bindings of different part of genes, which will make the gene varies between environment to environment. And will make the chromatin either eukaryote or heterochromatin or euchromatin within the nucleus if it shows under the electron microscopy, or even under normal microscopy, will be very clear the coloring and the variation of the colors. Actually, this all information has been mentioned, and the histones and the 3D structure, which is really important for the structure of the genetics. The regulation, the main regulation which has been mentioned also by my colleagues yesterday, the methylation and also histomodification, acetylation, and also the other function, which is really changing the functionality of the cells dramatically, and will be moved from function to non-function and from non-function to function by having different epigenetic by different activities happening there, either by acetylation or methylation or even other themes. Though the importance of this, the importance of the enzymes of the histone acetyltransferase, that it's happening, and it's multiple families like GANT and MICE and CBB, GTF, and have multiple function within the nucleus and can affect the whole life, affect the even the intaking of many functionality after those. So this is the different, as I mentioned, histone modification has been studied very well and mentioned. So also the function of histone, as I mentioned, that it's either by activation or repression, and will be having major role in many activities. And in a gene level, in a chromosome level, there is a lot of functionality there. Also, there is a lot of another functional, like in if it's by recruitment or any modification, and by doing the coding, and there is a lot of combination. I think this all has been covered. I want to repeat it. I will go direct to the summary for this histone modification. It's either by HAT or HMT or kinase phosphatase will affect or will result of histone modification, and those histone modification will be either local structure changes or binding site of protein or epigenetic mark for EU and heterochromatins, and all those changes in epigenetic will have a biological event which will affect our subject there. And as you know that there is a lot of impact which has been discussed yesterday, but we will go through some of them today. One of them is the nutrition and lifestyle of mother will affect the epigenetic of the child. And this has been studied in many studies, as well as the identical twins acquire discordant epigenetic during life course. And we would see one of the studies which is having the changes in chromatin on 3 years and 50 years, and the variation between this, where they were having the same genetic makeup, but the only factor there was the epigenetic. And the maternal care also affect epigenetic by offspring. This is one of the things which is known as a role, or as one of the biological equation, genes plus environment plus epigenetics will be integrated and will have the disease characteristic. And this is really very important point, that the gene itself will not be end up by the disease or life characteristic. It's all three factors, by gene, by environment, and also epigenetic, which is play a major role in this. And the biomarker correlation with disease and epigenetics therapies too. This is the study which I mentioned. This is what studies 2005, and they have studies the chromatin or the chromatin pattern by two twins lifestyle in 3 years and after years old twin, and you can see the variation that happening within those 47 years, supporting that the epigenetic and the environment effect is a major player in our genetic makeup, or let's say more specific, epigenetic makeup. There's one journal with one article which is I really like it. I really encourage everybody to have it, download it and read it. It's about 29 pages, but it's really very, very informative. And it is touch on our subject today and in our whole symposium, which is dietary modulation of the epigenetic. Dietary genetic of the epigenetic modulation of the epigenetics produced by Physiological Review. It is by the American Physiology Society, and it's really an important paper which is cover all the things, and this is what will make the epigenetics and epigenetic regulating enzyme writers and the marker by methyl group, acetyl group, also the micro RNA. And also the markers will have effect on each other, and also all of them will be affecting the psychological outcome, and the psychological outcome will have an back effect on diet, and it will be cycle. So with the whole cycle, this cycle will be repeating day after day, year after year, and we'll have the final result or the final outcome of our genetic makeup with makeup. It's a genetic, but the epigenetic like is more make it more beauty or more represented. This is one of the things which is really an important issue, which is the alteration diet pattern. If you go to the gastronomy, physical activity, psychological well-being, minimized carbon footprint, which is really, this is the lifestyle. And this is the real lifestyle which we are talking about all days. Those will do the epigenetic modification, and we have to be really aware and put our eyes on the what we call it epigenetic clock. Epigenetic clock, there is a clock. If there is protective factors like healthy food, exercise, stress-free environment, which is really making the three models emotionally and physically, and also the food intake. And if we have the risk factors, this will be really another direction by having an obesity, overweight, sedentism, toxic and drugs, stress, and which is really will be having an effect on our epigenetics. These factors or this clock will have the effect on our healthy aging, and will if you watch it and monitor it very well, it will be affecting our cardiovascular disease, obesity, cancer, type 2 diabetes, and even the neurodegenerative diseases. And this has been published recently, last year, which is a really very important informations.
5 minutes.
Inshallah, less than. This is just summarizing everything, that the epigenetic at the beginning, at the center here, it's affecting the person either by lean phenotype or obese phenotype. And the lean phenotype will affect the epigenetic makeup and vice versa. So it is a cycle, and we will end up by having either normal phenotype or disease phenotype based on the obese phenotype, and also safe or harm. So this is your choice, this is your decision, and you have to walk it through the whole life and decide where do you want to go, either for harming yourself or for saving the life after the مشيئة الله سبحانه وتعالى. This is just to show you the integration, the real integration between the diet and the epigenetic regulators enzymes. There's a lot of pictures like this in most of the activities within the nucleus. You will see effect for nutrients and nutrient metabolites and epigenetic regulators enzyme. And as you see, all blues are some of nutrients which we are taking it from by our diet. The nutrient metabolites, which will be happening, and the epigenetic regulators enzymes, which will be affected by the nutrient, or the nutrient will affecting them. So it's really an important, and it's really integrated, and we need to watch it very carefully, and being very care about this information. And as this is one of the example, it's part of it also. If we have high dietary fat, you will see that the epigenetic mark will be increasing, and some of them will be decreasing, depend on the factoring, and will have different effect either by lipid trafficking, or by insulin sensitivity, or by cholesterol, increasing of the cholesterol. So we have to make sure that the epigenetic is one of the steps after having the diet, and as I mentioned, the diet will be affecting it. This is the journal which I really recommending to be read, and to be actually put in as one of the main publication for this, as a recommendation by this conference. In summary, as I mentioned, epigenetic affecting diet affecting genetic, diet affecting the epigenetic, and we have to be very careful and study it very closely. And I think this is the era of to have more collaborative studies between the geneticists and the lifestyle medicine practitioners and other specialty, to come up with a really good model for this. By this, I will end up my talk, and thank you for your listening, and hope that I have something.
Thank you, Dr. Saleh Al-Ghamdi, for covering the epigenetics and nutrition topic. Our next speaker is Dr. Najd Al-Shammiri. She's a consultant in obstetrics and gynecology. She's the head of department at the obstetric and gynecology in the maternity hospital in حائل. And she works also as a teaching assistant at the College of Medicine, University of حائل. Dr. Najd will talk today about the pregnancy nutrition. Please welcome Dr. Najd.
السلام عليكم ورحمة الله وبركاته. صباحكم سعيد جميعا اليوم. أنا جدا سعيدة بوجودي معاكم لايف ستايل ميديسن. في البداية أود أن أشكر اللجنة العلمية في المؤتمر على رأسهم دكتور صالح الراجحي، دكتور سامي المحمادي، شكرا على دعوتكم الفاضلة، واللجنة التنظيمية بقيادة الدكتور فرحان الشمري مدير الشؤون الصحية في منطقة حائل. أنا جدا سعيدة بكونكم موجودين من حائل، بكوني أني أنا من أهل منطقة حائل. جدا شرفتونا وجدا سعيدة بصدى المؤتمر وسعادتكم بوجودكم بحائل. إن شاء الله حائل ستكون من أفضل المدن بخصوص النطاق الصحي بإذن الواحد الأحد. What I'm going to talk about today, inshallah, is explore the guidelines change in diet during pregnancy. My objectives is importance of healthy diet during pregnancy, dietary patterns, and the maternal and birth outcome. It's a systemic review result. The statement, the cultural statement of eat for two, and weight gain during pregnancy, food safety during pregnancy, my recommendations. I hope, inshallah, you will enjoy it. First of all, importance of healthy diet during pregnancy. We should agree that pregnancy is a physiological change, it's not a pathology. So, according to the physiological change, there is a change in the demand regarding diet. So, a healthy, balanced diet during pregnancy is essential to support growth, optimal growth and development of the fetus and the physiological change that occur in the mother. The comprehensive improvement in nutrition and health status of women before, preconceptional and during conception and post-pregnancy contribute to optimal fetal growth and lead to favorable obstetric outcome, improved perinatal survival, and the potential better for long-term health in both mother and the offspring. There is a statement in the guideline that says poor and inappropriate maternal nutritional status is causally associated with abnormal fetal growth patterns, including low birth weight. Low birth weight defined as less than 2,500 grams. Or small for gestational age, which defined as less than 10 percentile for birth weight for gestational age, or fetal growth restriction, or macrosomia, which means 4.5 kg, and large for gestational age, which defined as more than 90 percentile birth weight for gestational age. Each which associated with increased risk of developing childhood and adult chronic disease. However, there is a recent Lancet paper estimated that 20 million of infants will born with low birth weight globally. So progress toward achieving the target has been slow regarding the maternal nutrition. So maternal nutrition status including low and high pre-pregnancy BMI score, inadequate weight gain, short stature, anemia, micronutrition deficiency, causally associated with low birth weight, which may be a result of preterm birth, impaired fetal growth, or both. The dietary pattern and maternal and birth outcome, it's a systemic review result. It shows the impact of improper diet during pregnancy regarding some of conditions in pregnancy. It's a systemic review led by the USDA and HHS. This systemic review collaborated with NESAR. It's an expert group studying the dietary pattern during pregnancy in conditions like hypertension disorder of pregnancy, gestational diabetes mellitus, and gestational age, birth weight. This study has some limitation of information because of the difference regarding the race and ethnicity. However, the hypertensive disorder pregnancy, there is limited evidence in healthy Caucasian women with access to health care suggested that dietary patterns before and during pregnancy that are higher in vegetables, fruit, whole grains, nuts, fish, vegetables, and lower in meat and refined grains are associated with the reduced risk of hypertensive disorder of pregnancy, including preeclampsia, gestational hypertension. Not all the components that assist dietary patterns were associated with hypertensive disorder, which means that the evidence is insufficient to estimate the association between the dietary pattern before and during pregnancy and risk of hypertensive disorder of pregnancy in minority of women and those with lower socioeconomic status. And regarding the gestational diabetes mellitus, limited but constant evidence suggests that certain dietary pattern before pregnancy associated with a reduced risk of gestational diabetes mellitus. Protective dietary patterns are higher in vegetables, fruits, grains, nuts, fish, and lower in red and processed meat. Most of the research was conducted in healthy Caucasian women with access to health care. Evidence is insufficient to estimate the association between the dietary pattern during pregnancy and risk of gestational diabetes. Regarding the gestational age, limited but constant evidence suggests that certain dietary pattern during pregnancy associated with lower risk of preterm birth and spontaneous preterm birth. Protective dietary pattern regarding the preterm delivery, including higher in vegetables, whole grains, seafood, and lower in red and processed meat and fried food. Anyhow, most of the research was conducted in a healthy Caucasian woman with access to health, but evidence is still insufficient to estimate the association between the dietary pattern before pregnancy and gestational age at birth, as well as the risk of preterm birth. Birth weight, there is no conclusion can be drawn on the association between the dietary pattern during pregnancy and birth weight outcome. Although research is available, but the ability to draw the conclusion is restricted by the inconsistency in study finding, inadequate adjustment of birth weight for gestational age and sex, variation in study design, and dietary assessment methodology and adjustment of key confounding factor. It's still insufficient evidence exists to estimate the association between the dietary pattern before pregnancy and birth weight outcome. There are not enough studies available to answer the relation between the preterm birth and relation to a specific dietary pattern. So now we reach to the culture statement that you need to eat for two. Do actually pregnant women need to eat for two? No, they do not need. Because according to the guidelines, what do they need? It to increase their calorie based on the gestational age. Each trimester has a specific calorie to increase. So, women and providers commonly ask what a healthy diet for a pregnant woman should look like, and the message to us is women should eat better, not more, the pregnant woman. This can be achieved by basing the diet on a variety of nutrition, dense whole foods, including fish, fruits, vegetables, omega-3, fatty acid, and whole grains, in place of poorer quality processed food and beverage to enhance the nutritional quality without excessive energy intake. The strategy to improve the maternal nutrition should avoid more is better approach. Overconsumption of certain nutrients can pose significant problem, especially individuals who are already achieving sufficient intake. Problem that may aggravate the overweight or obesity during pregnancy. If they eat more, they will get more weight, which obesity has an evidence-based medicine that obesity in pregnancy, it's very risk to have a preterm birth, more risk to hypertensive disorder during pregnancy, more risk to have an bad obstetrical outcome during delivery, in addition to the post-delivery difficulty in losing weight during the postpartum period. The nutritional demands of expectant mothers differs notably compared with women who are not pregnant. Nutrition intake is highly individualized Variability can be attributed to numerous interplaying factors, including individual-based nutritional status, disease status, genetic, socioeconomic status, and allergic status of the pregnant woman. When providing nutritional guidance during maternal journey, it's important to consider the different phases: preconception phase, pregnancy phase, and lactation phase, to ensure the additional physiological requirement of mother and offspring are appropriately met at the right time. So, what do this table showed? It's the estimated change in calorie needs during pregnancy and lactation for women with a healthy pre-pregnancy weight. This table, it's from the dietary guidelines for the Americans 2020 to 2025. Each trimester and the lactation period has a specific increase in the calorie in addition to the pre-pregnancy calorie. For example, the first trimester, we have 0 calorie to increase above the calorie that she's already taken. For the second trimester, she needs to have +3 for 40 calorie in addition to her calorie she is demanding. So, this table recommended reproductive diet patterns. The nutrition science, the last volume was published in 2022, September 2022. There is a statement that the nutrition pattern, it should not be customized for all pregnant women because we are different. What I eat is different from what you eat, and this is also applicable to the pregnant woman. What a diet should be, it should be individualized, tailored according to the pregnant needs and what actually she is has a risk or no risk, and also the socioeconomic status, the genetic and the allergic status also should be tailored according to the individual herself. So this is only an example. The recommended reproductive diet patterns for the Mediterranean diet, which is plant-based food, vegetables, fruit, whole grains, nuts, herbs, olive oil, fish, and up to 40% calories from fat. The exclude limits red meat a few times per month. Benefits reduce the risk of cardiovascular disease, mortality, cancer, and cognitive disease. This is one of the good healthy diet, is the Mediterranean diet. Also, the dietary approach to stop hypertension. If patient is hypertensive pre-pregnancy, we should tailor her diet according to her pre-pregnancy status. For the balanced complex carbohydrate, 85, lower fat, and lower in cholesterol, high in protein, it reduces weight, lower blood pressure and cholesterol, reduced risk of cardiovascular disease. The risk, it might need a vitamin D to support the diet. And for the diet to avoid during pregnancy, for example, like keto diet or ketogenic diet, which consists mainly on the protein and fat and exclude the starchy food or carbohydrate. And the benefits of this diet is reduce weight, but it's not recommended during pregnancy because it lacks a lot of vitamins and minerals. And it might alter the neonatal brain development because of needs of vitamin C and B, and the ketogenic diet lack of vitamin C and B, folic acid, calcium, and fiber.
2 minutes to finish.
This picture, it's from my plant plan, which is an access website. You can fill just your data and you can reach what diets suitable for the pregnant woman according to her age, pre-pregnancy status, weight, height. This table, it shows the expert recommendation for daily supplementation during pregnancy and the difference between each guidelines. For example, like WHO, vitamin A only in population where deficiency is severe in public health problem. The ECOG and NAS, there is no recommendation in their guidelines. For vitamin B6, it's recommended for nausea in the WHO, and for the NAS, they recommended 2 milligram for pregnant women. For example, like the iron, we can see the WHO recommended 30 to 60 milligram, and NAS 30 milligram. ECOG, they recommended for needs, if patient needs to take iron, as well for the other vitamins. The healthy US-style dietary pattern for women who are pregnant or lactating with daily or weekly amount from food group or subgroup, according to their calories need per day, they divided their vegetables, the portion of vegetables, fruit, grains, dietary, and protein. This is only a suggestion. And I repeat that it's individualized, tailored. We cannot put a schedule for every woman because their status is different from a pregnant woman to a pregnant woman.
1 minute to sum up.
Caffeinated beverage during pregnancy. This is very important. That mean caffeine content of a drink according to the AFSA 2015. The given safe caffeine dose for a period of pregnancy, it's not exceeding 200 milligram per day. So this is the drinks and how much they contain according to the amount of the beverage. The Ministry of Health, they are working on the pregnancy, regarding pregnancy in whole approach, and nutrition in pregnancy, it's one of the approach. The dietary reference intake calculator for healthcare professional, this is very useful website, which you can enter everything, every data, all the data of the patient, and you can get what you need during pregnancy and the calorie intake. Weight gain during pregnancy, it's different regarding the pregnant woman, underweight, healthy weight, overweight, and how much she needs to gain during pregnancy. A pregnancy is really an opportunity to return to a healthy lifestyle. Food safety during pregnancy, it's a very vital to have a safety during pregnancy, especially for pregnant women and their unborn babies, because of the immune system change during pregnancy. It has an impact on the woman, so it's very important to prepare food in a proper way. One of the concerns that fish, is fish safe during pregnancy? Yes, fish is safe during pregnancy. Low mercury fish, it's safe in pregnancy, and the best choice is anchovy, butterfish, black sea bass, and the worst choice is the king mackerel, shark, tilefish, and big eye tuna. 4 steps to food safety: clean, wash hands and service often, separate food, meat away from the vegetables, cook food to serve internal temperature, and refrigerate food properly. My recommendation is to design evidence-based educational approach that focus on nutrition across academic clinical programs for all providers in training, emphasizing a multidisciplinary team approach to management. Design evidence-based education intervention focused on nutrition aimed at the public for both consumer, pregnant women, and their family. Utilize technology to disseminate appropriate nutrition education and create connection between scientists, policymakers, and the general population. And also we need more study regarding our community to make our own guideline in the Kingdom of Saudi Arabia. Thank you, and this is my reference.
Thank you, Dr. Najd al-Shamri, for covering pregnancy and nutrition and your recommendations on individualized plans for pregnant women. Our next speaker is Dr. Ali Juratli. He is currently the head of Department of Psychiatry at King Fahd Medical City and a member of the American Board Psychiatry. Dr. Ali will talk about food psychology. Please welcome Dr. Ali Juratli.
This is how it works. Bismillah ar-Rahman ar-Rahim. First of all, I want to thank the organization committee who invited me to this lovely place in Ha'il. I'm very happy to be here. And Dr. Saleh, thank you very much for inviting me also. And I will today try to take you to a journey and talk about the relation between the psychological issues and the brain and food, which is, I think, is very, very important part in psychiatry and in mental health in general. So first, we, as a psychiatrist, this is a basic understanding of the brain, and the brain is the most important part of our life in deciding what to do and how to do things. So basically, we have three brains. The first brain, we call it the old brain. This is the brain we share with lizards and animals, and this is what take care of our basic survival issues like eating and breathing and heart rate, and all of that is in the midbrain. We call it the old brain or the midbrain or the survival brain. The second brain we have is the emotional brain, where our emotion is located in the place inside the brain called the limbic system, which control our emotion and our love and our issues related to how we connect with other people. Of course, the limbic system is much more complicated in women than in men, because woman has to take care of herself and other people. So women's limbic system is always much, much more complicated than men. Then we have the thinking brain, we'll call the neocortex, which is the things that we create. For example, everything in this room are created in some imagination of somebody in this front of the brain called the front of the brain. Basically, the frontal lobe is what we call the babysitter of our brain. So when we have emotion, when we have any feeling, that it is located in the limbic system, and the midbrain is is in the neocortex, is the one that try to control our behavior. So basically, the brain develop from back to the front and from down to up. So basically, we feel fearful before we know why we are fearful, because the brain develop from bottom to the top. So basically, in mental health, in obesity, in anxiety, in depression, everything has to do that we need to use the frontal lobe. So I always tell the patient, you are not using your frontal lobe. If you use your frontal lobe correctly, then you will be able to control all of the aspect of your behavior, because the frontal lobe is the part of the brain that should be used in most patients. So when we talk about food, and what makes this cake very delicious, why we enjoy this cake. So what happened in the brain? When we eat this cake, there is a substance will be secreted in the brain called dopamine. Dopamine secreted in the brain and tell you that, wow, it's feel good. I want more of that. So dopamine's role is to initiate that response of wow. And it's secreted from a place in the brain called the ventral tegmental area, which is located in the midbrain or the survival brain. So this is the brain that make you decide what is good for survival. Like this cake is good for survival, so I need more of it because it will make me survive on the face of the earth. So dopamine secreted from here, and it goes to a place called nucleus accumbens here, and nucleus accumbens is the joyful part of the brain. So the more dopamine we have in your nucleus accumbens, the more happy you are. So when you eat this cake and we say yum, the word yum means I have plenty of dopamine in my nucleus accumbens, and that make me feel great, and I want to do it again. So I want to do it again means my survival brain in the midbrain, where ventral tegmental area is located, telling me that this cake is very important for survival. And you say, so basically, when I have more dopamine here in this nucleus accumbens, I feel great because dopamine has been secreted here, and that's what make me feel that these things are very important for survival. But the problem is located here in the midbrain. The midbrain is unconscious, so basically we don't have control over the midbrain. And that's the challenge in any treating of obesity. Why treating obesity and addiction is very hard? Because when the mistake we make, we talk to the frontal lobe, and the frontal lobe has nothing to do with it. The frontal lobe is the thinking brain. The original of the problem is always related to the midbrain, and the midbrain is basic survival brain, and we don't have control over it most of the time. And the midbrain decide what is good for survival. So what's good for survival is this cake or that piece of thing that increase our dopamine. So the more dopamine increase, the more it's important for survival. And that's why when we being hooked to chocolate and alcohol or cocaine or Captagon, the problem with these substances is they increase dopamine way too much that it fools the brain and make us feel like this is very, very essential for our survival on Earth. So what we need to do is try to control our midbrain, because our midbrain is unconscious and unable to do all of this. Okay, so why we like capsa more than cucumber? We like capsa more than cucumber because a lot more dopamine is secreted when we eat capsa comparing when we eat cucumber. And that's why you never invite somebody to eat a cucumber or to eat tomato with you, because they don't increase dopamine as much as capsa. And that's why we like capsa a lot. We like biryani a lot, because the more dopamine increase, the more it will cause us to feel attached to that one, and the more important it is for the midbrain to decide this capsa is very important for survival. It gives me more reward, it gives me more dopamine, and I am being hooked on it too much at that point. So when we have a substance that increase our dopamine way too much, it will hijack our brain. So our brain will be hijacked, and our brain will always think about it day and night. If you ask any drug abuser, what is your thinking? Their thinking is always where I can find that drug again. They know the drug dealer's place, how they can find that drugs. People with obesity, they think about food 24 hours, 7 days a week. Why? Because it's occupied their memory in the brain. So the memory of the brain will be all related about food and the importance of food and how they kind food. Why? Because that food had increased their dopamine too much, way too much, more than normal, and that caused their midbrain to be hooked on it and caused the midbrain to decide which is important for survival. So when God sent us to us, he put this part of the brain called the nucleus accumbens and the ventral tegmental area, we call it, to survive on Earth. So what increased dopamine usually, normally food, water, sexual activity, nutrition. Nurturing means saying good thing to people. So when you say you have a great job, that will increase your dopamine. That's why you don't need to see anything bad. So فَلْيَقُلْ خَيْرًا أَوْ لِيَصْمُتْ, because when you say good thing to people, it will also increase their dopamine. Music, art, prayer, anything that can increase dopamine, that is normal dopamine increase. Why dopamine is essential? Because our ability of the frontal lobe to function is based on dopamine. So when you are hungry, you cannot do anything because there is no dopamine in your brain. When you don't sleep well, the next morning you feel grouchy and irritable because there is no dopamine in your brain in the morning unless you sleep very good. So sleeping good at night will increase your dopamine in the morning where it's badly needed. Food will increase the dopamine. For example, strawberry will increase dopamine. It will not increase my dopamine, strawberry, but this one will increase my dopamine too much and make me function much better. Marriage and love will increase our dopamine way too much. That's why we would like to do it again and again. Anything that increases dopamine normally. So we call that normal pleasure. This is the normal thing that God gave us to survive on Earth. Without this, we will not be able to live. For example, if you take that nucleus accumbens here, if you take it bring a cat and you take her nucleus accumbens, she will sit in that corner and she will not eat or sleep and she will die in 2 days. Why? Because nucleus accumbens is the part of the brain that tells you unconsciously what to do and how to do it and what is important for survival. So if we don't have dopamine in our frontal lobe, then we are very tired and grouchy. So when you do like severe diet, when you are a drug addict and you stop using that cocaine and you stop using that alcohol and chocolate and food and marijuana that was increasing your dopamine and make your frontal lobe function. Without dopamine, you will be like this. You don't have any motivation, you cannot function, and then the brain will tell you, the midbrain here, ventral tegmental area will tell you here that you are not surviving, go back and use that drugs because we are dying here. Without that food, without that drugs, we are unable to function, and then we go back. We decide that this substance is so important for our survival and we will not be able to function without it and we have to die without it. And Dr. Joseph Ledoux, a long time ago, did this study, and this is a fascinating study. So he said, let's say you are in the jungle and you saw a snake, you immediately jump. Which part of the brain that make you jump? It's not the frontal lobe. It's not this part of the brain, the cortex. No, it's the amygdala. The amygdala is part of the old brain. It will, the role of the amygdala is always to protect you, to make you safe. Amygdala, I call it like your mother. Is the role of the mother is to protect you and take care of you and watch you 24 hours, 7 days a week. So the amygdala is the one, when she saw the snake, the amygdala registered in the amygdala that snake is very dangerous creature. So amygdala will immediately make you activate your parasympathetic nervous system and you jump. Sympathetic nervous system and you jump away. It has connection with the heart and muscle and you jump. Finally, the frontal lobe knows about it and said, good job, amygdala. Because you don't want to take the frontal lobe to take care of you in that situation. The frontal lobe takes time to decide. By the time he will decide something, the snake will bite you and you will be a history. So what happened, this is when you have a snake. The problem with food is when you see this pizza, it's the same amygdala that saved you from that snake, is the same amygdala that said, wow, this pizza is hugely important for survival. And you jump and you eat the pizza without making the frontal lobe knows about it. The frontal lobe comes later. So the frontal lobe will tell you, wow, you did a bad mistake here. But the problem is always with addiction to food, with addiction to drugs, is the always remember this, is not the conscious brain, is the unconscious brain, is the amygdala that decided first. So part of the treatment of any problem with obesity is to make the frontal lobe engage and to make the frontal lobe decide, not the old brain. So God always put balance in things. So we are not a victim of our midbrain. So he said, God put the two parts of the frontal lobe, the anterior cingulate cortex and orbitofrontal cortex, are the two parts of the brain that are important in balancing the amygdala needs. So you said, I want to have that pizza. Wow. Then the frontal lobe said, okay, you can eat part of it, but you cannot eat all of it. And that is the balance between the frontal lobe and the amygdala, what make us survive normally on Earth. The problem with obese patients is their frontal lobe, and the problem same with addiction is their frontal lobe is not able to balance that. So the frontal lobe is weak. And the more you eat, the more obese you are, and the more addicted to things you are, the weaker become the frontal lobe and the stronger is your midbrain, and that will destroy that balance. So always we need to teach the patient how to use the frontal lobe, not the survival brain. So when you see somebody eating heavily and obese heavily, that we need to train him that you are using only the survival brain, which is only should be used when you are in an emergency situation, when you need very basic need, not every need. And you always need to take that balance with you. That guy who is
5 minutes
crazy about, crazy about that food is when he smell the pickles, when he smell the cheese, when he smell that food, his frontal lobe is so weak that he cannot handle the huge increase in dopamine coming from that cheeseburger, so he will not be able to resist that. So the frontal lobe fail when there is a huge reward. And that's, God knows our weakness in this. It's the same for sexual activity. So for example, you are not supposed to be with one lady in one place alone. Why? Because the reward will be great and your frontal lobe will not function, and you will forget about halal and haram and you make a huge mistake. That's why God knows our weakness and He put red line. You should not cross that red line, because once you cross that red line, then you will not be able to handle it. Same thing. I have one time a patient who had bipolar, and bipolar tend to be very obese, and his mother told me that he worked in a pizza place. I said he should not work in a pizza place. Why? Because if you're obese and you work in a pizza place, that means you are exposed to that pizza all the time. I told her to change his job to work in a tire place, because he will be much better in that regard. So always when we see a patient, when we train in psychotherapy, when you see this donut, before you make your limbic system jump and the old brain jump to eat it, just let's engage the frontal lobe and let him wait for 5 seconds. Let him evaluate that importance of that food. Is it going to be, the reward is so huge that it will be outweigh the punishment I will get in my tummy, in my abdomen later on. The problem is when I see a lot of patients post-bariatric surgery, and most of them, not all of them, most of them will move from addiction to food to addiction to other substances. So a lady who never smoked before, she started using shisha 24 hours, 7 days a week. A lot of people tend to use alcohol and drugs after bariatric surgery, because they lost that dopamine increase. They really need that dopamine increase. And food is not available now, so they need that dopamine increase by using drugs to compensate or to replace food with other substances like alcohol and drugs. And that's the problem in that regard, is you need to teach the patient how not to use the drugs and how to rehabilitate the patient before and after bariatric surgery to prevent him from using other substances to gain weight. So what happened is, when you use diet or when you use bariatric surgery, the 6 months after that is very crucial, because this is where relapse happen. All the time the relapse happen in that regard, because the memory of food are located in a place called the hippocampus. This is the hippocampus, and this is our memory part of the brain here. So all the memory are located here. So memory of the food, usually in obese patient, will be occupying that memory. So if you look at the memory of patients who are morbidly obese, all of their memory in the hippocampus is about kapsa and food. And so when you deprive them from that substance, they feel so depressed in the beginning, because the midbrain, the hippocampus keep reminding the frontal lobe. Frontal lobe, we are not functioning very well, because their memory of the food this is regular memory, for example, for obese patient and drug addict patient, the same cocaine patient. This is normal memory, and this is the memory of the food. It's very, very strong memory, and it takes time for that memory to die down. Same thing when you love someone. I have one case of a friend of mine who was in love with a lady, and she dumped him, and he stayed 6 months to 2 years severely depressed, because it takes time to replace or to make this connection in the memory part of the brain. It takes time for that memory part of the brain to die down. It takes 6 months to a year from the grieving, whether it's a lost one or a lost hamburger or a lost kapsa, which was so essential in your memory. That dying of the memory, dying of this receptor, it takes at least 6 months. And this is the 6 months which is very crucial for those patients who had bariatric surgery.
2 minutes, Doctor.
Yeah, I'm almost finished. So this is the problem, is the memory of kapsa is so huge. It's occupied all the brain. Normal memory is so small. It takes time for that kapsa to die down, the memory of that kapsa to die down and subside again and again, because the hippocampus keep reminding the frontal lobe, we are dying without that dopamine which used to come from that food. And at that time, I'm going to the second part probably will not be able to handle it. Just quickly, the role of stress is very, very important, because when we are stressed out, stress will decrease dopamine. So anybody, I'll give you an example, anybody who stops smoking, after he stops smoking, let's say for 6 years, he is not smoking, any stress can make him relapse again. Why? Because the stress will lower dopamine. When you lower dopamine, then you need to go back and smoke again quickly to increase dopamine. So the problem with stress, it will make, thank you. So the problem with the stress,
you have 5 minutes additional from Dr. Saleh.
Thank you, Saleh. Always save me. So thank you very much. So the problem is when you eat capsa, when you smoke, the midbrain will tell you, this is the midbrain here. I want that all the time. The role of the frontal lobe is to supervise the midbrain. The problem with the stress and cortisol level will disturb the frontal lobe, will make the connection in the frontal lobe weak. So the frontal lobe will not be able to control that problem. So most of the patients become addict because the PFC or the frontal lobe become very weak, and the patient will be a victim of his midbrain and he starts smoking again. So stress will make the nucleus accumbens, make it very, very sensitive to food. So when we are stressed out, cortisol will make the nucleus accumbens crave this instead of this. So under stress, and they did study, if you can see it on BBC. BBC did this study, and they said they brought 12 people. 6, they slept very well, and 6 did not sleep at all. And the next morning, they gave each one 30 pounds to go and buy food. And because you don't sleep, when you don't sleep, you increase your cortisol. So it put you like you are in a stressful situation. So the people who slept well, they went to the store and bought all the good food that Dr. Najid talked about, the strawberry and the fish and all of that. The people who did not sleep well, they unconsciously chose the unhealthy food because of that stress. And the problem with that is really here in the orbitofrontal cortex. So this is the part of the brain that make you control your need or urgent need for food. And the orbitofrontal cortex is the part of the brain that grows when you have a good mother. So when you are connected with your mother in childhood, the orbitofrontal cortex mature very well. So most of the patients who are obese, if you ask for childhood history, you will notice that they did not have good bonding with their mother. So the orbitofrontal cortex become weak and unable to control that nucleus accumbens. So the role here in preventing obesity is really having good child-mother relation, because good child-mother relation will make the frontal lobe very well functioning and able to control that limbic system. The problem with why, for example, and this is question always come in the exam. Let's say you have 2 people. One drink alcohol and be fine, drink 1 beer or 2 beer and will never be addicted to it. The other one drink 1 beer or 2 beer and feel nothing, and he has to drink 6 beers just to feel normal. The difference between them is dopamine and serotonin. We say dopamine is the part of the brain that make you want things and want it again and again and again and again. The serotonin is the part or the neurotransmitter that make dopamine stop. So dopamine will make you go. Serotonin will make you stop. So most of these patients who are obese, they have this balance between dopamine and serotonin. So we need to restore that balance. The more dopamine, the more you're going to be addicted. The more serotonin, the less likely to be addicted to that food. The problem with cortisone will decrease serotonin. So cortisone also make you obese in another way by decreasing serotonin, make dopamine unchallenged and make you obese all the time. The problem is when you have a stressful situation and you become obese. Why? We call that emotional eater. So whenever you have stress, I have many of my patients tell me that whenever I have any stress, I unconsciously go to the fridge and start eating quickly because she want to relieve that anger. She want to relieve that emotion. that emotion will be relieved when they eat. So they use food as a way to calm down their painful emotion, and that's what causes them to be very, very stressful. We call that emotional eater. So part of the problem in treating obesity, more than exercise, more than food, more than anything, is two magic words: sleep, and stress, less stress. If you decrease the stress, because when you are stressed out, you compensate by eating or drinking alcohol. So food become your substance that make you less emotional, less painful, and decrease your painful emotion.
1 minute, Doctor, 1 minute.
Yeah, I'm finished always. I think so. Always remember the problem. This is my last slide. Why obesity is so bad for women. And women are very sensitive about obesity. And I usually, when I give antidepressant, because as you know, antidepressant will make you gain weight. And especially if you are a woman, it will make you gain more weight. Antidepressant in general will make you gain weight. And the problem with women is they are looked at by society at their figures. The women are more pragmatic. The women look at the male frontal lobe. She wants the good frontal lobe of the male. She doesn't care. She cares, but not too much about the appearance of the male. She cares more about his frontal lobe, because the frontal lobe is define who you are and how much job you're gonna get and how much money you're gonna get, so she can raise her kids with you. The man care only about the figure of the woman. So gaining weight for a woman will be devastating. That's why women are very sensitive to self-esteem. Self-esteem, if you have, they always come in the exam. One question: what is the most common in eating disorder in all female? Is low self-esteem. When you have low self-esteem, you gain weight. Gain weight will make you have low self-esteem. Thank you very much.
شكرا دكتور علي. Thank you very much دكتور علي جرعتلي for this very interactive topic on food psychology. I hope the audience can really reach Dr. Ali at the end of the session and talk to him and discuss. I hope they are not scared. Some really scary photos have been shown. Thank you, Dr. Ali, again. Our next speaker is Dr. Rihab Khalil Al-Anizi. She will talk about celiac disease. Dr. Rihab is specialized as a senior registrar in family medicine at Riyadh Primary Healthcare First Cluster. In addition, she is a Saudi and Arab board certified in family medicine. She is also a trainer at King Saud Medical City. Please welcome Dr. Rihab Khalil Al-Anizi. She will be talking about celiac disease.
Assalamu alaikum wa rahmatullah. Welcome everyone. It's a great pleasure to be here. Many thanks for organizing committee, especially Dr. Saleh and Dr. Samia, for their kind cooperation. My talk will be about celiac disease. And gratitude for, I would like to attract your attention for Saudi government efforts which are carried out by Ministry of Health. They, for supporting celiac disease patients, they offer great support for them from different aspects. Many also all gluten-free products are provided free without charge. Also, we have many of non-profit organizations in Saudi Arabia, like Celiac Disease Association and Celiac Patient Support Group. They also doing great work for celiac disease patients, so we must thank them. I would like to start with a brief background about celiac disease, just to refresh your information. Celiac disease is an autoimmune disorder that affects primarily small intestine. It's caused by gluten ingestion, especially for genetically susceptible individuals. About the magnitude of the disease, its prevalence, it's range from 0.5 to 2%, with an average about 1% of general population. For clinical presentation, the clinical presentation of celiac disease is highly variable. Most of the time, the patients presented with non-typical or non-classical symptoms like constipation, anemia, hypertransaminase, neurological disorders, or skin manifestation like dermatitis herpetiform. And a few number of patients presented with the typical or classical manifestation of celiac disease like diarrhea, weight loss, and malabsorption. 21% have no symptom, or they are in a subclinical stage. For the diagnosis, the diagnostic process started with clinical suspicion. So whenever you have high index of suspicion about celiac disease, start with a serological test or antibody test. If you found antibody tests are elevated, proceed directly to upper endoscopy. For duodenal biopsy, if the biopsy came positive, start gluten-free diet. It's shown here the most recent diagnostic algorithm from American College of Gastroenterology guideline. It may divide the patient into high probability and low probability. When you have high index of suspicion about celiac disease, you can go straight for the duodenal biopsy with serological tests. If both positive, that's confirm the diagnosis. If both negative, the diagnosis is unlikely. If there is a discrepancy between the biopsy and serological test, you can go for further evaluation, like genotyping, human leukocyte antigen DQ4 or DQ9, or measure other immunoglobulins, or do other workup to rule other differential diagnosis. If you have low probability or low index of suspicion about the disease, here you should start with serological tests, especially tissue transglutaminase IgA, in addition to total IgA. If both positive, proceed to endoscopy for biopsy. If both negative, the diagnosis is unlikely. If you have negative tissue transglutaminase and normal tissue transglutaminase, if you have negative tissue transglutaminase A and low IgE, here you need to do other antibodies like immunoglobulin G against gliadin or endomysium. Because the diagnostic process started with antibodies, I would like to go over that briefly. It's crucial to start with tissue transglutaminase IgA because it has the best performance characteristic. Its sensitivity and specificity listed here, but the drawbacks of this test, it may miss with low total IgA. I mean, it gives you false negative results when you have IgA deficiency. And IgA deficiency, it's commonly associated with celiac disease patients. So what do you think about the biopsy? Do we need to do a biopsy for any patient, for any suspected case with celiac disease, or no? What do you think? Do we need to do biopsy for every patient? What do you think? Actually, there's too much debate about that. In European guideline, it's the biopsy-free diagnosis for children offered by guideline. It's a part of standard care and it's increasingly gaining acceptance. In the British Society of Gastroenterology, skipping of biopsy is an option. In North America, no biopsy-free guideline for children or adults. For treatment, currently lifelong adherence to gluten-free diet is the only available treatment, but the gluten-free diet has some limitation, including issues related to adherence, lifestyle restriction, and cost. As a result, there is a growing interest in and need for non-dietary therapy to manage this condition. We have many of current and emerging therapies for celiac disease. We have different therapies and treatments of celiac disease have been developed and studied based on different mechanisms of actions like degradation of gluten in intestinal lumen, regulation of immune response, modulation of intestinal permeability, induction of immunological tolerance, and most of these therapeutic lines are evaluated with special emphasis on phase 2 and 3 and have promising results. We have also different targets and immune-mediated cascade of celiac disease have been identified in clinical and preclinical trials, like endopeptidase, modulator of enterocyte tight junction, and agents involved in gluten tolerization and immunization. What are the key elements in management of patients with celiac disease? We need, of course, consultation with skilled dietitian, education. We need to educate the patient very well. We need to reinforce the lifelong adherence to gluten-free diet. We need to also to give the patient vitamin and nutrition supplementation because celiac disease patients are at high risk of malnutrition and vitamin deficiency. As I mentioned earlier, access to advocacy group. Also, we need long-term follow-up by multidisciplinary team. Here, the gluten-free grain list. All celiac disease patients, their family, and also their physician must be familiar with that. What about oat? Is the oat safe for celiac disease patient or no? Actually, there is too much debate among different guidelines and study about oat. Some studies say it's safe, some say it's no. But to be in safe side, better to avoid the oat unless it's specifically labeled gluten-free because sometimes oat contaminated with wheat during growing and processing stage of production. However, over the recent decades, the nutritional profile of gluten-free products are questioned. Most of the gluten-free products available in market are low in protein, high in salt, sugar, and fat. So we need adaptable intervention for development and reformulations of the gluten-free products to improve the nutritional profile of them.
5 minutes.
Here we have some of celiac disease recipes. brought it from this website, and also we have many of similar websites in Arabic for those who are interested. What is the role of probiotics in celiac disease? Some strain of probiotics may act on gluten immunogenicity. It assists with intestinal healing and improving the symptoms. But caution is advised because some of probiotics may contaminated with gluten. We have many of modified wheat gluten methods to decrease its immunogenicity, newly discovered by either by microwave, gamma radiation, hydrolyzation with lactobacillus, and fungal protease, gene sequencing alteration, and microbial transglutamination. This is another option being explored. What are the other aspects of management? As I mentioned, we need to give the patient vitamins, nutritional supplementation, because they at risk of malnutrition and vitamin deficiency. We need also to give the patient vitamin D, calcium supplementation, because they are at risk of bone loss or osteoporosis. Pneumococcal vaccine is recommended. Most of celiac disease patients have hyposplenism and they are at risk of pneumococcus infection. You need to address other associated conditions as well, like constipation. Constipation. Celiac disease patients commonly have constipation because of their diet. Also, skin manifestation like dermatitis herpetiform. As I mentioned, it's a genetic disorder, so you need to do screening for first degree relatives, especially siblings, by serological test. For the prevention of celiac disease, does the breastfeeding or timing of gluten introductions alter the risk of celiac disease in children? Actually, either breastfeeding or timing of gluten introductions, either of them alter the risk, have no role in primary prevention of celiac disease. This is according to a well-designed randomized clinical trial. For secondary prevention, the rotavirus vaccine, one study found that infants exposed to celiac disease who received the rotavirus vaccine had lowered the risk of developing the disease following GI infection than those not vaccinated. Thank you.
Thank you, Dr. Rihab, for your presentation on celiac disease. Our next speaker is Dr. Saleh Al-Rajahi. He's a very well-known, he's the mastermind behind this conference. He will be talking about asthma nutrition prevention and treatment. Please welcome Dr. Saleh Al-Rajahi.
Assalamu alaikum wa rahmatullahi wa barakatuh. Sabahkum Allah khair. Good morning, everybody. I will make the asthma talk very quick, and I will make a few announcements if I have time. This is just to get your appetite to go and research different disorders and diseases and find out there is a lot of literature, research, and practices out there that use nutrition and lifestyle interventions to improve these conditions. Anti-asthma foods. I'm using pictures because usually they stick to the mind, and we'll go to Dr. Ali. Maybe someday he'll talk about the influence of photographs and videos on people's minds. And we say always, everything affects everything. Don't ever think that whatever you meet in your life doesn't affect you. Everybody is influenced somehow, either you know it or you don't know it. So we see black seed, very famous in our society, and be happy that to know that al-habba al-soda wa habbat al-baraka is very beneficial. apples, spinach, broccoli, turmeric. Turmeric اللي هو الكركم. Avocado, bananas, rosemary, and ginger. You could grow rosemary in your backyard, by the way. Very important. You know, if you want a healthy heart, you want healthy lungs, you have to eat a lot of fruits and vegetables. Asthma attacks, warning signs. I'm not going to go into that, so you need just go ahead and read it. This is just to show you, the more green you are, the more green your life, the better your lungs will be. Now, believe it or not, maybe Dr. Ali knows this one. They used to be cigarettes. It's called asthma cigarettes. Smoke and your asthma will improve. Well, of course, it's not true, but I think in the United States years ago, they used to sell cigarettes in hospitals on the floors, you know, before it was banned. Now, outline, introduction, dietary patterns, dietary inflammation, diet and risk of asthma, diet and asthma control, etc., etc. A lot of things has been covered, but I'll move very quickly through these so you get your appetite to read more. There will be a chapter in the common book, inshallah ta'ala, about this issue. Now, pathophysiology, I'm gonna skip that. You know, this is the Western diet, Mediterranean diet. Just to bring you to attention, the SAD diet, which is the standard American diet, is one of the worst diets anybody could eat, either you, your children, or your patients. By the way, the Mediterranean diet, الشيخ علي طنطاوي الله يغفر له ويرحمه يقول أفضل أكل موجود في العالم أكل الشام وكلامه صحيح. The old diet pattern that you used to have in our area is the best diet because it has lentils, legumes, whole grains, a lot of fruits and vegetables, and usually seasonal stuff. The literature examines individual nutrients, micronutrients, macronutrients, and how people eat these nutrients. You had enough for diet. I'm going to skip all of these things. Systemic and airway effects of dietary patterns on asthma. The Western diet promotes pro-inflammatory environment and causes an increase in airway inflammation. Fruits and vegetables consumption has systemic anti-inflammatory properties with a decrease of pro-inflammatory cytokines in the plasma. Also associated with lower airway inflammation and a reduction of neutrophils in asthmatics. Now, there is an issue with gut microbiota. So what you eat will affect your microbiota. The bacteria, the viruses, the fungi that live inside your GI tract will have a role also in the immune response to diet in asthma. So metabolites such as short-chain fatty acids, including omega-3s, have immunomodulatory effects that are produced in high amounts after fruits and vegetable intake because these bacteria, viruses, and fungi will actually help you out if you give them their food. The food of the microbiota is the fruits and vegetables and the fiber in your whole grains, so make sure you take those. Western diet doesn't have these things, so this is why there is a lot of disorders that come out of Western diet. Maybe 5 minutes. We're almost done. Chronic inflammation of the airways is a key component of asthma. This is so when you get an asthmatic, don't just give him the inhalers. Don't give him the Symbicort and the Ceratides and the albuterol and that's it. You need to move beyond. You know, you need to go through the lifestyle, sleep cycle. Sleep is very critical. Dr. Ali mentioned it, and many lectures did emphasize sleep, and Dr. Wadha Al-Ataybi also emphasized that. Sleep is a key issue in a lot of things. It does affect your hormones and your circadian rhythm highly. So if the patient doesn't sleep, especially teenagers, then you need to focus on that in addition to other components of lifestyle interventions. High fat intake will make asthma worse. So if the patient eating burgers and pizzas and taking junk food, probably the asthma will be worse. And also make sure they go on an emergency plan and also management plan and prevention plan. And the patient should not just be given the inhalers and go home and I'll see you in 6 months. This doesn't work. Now, I'm not going to get into the microbiota. There will be lectures on this one covering this area, and will be actually a whole conference just covering microbiota, inshallah ta'ala, coming soon. The Mayo Clinic advised their patients maintain a healthy weight, eat plenty of fruits and vegetables, avoid allergy triggering foods, take vitamin D, and avoid sulfites. There was a slide that was shown this morning showing the most common dietary deficiencies in our community. One is protein, second one is calcium, vitamin D, B12, iron, essential fatty acids. This is why a lot of patients just complaining of my hair is falling. That's or I have iron deficiency and I'm not feeling good. We have some here. We have antioxidants, very important. Vitamin E, vitamin C, beta-carotene, flavonoids, selenium, dietary fiber, etc. So done with asthma, just a few announcements here. For those who are intending to take the exam today, the International Board of Lifestyle Medicine, please make sure you register with Ms. Nof Al-Atiq and the group. And also you need to have intensive preparation, and we are planning to help you out for this issue. The second one, for new and young physicians who are interested in training to be speakers, please contact us. Talk also to Ms. Nof Al-Atiq. It's very important to get you trained ahead of time. In addition to this, those interested in writing scientific chapters and also research, please contact me. The other announcement, there will be a trip tonight to Jubba. So if you haven't been to Jubba, please make sure you plan to go. It's a very nice place to see. There is a lot of old ruins, more 10,000 years old, and also it's becoming one of the UNESCO's international protected sites with Shwemis, I think, in الحياة. So if you get a chance to go to الحياة, please do that too. And thank you.
Thank you, Dr. Saleh, for your topic and for the announcement. Our next speaker will be online with us. He's Dr. Faisal Al-Suwaidan. He's a neurology, critical care medicine, and a neurological and neurosurgical critical care consultant. He has a Master of Science in e-health management. And he's the Vice President of the Saudi Neurology Society, as well as a clinical assistant professor at Princess Noura bint Abdurrahman University in Riyadh. He's the head of a neurology division at Security Forces Hospital in Riyadh as a neurology clinical lead at Ministry of Health. Please welcome Dr. Faisal Al-Suwaidan, and he will be talking about food and neurocognition.
السلام عليكم جميعا.
عليكم السلام.
الصوت واضح؟
واضح الصوت. تفضل دكتور.
شكرا جزيلا. الحقيقة أنا أعتذر عن عدم استطاعتي إني أكون موجود معكم في هذا المحفل العلمي المميز، وكنت أحاول أبدل وقت المحاضرة لسبب بسيط، إنه من الصعب الحقيقة إن أحد يقدم محاضرة بعد الدكتور صالح الراجحي ويكسب إعجاب المتابعين. فلما انتبهت الجدول لقيت إنه حكون بعد الدكتور صالح، كنت أحاول أقدم في يوم مختلف وفي وقت مختلف، لكن فشلت المحاولة. فأنا سعيد أن أكون معكم اليوم بصورة افتراضية، وكذلك أشكر اللجنة المنظمة على دعوتي للمشاركة معكم في هذا اللقاء المهم، واللي حقيقة فتح لي أبواب جديدة للبحث العلمي في مجال أثر الغذاء على الجهاز العصبي، سواء الجهاز العصبي المركزي أو ما حنتكلم عنه اليوم اللي هو النيوروكوجنيتيف بار، أو حتى الجهاز العصبي الطرفي، بما فيه ذلك الأعصاب الطرفية والعضلات كمحور ثاني. سبقني الدكتور علي جرعتلي وتكلم عن الجانب النفسي، ولا ينفك الجانب النفسي ارتباطا بالجانب العصبي، يكادون يكونون وجهين لعملة واحدة. I'll continue in English in this presentation. I have nothing to disclose in this presentation, and I'm probably I'll do my best to explain to the audience, and probably that the thing I learned from searching this topic, how can food makes us smarter?
Dr. Faisal,
And if we
hear
can,
me? Dr. Faisal,
yes,
sorry, can you open the video?
you cannot see the video.
No, if you can open the video. Camera or the video. Just start the video down at the left.
Okay, can you see me now?
Yes.
Okay.
So
in this presentation, I'm going to try to solve the mystery of being smarter only by changing our diet. And we will try to find out what is the magic recipe that will make us smarter, probably will make our children smarter, because we have to start early on from childhood, if not during the pregnancy period, to make or maybe to use the food of the mother and the early nutrition of the baby as a tool to make our future generation smarter and brighter. So when we talk about food impact on the brain, we have 6 domains, and it's going to be from the early beginning of development, so that we will try to understand the effect of food on brain development since the intrauterine life. And then we'll move toward the neurotransmitter mechanism that will explain many of the cognitive component and the psychiatric component. And then we'll try to figure out how food can consolidate our memories by building protein or preventing degradation of protein, which we know is highly linked to the maintenance of memory. As we know, our memories are basically microproteins built in the nervous system and networking that keep our memories. And they will try to understand the effect of food on the chronic inflammation. And that is important because, as you've probably observed in the few slides presented early on, that many component has an anti-inflammatory effect, an antioxidant effect that can prevent chronic inflammation. And we know that many of the neurodegenerative diseases are basically having an underlying inflammatory pathology, chronic inflammatory pathology, that end up with neurodegeneration. And we will talk about something that came lately in the last probably decade, which is the neuroplasticity and the effect of the nervous system to regenerate or probably to reconnect again and build new skills even after full development of the nervous system. And the neuroplasticity is basically is a way of self-defense in the nervous system, and it also probably has good evidence in the psychiatric specialty, especially in schizophrenia. We have some evidence to talk about in this presentation. So let's start with the mother. Let's start from the early pregnancy. And the mother diet has an important component of the development of the baby's brain. And this kind of development continues up to the age of 2 years. And one of the most valuable nutritional component is the mother's milk, especially the early component, which is the colostrum of the milk, which has the highest level of gangliosides, which is important for the cell recognition, adhesion, and mobility and growth, and the development of neuroaxis during intrauterine life and myelination later on. Then we move toward the vitamins and the antioxidant. Many of those were covered in the earlier presentation. I'll probably focus on vitamin B as one of the most important vitamins for the brain. And not to forget that iron is important also for myelination and neurotransmitter for the nervous system. And also the zinc as well. It has more or less myelination impact and also help in the synaptic properties of the nervous system. And again, one of the most important things that we're lucky to have in Saudi Arabia is screening for hypothyroidism in babies. And we know that iodine deficiency can contribute to the mother's hypothyroidism, and that can affect the nervous system development in babies. When we talk about the neurotransmitters, we know that neurotransmitters are basically molecules that are driven from the amino acids and we need to have those amino acids, basic amino acids, to develop, for instance, serotonin or norepinephrine or dopamine. And we know those kind of neurotransmitters that has an impact on our mood stability, our energy, such as dopamine, and also our motivation. More or less of those neurotransmitters are related to psychiatric diseases, and we use some medication to treat patients who have deficiencies or impairment of those pathways. Good news for people who love to drink coffee or green tea. This could be a beneficial component in your daily diet. For instance, coffee has a benzodiazepine-like effect. It ameliorates pain, gives some energy, especially if you take it in the proper range. And also the green tea has a L-theanine that has properties that is kind of an anxiolytic and decreasing panic and depression symptoms. So if you have those items in your daily menu, I would advise you to keep it in proper dosage. When we talk about neurocognition in neurology, what matters in neurology, or probably the edge, is our memory. We know that many of our, I would say, the average length of life, or the estimated length of life in Saudi Arabia, the age will increase with time, and we probably will soon have in the next decade many people with age above 75, and that is expected with the development of the healthcare system, awareness, quality of life. And based on that, we want to keep those patients not only physically healthy, but also mentally healthy, especially in the memory part. So we have to figure out a way to make sure those patients does not have chronic vitamin D deficiencies, which were probably presented early on. They have good intake of vitamin E, and they have good intake or access to different vitamin B component, especially if they have high risk of hyperhomocystinemia, which is related to a stroke. And usually those vitamins come from natural sources, and we have to make sure that they have access to it every year in their life. And it maybe we need to replace them and correct them if they're deficient. I would like to highlight one of the probably well-researched diet, which is the Japanese diet of Okinawa diet, which is basically eating habit with the part of Japan. And it is more or less based on not having a lot of food. So they try to avoid eating till they have full satiety. So they're trying to decrease the intake, and they only eat when they're hungry. And I see there's probably something we have inherited from the, Prophet Muhammad advises not to eat a lot, and we eat only when we need, and not to be, always full. This advice has come from Islamic culture, and I think it's valid. And we have to look into our eating habit, and not to take all what we can take or eat, I would say what restaurants usually tend to offer, which is open buffet. Let's go to the proteins now. And the proteins is basically the micromolecules made from the amino acid and basically recognized or stored in the brain, developing our skills and memories. So in the microproteins, we have an issue if we have misfolding or inappropriately developed microproteins inside the cells of the brain, and that will lead to dysfunction of certain networking. For instance, if we have those misfolded protein within the cells of the movement network, we'll end up having Parkinson's disease. If we have them in the area of the frontotemporal area, we'll have psychiatric symptoms like frontotemporal dementia, or probably we'll have Huntington's disease, which has component of psychiatric symptoms and movement disorder. And basically, according to the location of the protein, that is misfolded protein, development in the nervous system axis will have different symptomatology. And it's advised to have high quality source of protein in our diet. And it was proven that if we have fresh sources of good protein, we'll less likely have mental illnesses when we grow up. Chronic inflammation, and concurrent was presented and talked about. It has an anti-inflammatory component, and it's something cheap available in the market. We can add it to many of our daily diet, and it has a good flavor, and it turned to be something good to avoid or probably fight against apoptotic changes in the brain, and maybe something to have future research for treatment of Alzheimer, or prevention maybe, because we need to prevent neurodegenerative disease before it happens. We know most of the medication we have now for cognitive disorder are working only to slow down the disease, but I think the future will be something that work in the prevention of the disease itself. When we talk about neuroplasticity, I would like to highlight two components: the carotenoid-rich fruits and vegetables, and the probiotic. And both of them have shown they increase the concentration of brain-driven neurotrophic factor, BDNF, which is kind of associated to the hippocampal neurogenesis. And the hippocampus is the area where we keep most of the memories and emotions. And if we have a way to repair the hippocampus, more probably it's going to be adding carotenoid-rich fruit and vegetables and probiotic. Why the hippocampus is vulnerable? The hippocampi basically are the thinnest structure in the brain, the cortex. It has only 3 layers of neurons, while if you study histologically other parts of the brain, you have 6 layers. So if we have only 3 layers and they're prone to have damage toward hypoxia, hypercapnia, toxins. They are also prone to have pathology when you have head injury, traumatic head injury, and accident. They're prone to have diffuse axonal injury. So those are a vulnerable area in the brain, basically from anatomical, histopathological point of view. And we found that they can be, repaired by taking components such as carotenoid and probiotic in our daily diet. Don't forget trace element. We have probably talked about zinc and selenium. We probably have to check in LW, calcium and magnesium, and they are also important for neurotransmitters, and they help in the homeostasis of the body and the brain. I will just add to the Dr. Saleh Rajhi recommendation to the Mediterranean diet. Somebody figured out some kind of a diet called the MIND diet. So it's basically the Mediterranean diet plus the DASH diet. And they worked it out in research, and they figured out this is the best kind of MIND diet. It's the DASH is basically dietary approach to stop hypertension, which is low sodium diet with a lot of vegetables and whole grains, and also fish. While the well-known famous Mediterranean diet, which we probably most of us are familiar in, and many cousins in Saudi Arabia, has more of again olive oil, fruits, and plants, and less intake of red meat. I would love to emphasize that most of our probably red meal is basically processed red meal, and it comes from factories and probably frozen. And we have to guarantee good access of meat in our daily meals. Keep this slide in mind. I think the future is going to be the understanding of the relation between the brain and the gut. And I think we can prevent many diseases in the future by early intervention through recognizing what can help our brain develop better through choosing what we eat. And we know for sure that the brain affects our gut. Such for many cases, for instance, is the irritable bowel syndrome, which is we know that is related to the central nervous system, and it has many symptomatologies. Basically, also kind of our psychiatric presentation from the GI point of view. And again, the future probably is going to bring to us new specialties. There are promising specialty that is called nutritional psychiatry. Probably have from the presentation you saw from Dr. Ali Jaratli ahead of my presentation, we are able to connect many diseases of the brain, either psychological diseases or cognitive diseases, by what we eat every day. And with this slide, I would love to conclude, and thank you very much for your invitation.
Thank you very much, Dr. Faisal, for your informative talk. Our last but not least speaker for this session is Dr. Abdullah Tahini. Dr. Abdullah Tahini is a consultant psychiatry. He works at the Irada Complex for Mental Health in Hail as a medical director. And he is also the service line of mental health in حائل cluster and the health holding company, and he is a member of multiple medical and legal committees in حائل health sector. Dr. Abdullah الطحيني, he will be covering sleeping hygiene as a lifestyle. Please welcome Dr. Abdullah.
السلام عليكم. صباح الخير جميعا. I am happy today to participate in this great conference with all of these big names. Today I'm going to talk about sleep hygiene.
استاذنكم بس دقيقة إن بس نحمل المحاضرة على البروجيكتور. سنبدأ الآن إن شاء الله تعالى.
It's okay? Yeah. Today we are going to talk about sleep hygiene as a lifestyle. When we are talking about sleep, we are talking about the third of our life. We are talking about the big part of our life. Healthy sleeping is must be priority. We are going to talk about healthy sleeping. When we sleep, we cycle through a series of sleep stage, non-REM stage and REM stage. We can see the four stage of sleeping. REM sleeping and delta sleeping are the deepest part of our sleeping. Successfully cycling through all of these sleep stage multiple times each night allows us to perform our sleeping in a good way and will give its critical function of restoring our body and mind. Sleeping enough time for each night and each stage allow you to get good sleeping. The National Sleep Foundation recommends that most adults get between 7 and 9 hours each night. And this is the total normal normal periods of sleeping. We are, as a physician, the easiest way when we face any patient suffering from sleeping problem is to diagnose or to diagnose the patient in each or any disorder or labeling. And this is mostly the common practice, but it's not the right way to deal with sleep problems. Healthy sleeping must be continuous or uninterrupted. Evidence suggests getting continuous sleeping serves critical roles in the support of our brain and body functioning, and that continuous sleep is at least as important as sleep duration. يعني quality and quantity. This is the equation. How to know if we have good sleeping or not? Good sleeping, we can wake up refreshed, with good mood, a lot of energy, feeling clear-headed. This is the normal sleeping, or indicators of normal sleeping. طبعا sleep problems, about 70 million people in USA suffer from sleep disorders. There are approximately 80 different types of sleep disorder. Most sleep disorders are secondary in the term of etiology. And as you see here, the multiple etiology may be physical, medical, psychiatric, environmental, working at the night shift, genetics as narcolepsy, medication, and aging. And in the aging is due to aging process, medical comorbidity, medications, and stressor. طبعا sleeping in general, Maslow hierarchy of human needs, هو حط sleep في البيز of hierarchy. طبعا حط له أسبقية على السيفتي، على اللاف، الإنجاز، على كل حاجة. طبعا هي الفيزيكال نيدز، السليبنج، الإيتينج والحاجات هذه. طبعا we have different nature of sleep disturbance. One patient have difficulty to fall asleep in the beginning of sleeping, and another one has interrupted sleeping, waking up early. طبعا لما نتكلم عن waking up early احنا نتكلم يعني mostly على ناس عندهم على سبيل المثال severe depression. حتى في أغلب الدراسات لما نتكلم عن الناس اللي حصل لهم suicidal commit، نحصل إنه one of the indicator إذا المريض wake up early. وأغلب حوادث suicidal commit تحصل في الصباح الباكر. طبعا في بعض disturbance تكون stage related، بعضها تختص في الكوانتيتي، الكواليتي، الانفايرمنتال. طبعا لما تجي الطبيب والله يا دكتور انا ماني قادر انام لي اسبوع، والطبيب على طول انسومنيا، بنزوديازابين او زد دراج، لكن تحصلوا والله في حفارات بجنبه بالبيت مزعجته لها اسبوع وهي اللي خلته ما ينام. فلازم يعني نوسع النطاق اكثر، يعني not labeling البيشنت very easy، ناخذ السيتويشن بشكل كامل كأطباء. طبعا sleep hygiene, many people with sleeping problem have a problem in sleep hygiene. Therefore, the sleeping hygiene is the first line treatment of many disorders and should be as a lifestyle and habit. طبعا أغلب model of care now is concentrating on society more than the patient themselves. يعني فدائما لما نحصل pathways في كل الأمراض سواء chronic diseases أو غيرها، المستهدف الأول السوسايتي. طبعا المؤتمر هذا مؤتمر طب نمط الحياة، هذا من الحاجات الداعمة عنصر السوسايتي في الباثويز. طبعا عشان الوقت بس ندخل على طول في التيبس اوف سليب هايجين. we should have fixed wake up time regardless weekend or weekdays. Try to wake up at the same time each day. طبعا حتى بعض الريكومنديشن تقول حتى لو تأخرت في النوم لازم تقوم بنفس الوقت، لازم تقوم بنفس الوقت. عود نفسك على أنه يكون لك جدول ثابت في النوم. طبعا sleeping دائما هو الضحية. أنا عندي شغل ما خلصته، ضحيتي هو النوم. أنا عندي والله مناسبة ما انتهت، لا تأخذ من وقت النوم. We must give the sleeping the priority. النوم لازم يكون خط أحمر ما نتعداه، يعني الساعة 10 النوم، الساعة 10 الساعة 10 أيا كان، كل حاجة تتأجل، ولكن دائما هو ضحيتنا. طبعا الادجستمنت make gradual adjustment. طبعا يعني دوبنا طالعين من عيد الفطر، فدائما تكون المشكلة أنا كيف أعدل نومي، أنا والله يا دكتور عندي مشكلة أنا فأغلب الناس يبغون يعدلون النوم يعني بيوم واحد بيومين، لا، لازم يكون في gradual adjustment، يعني نص ساعة ساعة كل يوم إلى أن يتعدل الوضع. Don't overdo it with naps. يعني لازم دائما الريكومنديشن recommend to be limited time، وما تتعدى بالكثير يعني نص ساعة. طبعا keep your routine consistent, following the same steps each night, including things like putting on your sleep clothes and brushing your teeth, can reinforce in your mind that it's the bedtime. طبعا هذه التجربة إذا مرت عليكم هي البافلوف اكسبيرمنت. طبعا في البداية لما نجيب الجرس للكلب، يعني الله يعزكم ما في أي لعاب يخرج منه. بعد كذا لما يجيبون الأكل فربطوا كل ما يجيبون الأكل للكلب يضربون الجرس. فالكلب يعني يفرز اللعاب بشكل كبير. في أحد الأيام ضربوا الجرس بدون الأكل، فالكلب خرج اللعاب. فوش نستفيد من التجربة هذه؟ إنه هذه التجربة في الكلاسيكال كونديشنينج هي أساس يعني ضليع في التربية، وأساس ضليع في تعويد الشخص والبيهيفيرال موديفيكيشن. يعني لما نربط بعض التصرفات أو السلوكيات في وقت النوم، خلاص هو تلقائيا in your brain خلاص هذا وقت النوم. يعني فمثلا ملابس معينة، brushing your teeth، هذه كلها behaviors لازم تكون مرتبطة في النوم عشان نعرف إنه خلاص it's bedtime.
5 minutes.
طبعا لازم يكون فيه dim light, unplug from any electronics, budget 30 minutes for winding down, as listening Quran, soft music, light stretching, reading, or relaxation exercise. The method of relaxation, يعني instead of making falling asleep is is the main goal, it's often easier to focus on relaxation, meditation, mindfulness, based breathing, and other relaxation techniques. Can put you in the right mindest for bed. يعني دائما لما ندخل الغرفة التحدي دائما أنا متى أنام أنا متى أنام. لا نركز على المسائل هذه أكثر من إنه to fall asleep. طبعا don't toss and turn. طبعا 20 minutes. يعني إذا ما نمت خلال 20 دقيقة لا تحاول تتحدى نفسك وتتقلب وتجلس وتعيد وتزيد في الغرفة لأنه حنا نبي نعزز اللينك between البيد and sleeping. الجلوس الكثير والتحدي هذا يضعف اللينك. فممكن نطلع ناخذ حاجة مثلا دافية دش دافي reading any activity. طبعا get daily light exposure, be physically active during daytime, don't smoke, cut down on caffeine in the afternoon and evening. يعني بالكثير يعني الساعة 5-6 المساء خلاص ما في كافيين. وإحنا ما نقدر نقول مثلا على الكافيين وسموكينج إنه to stop ولكن to limit الحاجات هذه. Don't dine late, restrict in bed activity. ونعيد للمرة الثانية إنه الشيء هذا عشان نعزز اللينك between and sleeping. طبعا the only exception is the sex. Optimize your bedroom. Have a comfortable sheet, blanket, mattress and pillow. Set comfortable temperature. طبعا في ناس التمبرتشر اللي يرتاحون فيها الأقرب للحرارة والناس البرودة. فما نقدر نعطي يعني مثلا درجة معينة أو recommendation معين. هي تختلف بناء على الأشخاص individual based. Block out light, drown out noise. Try calming scent like lavender. This is the summary of all of these tips of sleep hygiene, and these are my references. And thank you.
Thank you very much, Dr. Abdullah Tahini. We have finished well on time. We would like to thank all our speakers for this session and all the audience also for your attention. For the inshallah the certificates and تكريم بالنسبة للسبيكرز إن شاء الله راح يكون مع السيشن الثاني. We will have a break in a few minutes for 10 minutes break and then we will come back for our next session إن شاء الله تعالى. دكتور صالح has an announcement.
السلام عليكم. فريق مكة المكرمة، الزملاء من مكة المكرمة والزميلات، الاجتماع معكم اليوم اللي يستطيع على الغداء إن شاء الله تعالى. المناطق الأخرى اللي يرغبون في الاجتماع للتخطيط للأنشطة في المنطقة اللي جايين منها كلموني ونحدد إن شاء الله وقت لقاء. يفضل اليوم وبكرة في المساء أو بكرة على أبعد تقدير إن شاء الله تعالى. شكرا لكم.
It's now time for questions from the audience. If there are any questions, please give the mic. You can always also feel free to approach during break time or any time during the conference to our speakers and talk to them, approach them directly. You are most welcome. Please.
يعطيكم ألف عافية يا رب. أنا عمار تونكل طبيب بمارس تقريبا طب نمط الحياة for the past 3 years solely واللي في I really enjoyed Dr. Ali lecture regarding the reward system and I can confirm that it really works and it's really have wonderful benefit since I started tackling the neurotransmitter dopamine, serotonin, endorphin, adrenaline in changing behavior, especially eating behavior and a lot of things happens and a lot of changes happens after we tackle these neurotransmitters. My question to Dr. Ali, I've been reading a lot about the reward deficiency syndrome and the prevalence of that, and like 30% of the population have the genetic predisposition for the reward deficiency syndrome and the dopamine resistant and its influence on certain behaviors that can lead to obesity or chronic diseases. So what's your advice regarding if I find the patient that has all the elements of a reward deficiency or dopamine resistant? Is there certain advices for these population in order to reach an optimal goal? Thank you very much.
Okay, thank you for your question. Please, Dr. Ali.
شكرا كثير. Very good question. ما شاء الله عليك. أخي الغالي, the most important things you mentioned that in reward deficiency that some people might have genetic predisposure where the dopamine tone is low because of many reasons. But that's not a way to give up. So what we can do in this situation is like somebody who had at risk of heart disease. So what we do with them, we tell them to exercise and eat. Somebody with low reward system, what is the enemy of reward? The enemy of reward is stress, one, sleep is the second one, like Dr. Tahini mentioned, stress and sleep, and then how to make your reward system function better. So for example, when you eat, the brain reward you by secreting dopamine. When you have good relation with your wife, then the brain reward you with giving you dopamine. So things is in your hand is to have good relation with people. People who make you have low dopamine, like people who put you down, ignore them. People who make you mad, sad, ignore them. Just delete them from your life and concentrate on people who make you nurture. Nurturing is very important to increase your reward system. What else can we do? Food, some food is full of dopamine, like for example, I think myself, fool is very good for dopamine. Fool and hummus are great for dopamine, for example. Yes, for example, almond, like when I put patient on SSRI tend to lower your dopamine. So I put the patient on a diet full of dopamine, like we said, fool and almond and protein that is full of dopamine because they have low dopamine. So food, exercise, sunlight, nurturing environment. Nurturing, as we said, that people who will make you feel better and make you grow. What else? Anything that increase your dopamine naturally. Most of these patients, unfortunately, they tend to use drugs. So for example, why two people use marijuana, one becomes severely addicted, one we don't, because they have low dopamine to begin with in the nucleus accumbens, and those patients are at high risk of addiction. So when I see patients at high risk of addiction, they need to prevent them, need to teach them how to get out of the drugs. The other important things, and this is what we face in Western society and now here, is the childhood. So we said the part of the brain that adjusts your emotion is this part of the brain above your eyes here, called the orbitofrontal cortex. This is, orbito means above the eyes directly. So this is the part of the brain that make you make the right decision, make you less impulsive, make you less able or less capable of using drugs. This is the one that control your limbic system and midbrain. And that part of the brain, as we mentioned, mature when you have good relation with your parents. So and I see a lot of women, they ignore their kids or they don't have time for their children. And the problem is this part of the brain, if you don't get bonding with your mother by age 2, you will never get bonding again. So this is what, if you look at most of the patients who are addicted to food or drugs, you'll always see some problem in the bonding process in these 2 years of life. And you see some abuse as a child. So this is one of the things we can prevent a patient from being...
Thank you, Dr.
So I think there's a lot in the future, and Dr. Salih and I will make a program about that, inshallah.
Yeah, thank you very much. Well said, Dr. Ali. So always stay positive, associate yourself with positive people and well-minded. Thank you. We will take one more questions before we go for a break, 10 minutes. If there is any question from the audience. Okay, let's take from the table here.
السلام عليكم جميعا. يعطيكم العافية. Very well presented lecture since this morning. سؤالي للدكتور صالح الغامدي. You have been presented very well the relationship between the epigenetic and the nutrition, but you have said like the nutrition affect the epigenetic. Is there like it can be like the other way around, like the genetic can affect the nutrition? Like for example, like the baby born who likes the sugar more than the other. And I'm not talking about the taste, but through the during the pregnancy.
Yeah, it's clear. Thank you for your question. Please, Dr. Saleh.
يعطيك العافية. Very interesting question. As I mentioned, the interaction actually is interaction more than the causality is in both ways. The epigenetic will affect the diet, the nutrition, and the nutrition will affect the epigenetic makeup. And as I stated in one of the slides, you can see that the nutrition have a major effect in many of activities inside the nucleus. Plus, once we have some epigenetics will end up by some psychological output and will affect the diet too. So the effect is in both ways.
Thank you, Dr. Saleh. And this concludes our first session for this morning. Now we thank you for your attention. Now we will have a break for 10 minutes and we will be back for our second session. Thank you very much.
enterologist and inflammatory bowel disease consultant at King Fahd Medical City. He will be online with us to present inflammatory bowel disease. So welcome with me, Dr. Bashar Ibrahim.
Assalamu alaikum. Voice is clear? Assalamu alaikum jami'an. It is a great pleasure to be joining you today. I was supposed to be with you in person to join this great conference in the lovely city of Hail. However, I got a COVID infection a few days after the WHO announced the end of the pandemic. So I was unlucky this week, and the organizer was kind enough to allow me to present this lecture online. Can I get a confirmation? Do you get the voice or not?
Yes, doctor, your voice is very clear. Thank you.
Okay, great. Okay, so I named this lecture the role of lifestyle as a spark and the fuel of the disease, because the lifestyle has a play role in both sides in inflammatory bowel disease. So let's start with the disclosure. I have no disclosure for this lecture, and the outline of this talk will be we'll talk about the definition, diagnosis, and epidemiology of inflammatory bowel disease. We'll talk about overview of the medical treatment, and then we'll spend most of this lecture speaking about lifestyle as a trigger and the treatment of inflammatory bowel disease. So what's inflammatory bowel disease? According to the WHO definition, inflammatory bowel disease is a term of two conditions: Crohn's disease and ulcerative colitis. These are characterized by chronic autoimmune inflammation of the gastrointestinal tract. The prolonged inflammation resulted in damage of the GI tract. The inflammatory process is not limited to the gut, and there are many extraintestinal manifestations. Most commonly affected organ are skin, joints, and eyes. So it's a relatively new disease, whether this is related to our ability to diagnose them or to the change in lifestyle. So the first description of the ulcerative colitis was probably in the late 18th century, while Crohn's disease has more recent description of the mid 19th century. And we start using the immunosuppressive medication and the treatment of this disease in about 1960. And interestingly, in Saudi Arabia, these diseases are almost never heard of before the year 1990. So what's ulcerative colitis? Ulcerative colitis is a chronic inflammatory condition that causes continuous mucosal inflammation of the colon. It affects the rectum in a variable extent of the colon in a continuous fashion. So always started with the rectum and go proximal. It is characterized by relapsing and remitting course. Crohn's disease, on the other hand, is a transmural inflammation. So it affects the whole thickness of the bowel, not the mucosal layer only. And it's characterized by a skip lesion involving segment. It has the skip lesion, meaning segment of normal appearing bowel interrupted by diseased area. The transmural inflammation of Crohn's disease lead to fibrosis, stricture, and obstruction, which is the complication of Crohn's disease. The transmural inflammation also resulted in a sinus tract formation, and this gives rise to microperforation and fistula formation. And fistula is an opening between two lumen, or between bowel lumen and the skin. The most common involved area is the ileum and the proximal colon. However, any part of the GI tract can be affected, from the mouth to the anus. We'll talk about epidemiology for both Crohn's and UC. It has a bimodal distribution of age. So the first peak is usually at young age, between 15 to 30 years. The second peak is a little bit older or mid-age, around 50 to 70 years. There is no sex predominance, so male and female are almost equally affected. However, there is slight female predominance for Crohn's disease. About 5 to 10% of the disease of the affected person has a family history of IBD. So no big genetic predisposition for the disease. However, there are some genes are linked to the disease development, and we'll talk about them later. The highest incidence of the disease are reported in the Northern Europe, Canada, Australia, and the US. The rate is maximum reaching about 30 per 100,000 person of the incidence per year. Similar distributions for UC, but probably UC is more common than Crohn's. About 3 million people live with IBD in the US, and the incidence in Saudi Arabia is about 3 per 100,000 per year. So less than the incidence. Still, we are less than the incidence in Northern Europe and US. However, this incidence is growing rapidly. So this incidence is based on slightly older study. I believe that if we do the study nowadays, we will get a way higher incidence. So I think we are approaching the incidence of the Northern Europe and the North America. The clinical presentation, common clinical presentations with diarrhea, with or without blood, mucus discharge, urgency, tenesmus, and nocturnal bowel motion, abdominal pain, and obstructive symptoms, especially for Crohn's disease, fatigue, fever, and weight loss, and there's some extraintestinal manifestation like joints, the pain and swelling, skin, eyes, involvement, and liver involvement with jaundice, as this disease predisposes to primary sclerosis and cholangitis. Perianal symptoms are common, including abscess, fistula, pain, and itching. There are no single investigation to diagnose IBD. It's a combination of the clinical judgment and the diagnostic clue. So, but the most common investigation of blood work include that showed anemia, leukocytosis, high CRP, abnormal liver enzyme, low albumin, and other nutritional markers, including iron, B12, and electrolyte. And also celiac profile is important because there are a common association between IBD and celiac. Fecal calprotectin usually high and help to differentiate IBD from IBS in the primary care setting. Imaging including ultrasound, CT scan, and MR enterography, and of course endoscopy is the gold standard. These are on the left side. You can see the endoscopic view of patient with ulcerative colitis, and we commonly use Mayo score or UCEIS score to quantify the severity of the disease. The treatment outline, and I wouldn't go into details of the medical treatment. I would focus on lifestyle. So it's important for the patient to understand that these are chronic diseases, so similar to diabetes and hypertension that require lifelong treatment and follow-up. The first goal of the treatment is to induce remission. The second goal is to maintain remission clinically, biochemically, and endoscopically. And the third goal is to prevent disability, surgery, and colon cancer as a long-term sequelae of the disease. It is important to ensure that your patient have a good understanding of the disease and the mechanism to adjust his life accordingly. Family and social support are crucial for the patient. And the estimated life, I always explain this to the patient who's panicking with the diagnosis of IBD, that the estimated life expectancy of IBD patient is comparable to the normal population, as long as their disease is in a good control. The pharmacological treatment, the oldest treatment is 5-ASA, 5-aminosalicylate acid. It's a compound similar to aspirin. It's the safest medication, and it's the only medication that is not considered immunosuppressant. Steroid can be used to induce remission, but not as a maintenance due to its wide variety of side effects. Immunomodulators like azathioprine, 6-MB, and methotrexate are used to maintain remission. And newly we have the biologic agents, the anti-TNF, anti-IL-12/23, and anti-integrin, and the newer family of medication joining our armamentarium is the non-biologic small molecule JAK inhibitor and S1B modulators.
5 minutes, Doctor.
Sure. So what's called IBD? So as I mentioned, there is a small percentage of genetic predisposition, probably the most acceptable, the most known gene associated with IBD is the NOD2 mutation. However, only 5 to 10% of the patients with IBD carry this gene mutation. So there are many other lifestyle factor linked to IBD, including the exposure of antibiotic, smoking, exposure to bits, which is protective actually. The sunlight exposure and vitamin D is protective, and anxiety and depression seems to play a role in the development of disease. And breastfeeding is beneficial, and the most strongly associated is the ultra processed food, and we'll come into this in details. So why IBD developed? The most acceptable theory of development of IBD is the hygiene theory, or hygiene hypothesis. So the hygiene hypothesis, in summary, is that indicate that if you don't get exposed to certain pathogen as a child, if you grow in a very clean environment, when this will trigger your immune system to act up abnormally when you get exposed to this pathogen when you grow up. So growing up in a very clean environment is actually a risk factor for developing IBD. So let the children play in the dirt. That's what my mentor used to say. So the other factors that can affect the development of IBD is the breastfeeding, which seems to be protective against IBD versus the bottle feeding. Genetic factors we mentioned, and exposure to antibiotic, environmental and air pollution, and diet. And these can cause IBD through a change in the gut microbiota and dysbiosis. This figure show you that the incidence and prevalence of IBD development, and that show you clearly that the IBD development goes hand to hand with the Western lifestyle. So up to the mid-19th century, the IBD is considered a North American and North European disease. However, now with the westernized lifestyle, we're seeing a growing number in the third world countries, in the Middle East, in India, and in China. And we are expecting to reach the incidence in the Western world soon because of the urban lifestyle. Pure study is one of the nicest study done on the exposure and the lifestyle effect and the food on development of IBD. So it's a prospective study of a large number of patients, around 100,000 patients, more than 100,000 patients between age of 30 and 70, from 21 countries and 7 geographic regions. And the participants were followed up for about 3 years, and the main clinical outcome was the development of IBD, including Crohn's disease, ulcerative colitis, and then they looked at different exposure risk factors. And they will go in summary over this because of the time. So in summary, what they found in this study that consuming more than 5 servings per day of ultra-processed food increase your risk of developing Crohn's disease by about 5 times. Also, an association was found with ulcerative colitis less obvious than Crohn's disease, about 1.5 time risk of developing ulcerative colitis if you consume more than 5 servings per day compared to less than 1 serving per day of ultra-processed food. And when they looked at the types of processed food, actually the hazard persists despite in all type of ultra processed food. So these include meats, processed meat, soft drinks, sweets, salt, snacks. So all kind of ultra processed food increase your risk of developing IBD.
1 minute, doctor.
Yes.
1 minute.
Okay. Also, this study looked at the association with the antibiotic exposure, hormonal therapy, oral contraceptive, and long-term non-steroidal anti-inflammatory drug. And all of these was found to be a risk factor for developing IBD. Then people start to think about food as a medicine for IBD, and our pediatric colleagues are ahead of us in this field. So they use a lot of enteral nutrition. And what they found in summary that the exclusive enteral nutrition is as good as a steroid, which is one of the most effective treatment in inducing remission. However, the main issue with the enteral nutrition is that you cannot maintain the patient on enteral nutrition for a long time. So this show you that when patients return to normal diet, they relapse. This is the problem. So people start thinking about mimicking the enteral nutrition through diet and formulating a diet that is similar to exclusive enteral nutrition to maintain remission. And still there are a lot of work going for this. And this study showed that combining exclusive enteral nutrition or replicating exclusive enteral nutrition have a better tolerability and almost similar efficacy to exclusive enteral nutrition. And the way the westernized diet work is actually increasing your gut permeability and inducing inflammation. While if you tried a sort of diet that eliminate ultra processed food, you will strengthen your gut permeability and decrease this immune reaction. There are some studies done over a neutropathic substance, and however these are unfortunately not well designed. However, one of the most studied natural treatment for IBD is the curcumin, and there are some studies done on this venue. Other environmental factor that can develop can cause the IBDs are the cigarette smoking. You have twofold increase of risk of developing Crohn's disease. Also, smoker have a risk of flare, and the need of immunosuppressant increased by 1.5-fold. Breastfeeding decrease the risk of developing Crohn's disease by a odd ratio of about 0.7. Depression, stress, and sleep disturbance increase the risk of disease by 2-fold. So the take-home message is inflammatory bowel disease is a complex autoimmune disease in which lifestyle factor and environmental exposure play a pivotal role. Epidemiology study indicate that exposure to processed food lead to increased incidence of IBD and the shift in the geographic distribution of this disease. The dietary treatment have a proven efficacy, especially in pediatric population. However, there are multiple ongoing studies to define the optimal diet that can be tolerated in the long run as to maintain the remission in IBD. Thank you very much, and I would be happy to take any question.
Thank you, Dr. Bashar, for this very, very interesting talk, actually. I need you to welcome with me Dr. Muna Hafid, our next speaker. She will gonna continue our journey in GI system in relation to lifestyle. Dr. Muna Hafid, she is a family medicine consultant, Saudi and Arab board, and she will gonna talk about gastroesophageal reflux in relation to lifestyle. So welcome with me, Dr. Muna.
Good morning, dear all. I'm delighted to be here today and honored to have this opportunity to share the knowledge and experience with you, and I hope you will find this presentation informative and engaging. We will start with Mr. Ali's complaint.
Hello. My name is Ali. I'm 45 years old. I have been experiencing symptoms of GERD for the past 2 months. I'm experiencing heartburn, regurgitation, and the sensation of acid coming up into my throat 2 to 3 times weekly x 2 months. My doctor has diagnosed me with GERD, but I am not sure what that means exactly. Can you tell me more about it, its clinical features, diagnosis, and management?
Sure, Mr. Ali. GERD is a condition in which the reflux of gastric contents into the esophagus.
Hello.
GERD is a condition in which the reflux of gastric contents into the esophagus result in symptoms and/or complications. GERD is objectively defined by the presence of characteristic mucosal injury seen at endoscopy and/or abnormal esophageal acid exposure demonstrated in a reflex monitoring study. Prevalence of GERD was found to be 10 to 20% in the Western world and less than 5% in Asia. A SWOT study estimated that the prevalence of GERD among the Saudi participants was 28.7%. The prevalence of GERD among the Saudi population is higher than that in Western countries and East Asia. The pathophysiology of GERD includes poorly functioning esophageogastric junction, impaired esophageal acid clearance, decreased salivary production, delayed gastric emptying, and sometimes esophageal hypersensitivity. Some of the risk factors of GERD, among others, are family history, obesity, pregnancy, hiatus hernia, disordered or delayed esophageal motility, Zollinger-Ellison syndrome, xerostomia, which means the dry mouth, alcohol, and drugs. GERD manifests classically as heartburn and regurgitation. Heartburn is typically described as burning sensation in the retrosternal area, most commonly experienced in the postprandial period. Heartburn is considered troublesome as symptoms occur 2 or more days a week. Regurgitation is defined as the perception of the flow of reflexed gastric content into mouth or hypopharynx, and patients typically regurgitate acidic material mixed with small amounts of undigested food. GERD can manifest as well as atypical symptoms or extraesophageal symptoms, mainly ENT and pulmonary symptoms, like the water brush, dysphagia or adenophagia, chest or epigastric pain and or discomfort, satiety, burping or hiccups, bloating, nausea or vomiting. And for the ENT symptoms, which is an extraesophageal, symptoms like sore throat, recurrent otitis media, laryngitis, sinusitis, hoarseness, and for the pulmonary symptoms like chronic cough, asthma, and wheeze. It's very important that in the absence of classical symptoms of heartburn and regurg, other disorders need to be excluded before attributing the symptoms to GERD. So don't rush to the diagnosis of GERD if you have extraesophageal symptoms. Alarm features which are suggestive of GI malignancy include a new onset of dyspepsia in patients 60 years or older, evidence of GI bleeding like melena or occult stool occult blood, dysphagia or adenophagia, GI cancer in a first-degree relative, iron deficiency anemia, anorexia, unexplained weight loss, and persistent vomiting. The most common complications and serious complications of GERD are erosive esophagitis, esophageal stricture, and Barrett's esophagus. Okay, now there is no gold standard for the diagnosis of GERD. Thus, the diagnosis is based on combination of symptoms, presentation, endoscopic evaluation of esophageal mucosa, reflux monitoring, and response to therapeutic intervention. In the latest American College of Gastroenterology Guidelines 2021 for the diagnosis and management of GERD, it recommends for patients with the classic GERD symptoms, of heartburn and regurg who have no alarm symptoms, they recommend an 8-week trial of empiric PPIs, which is proton pump inhibitors, once daily before a meal. They recommend attempting to discontinue the PPIs in patients whose classic GERD symptoms respond to an 8-week empiric trial of PPIs. In patients with a chest pain who have had adequate evaluation to exclude heart disease, objective testing for GERD, which is endoscopy and/or reflux monitoring, is recommended. They don't recommend the use of barium swallow solely as a diagnostic test for GERD, and they recommend endoscopy as the first test for the evaluation of patient presenting with dysphagia or other alarm symptoms, such as weight loss and GI bleeding, and for patients with multiple risk factors for Barrett's esophagus. In patients for whom the diagnosis of GERD is suspected but not clear, and endoscopy shows no objective evidence of GERD, they recommend reflex monitoring be performed of therapy to establish the diagnosis, and they suggest against performing reflex monitoring of therapy solely as a diagnostic test of GERD in patients known to have endoscopic evidence of grade C or D reflux esophagitis, or in patients known to have long segment Barrett's esophagus. Okay, regarding the diagnostic test, the most common or the most known diagnostic test for GERD is the esophagogastroduodenoscopy, which is indicated for alarm symptoms suggesting complicated disease, such as if the symptoms were atypical, persistent, or relapsing symptoms, may show esophagitis like erosion, ulceration, strictures, or Barrett's esophagus. The second is the esophageal capsule endoscopy, which involves swallowing capsule endoscopy to visualize the esophagus. It doesn't require sedation, and this is a credit for this study, and it may show esophagitis or Barrett's esophagus as well. Ambulatory pH monitoring can demonstrate abnormal exposure to esophageal acid in the absence of esophagitis. American Gastro Association recommends ambulatory pH or impedance pH monitoring while off of PPI therapy for 7 days. For the combined impedance pH testing, it can quantify exposure to esophageal acid and identify reflux events, regardless of acidic content, to assess correlation with the symptoms, and may detect acid or non-acid reflux events. Esophageal manometry evaluates esophageal contractions and lower esophageal sphincter function. It may detect subtle presentations of esophageal motility disorders such as achalasia or diffuse esophageal spasm. It may suggest achalasia, as I mentioned, esophageal spasm, or other motor disorder. For the barium swallow, it may be useful in patients with dysphagia for whom endoscopy is contraindicated or unavailable, or as a complement to endoscopy. It may exclude other causes of dysphagia. Now, the most important part of our presentation is the management of GERD, and we will concentrate on the lifestyle, and we will quickly go over through the other modality of treatment. For the lifestyle, let us start by weight. Weight gain has been associated with a new onset of GERD symptoms, even in those with a normal BMI at baseline. Obesity increased the risk of GERD, possibly because of combination of eating diet high in fat and other food that promote reflux. Increased intra-abdominal pressure that promotes reflux because of increased intra-abdominal fat, physiological changes induced by products of visceral fat. In a population-based study in Norway, assessed weight and GERD symptoms at baseline and 10 years later, and identified a dose-dependent improvement in GERD symptoms with weight loss.
5 minutes, doctor.
Okay. Also, prospective and cohort study also have shown improvement in GERD with weight loss. One study documented 40% reduction in frequent of GERD symptoms in women who reduced their BMI by 3.5 or more compared with controls. A meta-analysis suggests that weight loss in overweight patients and avoidance of eating before going to sleep, smoking cessation are effective in the relief of GERD symptoms. American College of Gastroenterology recommended to eat smaller meals, cessation of foods that potentially aggravate reflux symptoms such as coffee, chocolate, carbonated beverage, foods with high fat content, spicy food, acidic foods such as citrus, tomatoes, and alcohol, and ketchup as well. Supporting data for these recommendations are limited and variable, often involving only small and uncontrolled studies, and rarely at the only intervention, making interpretation and definitive recommendations difficult. In lab studies, coffee, caffeine, citrus, and spicy food had little to no effect on lower esophageal sphincter pressure. However, some of these items may have irritant effects that could evoke GERD symptom without influencing reflux. Peppermint and high-fat foods do reduce the lower esophageal sphincter pressure in the lab, but few studies document the benefits of avoiding these foods and practices. A recent article using data collected from the prospective nurses' health study evaluated women without a known history of GERD for the impact of coffee, tea, soda, milk, water, and juice on reflux symptoms. 6 servings of coffee, tea, and soda were associated with increased reflux symptoms compared with 0 serving per day. By contrast, milk and juice were not associated with increased reflux symptoms, despite the acidic nature of some of these beverages. Substituting water for 2 servings of coffee, tea, and soda was associated with a decrease in GERD symptoms, suggesting that substitution of water for these beverages might be helpful in the management of GERD. Regarding the timing of food intake, the ACG recommends to avoid meal within 2 to 3 hours of bedtime. The timing of food intake can also affect GERD symptoms. A short interval less than 3 hours between eating and bedtime or lying supine is associated with increased GERD symptoms and the need for medication. Meta-analysis suggests that weight loss in overweight patients avoiding of eating before going to sleep and smoking cessation are effective in relief of GERD symptoms. Multiple studies including regarding the sleeping position, the third issue, is that multiple studies, including several RCTs, have demonstrated improvement in nocturnal GERD symptoms and nocturnal esophageal acid exposure with head of bed elevation or sleeping on the wedge. The first is the head of bed elevation, and the other one, the sleeping on a wedge. It's available at Amazon, if anyone wants to request.
1 minute, doctor.
Smart, okay. Also compared with lying left side down, lying right side down, increased nocturnal reflux and reflux after meals, because of right-sided recumbency places the esophageal gastric junction in a dependent position relative to the pool of gastric content that favors reflux. Thus, patients might be advised to avoid sleeping right side down. Regarding the smoking, smoking cessation was shown to improve GERD symptoms. Patient smoking cessation study had GERD symptoms measured by a validated questionnaire, and those who successfully quit smoking for a year had 44% improvement in GERD symptoms compared with 18% those who continued to smoke. A cohort study has found that smoking cessation may be associated with improved reflux symptoms in normal weight adults with GERD, and at least weekly anti-reflux medication use, but not in adults with less than weekly anti-reflux medication use in those with overweight or obesity people. Other measures that have a physiological basis but have not constantly been demonstrate to improve reflux symptoms, such as avoidance of tight-fitting garments to prevent increasing intragastric pressure and the gastroesophageal pressure gradient, promotion of salivation through oral lozenges, chewing gum to neutralize reflux acid and increase the rate of esophageal acid clearance, abdominal breathing exercise to strengthen the anti-reflux barrier of the lower esophageal sphincter. Now we will go. I have no time, sir. Okay, so we'll quickly get through the medications and the surgeries for GERD management. For the mild and intermittent symptoms, we can start with antacids PRN. If it is not effective, we can go to the histamine 2 receptor antagonist. And for the severe or frequent symptoms of erosive esophagitis, PPIs for 8 weeks, as we mentioned before, is a first-line treatment for GERD, and it is a diagnostic as well. Treatments not recommended for GERD, like prokinetic therapy and baclofen, it should not be used for GERD without diagnostic evaluation. There should be a diagnostic evaluation before. Helicobacter pylori eradication doesn't improve or worsen heartburn or GERD. This is a very important information because a lot of physicians are requesting Helicobacter pylori in case of the patients having GERD, which is not useful. For the anti-reflux procedure, we have several procedures, either through endoscopy or laparoscopy. For the endoscopy, we have the radiofrequency treatment called Strita and transoral incisions fundoplication. And for the anti-reflux procedures surgery, we have Nissen fundoplication, laparoscopic held gastropexy, and partial fundoplication called Atobay surgery, and the magnetic sphincter augmentation surgery. And thank you very much.
Thank you so much, Dr. Amuna, for this very interesting talk. And it was shocking, actually, percentage, 44% after smoking cessation of 1 year improvement and 40% after weight loss. So it's really worth to work on that. Our next speaker will be Dr. Leila Al-Arefi. She is OB/GYN consultant Saudi board, and she is participating in women health teaching as a Saudi Commission member, and now she's doing her fellowship in American anti-aging medicine. She will gonna take us in a journey in reproductive health in association lifestyle. So welcome with me, Dr. Leila Al-Arefi.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, ladies and gentlemen. I would like to thank the organized committee for performing this excellent conference, and also the audience for their attendance, and all my colleagues in the last 2 days who give us the very informative, comprehensive lecture, also for today morning session, which was very deep and informative and comprehensive. Today my talk is about effect of lifestyle on reproductive health, and this is my content, which including introduction, object and definition, incidents, and various lifestyle factors with reproductive health. Then we'll go to the recommendation and the practical management. Then we'll end with the conclusion. Reproductive health and fertility are important biological function for a human being. They potentially influenced by many modifiable and non-modifiable lifestyle factors, either positively or negatively. My object to give you a review on the influence of and the effect of these lifestyle factors on reproductive health, as well as practical application of them to improve reproductive health and fertility outcome in both women and men. Lifestyle factors defined as a various modifiable and non-modifiable behavioral practice by each individual. Usually, they are influence general health, well-being, quality of life, and also including reproductive health and fertility. Infertility defined as a failure to naturally conceive after unprotective 1 year regular sexual intercourse. It was estimated by WHO that 15% of all couples worldwide affected by infertility. Fecundity reduced in the last 5th and 6th decade worldwide. This is due to many medical and surgical factors, as well as changing in the lifestyle, especially in the industrialized developed country. It was found that the ability to conceive naturally, it's reduced with increased number of lifestyle factors. It's inverse relation. When there is no adverse lifestyle factor, usually it's more 80% they are conceived normally. If it is increased gradually up to 4 adverse lifestyle factor, the natural conception within 1 year is less than 40%. This is show you the important effect of this lifestyle factor on reproductive health and fertility. So we'll go to the first of this lifestyle factor. It's the age. Delayed childbearing age and starting a family late in the late 30 or 40, showing adverse effect on the reproductive health. Because when you get older, aging process is started, there will be degenerative change, inflammatory response also started, and this go in favor with oxidative stress also increased, involving all organs, and those also individual may have other harmful lifestyle habits, like they may smoke, they may have obesity, they have less activity. This showing this is the imbalance which will increase this oxidative stress, and this will damage on the DNA, especially in sperm, and it will affect sperm quality, as well as given reproductive complications like miscarriage and congenital anomalies. Nutrition and body weight also. We hear a lot about nutrition for this last 2 days and today. In general, unhealthy eating, it's prone to get obese, overweight. They found that the male who have BMI more than 30%, he had a 3-time reduction in sperm quality comparing to the normal one. Also, obese women showing more irregular cycle, more anovulation, more PCO. It takes longer time to conceive and a higher rate of failure in the treatment, as well as a higher rate of failure of assisted reproductive technique. Also, it's associated with more pregnancy complication. By reducing the weight in the women, almost at least 10 kg, she can resume her ovulation in 90%. Not only the overweight, also those who have eating disorder like bulimia and anorexia nervosa, or their BMI below 80%, they have also adverse harm effect. This is, can you see in this diagram, different negative diet and their effect and how we can overcome them to improve the reproductive health. I will not go in detail because of the time. This is some of the beneficial diet, like oily fish, vegetable, nuts, lean product, olive oil, all of this containing fat-soluble vitamin, omega-3, folic acid, antioxidant agent, and essential mineral. Also this another antioxidant agent, vitamins, minerals, which can help to optimize the male semen. Physical activity and exercise have a benefit in the improving the reproductive health. It was found that men who exercise moderately have more than 15% better sperm quality comparing to those who are not exercising or have little exercise. Also in the women, physical activity in moderate amount, it can have improved their insulin resistance, ovulation, chance of conception, especially if she's overweight or if she had other chronic illnesses. Also, it shows more beneficial if it is combined with weight loss. But the heavy, vigorous exercise shows adverse effect in the reproductive health and fertility potential. Study proved that in the cohort study of 5,000 athlete women with BMI less and equal 25%, they show they have a regular cycle and ovulation, amenorrhea, poor fertility potential, and poor reproductive outcome. Psychological factor, it's important factor that because the failure to conceive as well as reproductive complication, it's a stressful situation, and it's found that depression and anxiety and other psychological stress have an negative effect on the reproductive health. This work through elevation of stress hormone on HB adrenal axis, which influence the HB gonadal axis, and in men it will reduce the sperm quality, reduce testosterone level and spermatogenesis. In women also, by this increasing the adrenergic activity, it will inhibit and altering the HBG axis, which give a regular cycle and ovulation and amenorrhea. This diagram shows the involvement of stress to the infertility with hormonal involvement. Also, this is showing a gear wheel mechanism between the stress and the quality of life and infertility. Whichever setting you start, it's all related to each other. Also, this is showing a summarize the stress factor. It's a vicious circle involving fertility with stress and give poor quality of life, as well as with hormonal involvement through the hypothalamic, pituitary, adrenal, and gonadal axis. Sleep is important lifestyle, as we hear today in the extensive lecture from my previous colleague. It found that more than 20% of infertile couple had bad quality sleep. This also can raise the stress hormone, and this diagram showing the effect of sleep deprivation in a female as it's increased, this increased prolactin level, oxidative stress, altering the HBG axis, as well as having glucose intolerance and insulin resistance. All of this due to melatonin suppression. This will give anovulation and amenorrhea, and this will lead to infertility. And if she able to get to conceive and get pregnant, they are prone to more early pregnancy loss. In the men also, this. Okay, so this is the effect of a sleep on deprivation in the men. Also, as we hear today about the effect of a sleep, it can raise the cortisol, which inhibit testosterone and derangement of Leydig cell, lead to infertility. Also for medication and substance, those are medication can affect fertility, like smoking by increasing cigarette, by increasing oxidative stress. And we found that more than 35% of infertile male are smokers. Also women who smoke, they have decreased their ovarian reservoir, and its function. Also, alcohol have negative effect on reproductive health because it depletes the essential nutrient and reducing testosterone in male and quality of semen in women. It leads to anovulation, reduced fertility, as well as reproductive complication in form abortion, abruption, placental abruption, and teratogenicity in form of fetal alcohol syndrome. Caffeine, we hear for this last day a lot about caffeine. It's used as a privilege and a stimulant. There is a lot of conflict report in its effect, but it's advisable not to exceed the amount, because for more than 500, it found that it have fertilization and implantation problem. This is summarize some harmful lifestyle factors in fertility. And this is also a framework for effect of these different lifestyle factors in fertility outcome. Also, recreation drugs and illicit drugs and addictive drugs like heroin, cocaine, marijuana are associated with reduced reproductive health, and also they are involved usually with risky sexual behavior, like sexually transmitted disease, which lead to the infertility. Prescribing drugs, there are many, like some of antibiotic, some of H2 blocker, antihypertensive, long list, also can affect fertility. But the good thing about them, they are reversible once the individual stop them. Environmental health, including many factors, and this carry a potential harmful life hazard in reproductive health and fertility. Like cellular phone, that some study found putting them in the trouser, they have thermal and non-thermal effect through the electromagnetic radio frequency, and also radiation is dose dependent. Also air pollution, it's different element in the air can affect reproductive health for both male and female. Also heavy metal like lead, mercury, arsenic, cobalt also have a strong association. So we come to the practical management guide to modify lifestyle factors to improve reproductive health and fertility. First of all, understand the biology of aging. Couple can make informative decision when to start their family. It advised for women to start her age at age below 30, and for men at age below 35. Regarding nutrition and body weight, maintaining ideal body weight is crucial, as well as eat healthy food. As you know here today, or the last 2 days, about the Mediterranean diet, about the balanced diet, all this important, avoid processed food. Also do a moderate physical exercise, avoid heavy, vigorous exercise, as well as avoid sedentary lifestyle. For the stress, encourage them to relax, avoid and eliminate stress in their life, seek social and psychiatric counseling, and seek support and participate in supporting group. Optimize the quality of sleep is recommended, as we heard today about sleep hygiene. Also quit and minimize smoking and avoid passive smoker. Also abstain from alcohol, minimize caffeine drink. Also substance abuse should be avoided and treated if present, and also avoided unnecessary prescribing medication and drugs. Also identify and minimize exposure to the environmental health hazard, like electronic field from mobile devices and other devices and radiation. It is impossible to eliminate all harmful lifestyle factors, but effort can and should be made to minimize and reduce their adverse effect on reproductive health and fertility. So I come to my conclusion. Lifestyle factors have potential important role in reproductive health and fertility. It's important to understand their behavior either harm or beneficial effect on reproductive health and fertility. Evidence proof it's successful when it applied with or without medical approach to treat, to improve outcome of fertility and reproductive health. Healthcare providers have great responsibility practicing lifestyle perils for optimizing reproductive health outcome, as well as patients should have responsible and proactive role to optimize their health and reproductive health. More regulation and legislation recommended from the higher health authority to emphasize to implement its valuable role in the community. And more well-designed, controlled, randomized prospective study researches is needed and recommended, focused more in associations, causation, relation, effects between various modifiable and non-modifiable lifestyle factors, and reproductive health also is needed. Thank you for your listening.
Thank you so much, Dr. Leila, for this very conclusive and informative talk. Now we have more 2 lectures to end up with this session, but I won't take your permission. If you want to stand, we can play together just for 1 minute. Please, everyone. Yeah, stand up. Okay, so I'm going to say stand up, you'll stand up. When you're going to sit, you will sit. Okay, just play. So, sit. Stand up. Stand up. Good. Sit. Stand up. Stand up. Very good. MashaAllah, you are awake up. Thank you. Thank you so much. So our next speaker will be Dr. Ibrahim Al-Zibni. He is oral and dental surgeon and Chief Executive Officer and Medical Director of Medical Remote Group and Dental and Oral Surgery. He will gonna take us on journey in dental health, diet, oral health. We have really interesting to hear from him. So welcome with me, Dr. Ibrahim Al-Zibni.
عليكم. أول شيء شكرا لكم وشكرا للدكتور صالح وشكرا للدكتورة سامية أنهم سمحوا لنا السنة هذه ندخل طب الأسنان ضمن مؤتمر حائل طب نمط الحياة. بحاول أعيد الكلمة لأنها ممكن ما سمعتوني وهي تستحق الشكر للدكتور صالح والدكتورة سامية. ما أدري الدكتورة سامية موجودة ولا؟ كلمة شكر لكم إنكم سمحتوا لنا السنة هذه ندخل طب الأسنان ضمن طب نمط الحياة وأهميته. كلمة شكر ثانية رجال أمننا اللي واقفين الآن في مكافحة في الحملة الوطنية لمكافحة المخدرات بقيادة سمو سيدي ولي العهد. طبعا الحملة هذه حملة أنا حاب أتكلم عنها دقيقة لو سمحتوا لي بس. الحملة هذه حملة لازم المجتمع كلنا سواء الأطباء أو حتى أنا شايف معانا طلبة الثانوي. فمن الأصغر فرد في المجتمع لأكبر فرد في المجتمع الحملة الوطنية لمكافحة المخدرات لابد أن نتعاون معاهم ونقدم لهم يد المساعدة. كل رجال أمننا اللي واقفين ونشوفهم في نقاط تفتيش كثير ومعرضين حياتهم للخطر من عشان مجتمعنا وعشان صحة وقوة هالبلد بقيادة خادم الحرمين الشريفين وسمو سيدي ولي العهد. طبعا أنا حاب استسمحكم عذرا بس لأن معنا الطلاب الثانوي وحاب أتكلم شوي باللغة العربية عشان يفهمون معانا بس لأن الأطباء أكيد عارفين وأعلم مني في الكلام اللي موجود هنا. فحاب أوجه رسالتنا للطلاب الثانوي أو طلاب الجامعة. طبعا الفم وصحة الفم هو البوابة أو بوابة الجسم. إذا صلح الفم وصلح صحة الفم صلح سائر الجسد. الدراسات أثبتت أن حوالي 90% من الأمراض ممكن يكتشفها طبيب الأسنان في العيادة. تمر علينا حالات كثير خصوصا في مرض السكر او في مرض الضغط يبين لي ان المريض اللي قدامي فيه ضغط وهو او سكر وهو مو عارف ان فيه مرض اصلا ولا حل. فالفم الصورة هذه بنرجع لها ان شاء الله بعد ما نتكلم عن المحاضرة، وبنختار وين الصورة اللي ودنا يصير اللايف ستايل حقنا الان ان شاء الله. البنفيتس للتشيز، هو الفائده لانه موجود الكالسيوم، والكالسيوم طبعا مهم لكل اجزاء الجسم للعظام، والسن مكون عظم او الفك كذلك مكون عظمي، فالاجبان او الملك مفيد لتقويه مثلا عظام الفك او عظام، انا حاب اتكلم عن الاسنان بالمختصر، فمفيد للاسنان او مفيد كذلك لعظام الفك. طبعا لها فوائد كثيره ما تخفانا، ممكن يسوي لي اسيد بافرينج افكت، وممكن يسوي لنا عنده البروتين والكالسيوم عنده الفوسفورز، وفي الفوائد للاوميجا 3 الفاتي اسيد السبورتك الهارت هيلث، وله فوائد كثيره حتى في الجهاز الهضمي. فالجبن او الملك او مكونات الملك شيء مهم ورئيسي في الحياة. effect malnutrition on pediatric oral health. طبعا التغذية دائما احنا في اطباء الاسنان في العيادة، حتى لما تكون مثلا تجينا الام هي تفحص ومعها طفلها، دائما ننصحها في الاهتمام بتغذية الطفل، لانه ما بني على اساس صحيح حيستمر الاساس الصحيح معه. الافكت اوف المالنيوتريشن اون بيدياتريك اورال هيلث، الدراسات اثبتت عندنا ان التغذيه الضعيفه او التغذيه الغير الصحيحه للطفل في بدايه حياته في الاسنان تاثر عنده على اشياء كثيره، اللي هو الريبشن ديلايد اللي هو تاخر ظهور الاسنان البيرمننت، فهذه راح تاثر عندي، ممكن تسبب لي كراودنج اللي هو تزاحم الاسنان او سبيسنج في الاسنان، ويصير بعد الحاله هذه يحتاج مثلا التقويم ويدخل في علاجات كثيره ممكن تستمر مع لحد عمره 25 سنه او اكثر. وتسبب لي انيمال هايبوبليجيا، الانيمال الهايبوبليجيا هو التصبغ على الاسنان، نفس الخط الابيض، فيصير الاسنان ضعيفه او قابله للفراكتشر في اي لحظه. والدنتال كيرز اللي هو يساعد على نمو الكيرز في الاسنان. طبعا في البيرودنتال ليجمنت، وايضا عنده تاثيرات على الكافيتي اللي هو التجويف الفموي بالضبط، اللي هو المصطلح الكافيتي هو اللي هو التجويف الفموي ومشاكله واضراره الكثيره. فاذا الطفل ما تغذى صحيح من بدايه عمره رايح يتسبب له اضرار كثيره، ممكن يعيش معاها الى العمر كله، وممكن يحتاج علاجات مثل التقويم او التركيبات واشياء تدخل هو في غنى عنها. الجروث انهبيشن اوف اورال ميت ستريبتوكوك، الستريبتوكوك طبعا كلنا عارفينها، يعني حتى من امس كنت في محاضره في الغزاله وكنا نتكلم عن علاقه الاسنان بصحه الجسم كامله. ف يعني حتى كنت القي المحاضره لانها كانت مو للاطباء، كانت للجمهور عام، فكان مستغربين ان الاسنان تسبب لي امراض كثيره منها الاسنان او الباد اورال هايجين ممكن يسبب لي او يضر لي مشاكل في القلب، او ممكن يسبب لي امراض في الكلى. في حالات كثيره اثبتتها الدراسات انه ممكن يسبب السكتات القلبيه، في حالات كثيره اثبتت انها سببت سكتات قلبيه بسبب انتقال مايكروويف من الفم الى القلب. السليب روكزمز اللي هو احنا نسميه في العربي صرير الاسنان، اللي هو دائما هذه تكون هي مرتبطه طبعا مع نقص فيتامين دي، وغالبا يصير صرير الاسنان وهو نايم، فهذه تسبب لي اضرار ان الاسنان تكون صحيح دكتور، فهذه الاشياء تسبب لي انه ضعف حتى في الكاتنج فود، فتتسبب لي انه ترجع المشاكل ثانيه، ممكن تسبب لي مشاكل هضميه. المعده طبعا محتاج ان الاكل يجي لها جاهز للهضم، فهذا ممكن بعد من الاضرار لما المعده يجي لها الاكل فتحتاج، ممكن يسبب لي ارتجاع مريء. فهذه من ضمن الاشياء اللي احنا تكلمنا امس. انا معليش دمجت محاضره امس مع اليوم، فعشان بس اوضح اضرار اهمال الاسنان. آية قرآنية: وجعلنا من الماء كل شيء حي. طبعا أهمية الماء لنا إحنا كأطباء أسنان بوجود الفلورايد. الفلورايد طبعا هي المقاوم الأول لتسوسات الأسنان، أو هي الطبقة اللي تحمي لي السن من التسوس. طبعا للأسف أنا في العيادة ملاحظ كثير إن عندنا في المراجعين مشكلة عدم إدراك أهمية الابليكيشن فلورايد. الابليكيشن فلورايد طبعا تطبيقه عندي أنا في العيادة ما ياخذ مني 10 دقائق، وبدون أي تدخل جراحي وبدون أي أنستيزيا وبدون أي شيء، يعني تاخذ مني 10 دقائق وأنا مخلص الموضوع. فمحتاجين، أنا أتمنى أن تصير ثقافة شعبية عندنا أن كل الأطفال نزور فيهم عيادة الأسنان ونطلب من طبيب الأسنان الابليكيشن فلورايد لحماية الأسنان. حتى لو كانت أسناني أنا كأدلت، لو كانت أسناني سليمة، أنا محتاج إني أسوي الابليكيشن فلورايد. إجراء بسيط جدا ويحمي لي أسناني على المستوى البعيد. طبعا هذا لما تكلمنا عن أهمية الفلورايد، مثل ما قلنا الفلورايد decrease البين and sensitivity للسن، فهو يعني يسوي لي زي الطبقة العازلة بروتكت للسن. ريديوس الجم ديسيز اللي هو الأمراض اللثة أو مشاكل اللثة. طبعا مشاكل اللثة باب طويل، بس إن مشاكلهم ممكن الابليكيشن فلورايد ممكن يحمي لي الشيء هذا. وبريفنت التوث ديكاي، تحميل السن من الكيرز او من المشاكل اللي ممكن تحصل لي مع بسبب عدم وجود الفلورايد او ضعف الفلورايد في المياه الموجوده عندي. oral manifestation of nutritional deficiency اللي هو نقص الفيتامينات الموجوده. الفيتامينات هذه كلها عارفين انها موجوده في الاغذيه بشكل عام، طبعا الاغذيه الطبيعيه. بنتناول اللي اكثر شيء موجود الفيتامين اللي موجود نقص، فموجود عندنا هنا شعبيا او متداول. مثلا عندنا نقص فيتامين بي 12 ممكن يسبب لي بون لوس، او ممكن يسبب لي البينفول ارسل ان ماوث، او ممكن يسبب لي انجلر شيلايتس اللي هو مشاكل في الانجل للماوث. عندي فيتامين سي بليدنج الجمز اللي هو ممكن نزيف اللثه، وممكن يسبب لي نزيف اللثه. ونزيف اللثه طبعا له عده اسباب كثيره غير فيتامين سي، منها مرض السكر او مرض الضغط. وبالمناسبه انا حاب اتكلم على نقطه بعد اللي هو من الدايجنوزز اللي دائما نشوفها في العياده. دائما في بعضهم يجي مريض ضغط وهو مو عارف انه مريض ضغط ولا شيء، فاجي اللثه عنده لما اكشف على اللثه احصل النزيف بسيط يطلع من اللثه. طبعا احنا عارفين ودكاترتنا عارفين الشيء هذا اكيد، ان ضغط الدم، ان ارتفاع ضغط الدم في الجسم فيحتاج الدم يطلع من اي مكان، فيحصل البلد فيسلز الضعيفه اللي هي موجوده من اضعف الاشياء الموجوده هي في اللثه، فيطلع من عندها الدم عشان يخفف الضغط على في الجسم. وفيتامين دي، فيتامين دي الانيمال هايبوبليجيا وابسنس اوف اللامينا ديورا. اللامينا ديورا طبعا غياب اللامينا ديورا عندي ممكن يسبب لي، اللامينا ديورا هي اول شيء هي اللي تسوي لي الاتاشد بين الروت اوف تيث والجو، هي اللي تمسك لي السنه يعني بالعاميه يعني، فبدونها ممكن يسبب لي موبايل اوف تيث. الجزر يعني في المصطلح العام طبعا في فائدة ممكن مميزة فيه ان require الفلوت شيوينج كلين تيث، يعني مضغ الجزر قاسي شوي، فمضغه ممكن يساعدني في تنظيف الأسنان. طبعا وجود الفيتامينز فيه اللي محتاجها الفم او المينرالز اللي محتاجها الفم. طبعا الجزر يساعدني في ستيمولت ذا فلوس اوف سلايفا. طبعا السلايفا اهم شيء في الفم موجوده، يعني غياب السلايفا او اللعاب في الفم ممكن يؤدي لكل المشاكل اللي احنا نخاف منها الاسنان. تسوسات الاسنان، طبعا التسوس او الكيرز محتاج بيئه جافه عشان يبدا يتعايش ويتكاثر، فالسلايفا وجودها مهم جدا. طبعا في ادويه كثيره تسبب لي ديكريز اوف سلايفا. طبعا كونتين اوف فيتامين سي والكالسيوم والكرياتين. الناتس اند الكاشيو اللي هو المكسرات بشكل عام. طبعا هي باكد with calcium and phosphorus which add benefits to teeth and bone. طبعا المكسرات بشكل عام هي مفيدة للعظم الفك وللأسنان بنفس الوقت. طبعا تحتوي على كثير من الفيتامين ومن الأشياء اللي يحتاجها تكوين السن أو تكوين اللثة أو تكوين الجو نفسه. طبعا هذه الفوائد بشكل عام للجسم، فبحاول اني اختصر الوقت لانه باقي 5 دقائق او اقل الحين. التي اند الكافي، طبعا احنا اطباء الاسنان نعيش انفصام شخصيه ترى مع التي اند الكافي. التي اند كافي انا ودك مره تنصح فيه وودك مره ما تنصح فيه. طبعا هو مفيد جدا للاسنان، لكن الضرر الوحيد انه يسبب تصبغات سريعه، وكل اعتقد الان القهوه ترند عندنا في السعوديه، فنعاني كثير من تصبغات الاسنان. طبعا احنا ما ننصح في الوايتنينج اوف تيث لانه ممكن يسبب لي مشاكل، فالقهوه والشاي له فوائد كثيره في للاسنان. هي مثلا مضادات اكسده او انها بريفنت السيل دامج، ممكن تحافظ لي على السيل دامج. الفائده الاساسيه عندنا للتي اند كافي helping to fight cancer اللي هو سرطانات الفم. فالقهوه والشاي من اكثر الاشياء اللي تساعدني اني احارب سرطان الفم. طبعا احنا قبل شوي تكلمنا عن الفلورايد، اللي تكلمنا عن فوائد الفلورايد. فالتي غني بالفلورايد، وممكن التي يساعدني بتقويه السن اللي هي تقويه طبقه المينا في السن. هي طبعا الفلورايد مهم لطبقه المينا اللي احنا نسميها الانيمال، اللي هي اول طبقه في الاسنان. strawberry and other vitamin C rich. الفراولة فيها ميزة يعني خص الله سبحانه وتعالى في للأسنان، في هذه إنها تسوي لي الناتشورال وايتن للسن، يعني تبييض طبيعي للسن. تناول هذا الستروبري باكد with فيتامين سي وانتي اوكسيدنت and also malic acid which called FN natural whiten your teeth. فهي تساعدني في تبييض الأسنان الطبيعي، فنحاول نستغني شوي عن تبييض الأسنان. هذه إحدى الدراسات في طبعا هذا السن احنا قبل شوي كنا نتكلم عن الانيمال والدنتين واهميتهم. طبعا الانيمال اللي هو الطبقه البيضاء اللي هي اول حامي للسن قبل لا يوصل للبلب او يوصل للدنتين. طبعا الدنتين هو الكفر للبلب وقبل لا يصير عندي نكروتيك تيث او مشاكل في السن. فالانيمال هو الحامل الاول، وهو اللي نطبق عليه الفلورايد عشان نحاول ريديوس الكيرز جروث. سويت بوتيتوز باك هيلثي، طبعا غنيه بفيتامين A اللي هي البطاطس الحلوه والبطاطس هي غنيه بفيتامين A which help الميكوز ممبرين and soft tissue للجم، السوفت تيشو اوف جم اللي هو يعني تقوي لي من الاجزاء الجم وتخليه يقدر اللثه تكون صحيه اكثر. البروكلي، طبعا البروكلي مو كثير الناس تحبه اعتقد، صح ولا؟ ما له شعبيه كثيره. ها؟ طبعا هذه احد الدراسات، بس بنحاول نختصر عن نشوف فوائد البروكلي maybe you're not fan broccoli، لكن البروكلي سبحان الله يعمل لي كلينر، ناتشرال تيث كلينر للاسنان، فهذه احدى الفوائد في البروكلي طبعا لما يكون فريش يعني. وهذا البروكلي فيه تو فيتامينز يهموني انا كطبيب اسنان. الفيتامين سي اللي يقلل لي decrease the risk of periodontal disease and increase the tissue strength، هو يقلل لي البيريودنتال ديسيز. البيريودنتال ديسيز هي الرابط ما بين اللثه وما بين السن، فهذا يقلل لي يعني. garlic and onion، طبعا هو المشكله انه يسبب لي باد بريث، هذه المشكله الوحيده اللي تواجهنا، لكن هو انتي مايكروبل، يمكن يعتبر رقم 1 في الطبيعه. طبعا الفيش اند الميت هذا كلنا عارفين فوائده، لكن احنا كاطباء اسنان يهمنا انه في الشيوينج اكثر شيء، انه يساعد كثير في بروديوس السلايفه. احنا تكلمنا عن السلايفه واهميتها ووجودها في فم الانسان. طبعا التوازن الصحي هو مفتاح صحتنا كلها، فالغذاء للجسم كامل من كل اجزاء الجسم، من اصغر جسم لاصغر جزء لاكبر جزء، فاهميته كبيره في طبعا دائما احنا the best example are milk. دائما التريتيك اسيد naturalizing food after sweet meal. دائما لما ناكل الوجبات السويت نحاول ان بعدها ناخذ حليب او نشرب مويه كثير عشان نحاول نقلل. طبعا مهما تكلمنا ما راح احد بيقلل السويت او تناول السويت، فنحاول نقلله بوجود في طرق معينه مثل الكثار من المويه بعد الوجبات او الحليب. For good dental health, keep this tips in mind when choosing your meal and snacks. طبعا هذه الاشياء مهمه عشان تحافظ على صحه الاسنان. درينك الووتر، طبعا الووتر لازم يكون فيه فلورايد، وتناول وجبات كثيره من الفواكه او الخضروات او الفيش او اللحم. طبعا دائما ننصح ان مرتين تنظيف الاسنان. وطبعا الخيط الطبي، بعض اطباء الاسنان يعتبرونه اهم من الفرشاه والمعجون، لان الخيط الطبي يوصل الاماكن ما يوصلها للمعجون. طبعا المسواك كلنا احنا كمسلمين عارفين فوائد المسواك، حتى طبيا اثبتت الدراسات الان ان فوائده خصوصا في الاسنان. ممكن نستبدل السويت او الحلا في الجبان او الخضروات، او اذا اضطرينا ان ناكل سويت ان لازم مباشره ان نغسل الاسنان او الفم. طبعا هذه آفة العالم كله اعتقد، هذا على قولتهم ابو المصايب كلها. فالتدخين عدو طبيب الاسنان الاول، مشاكل كثيره، تصبغات، تسوس واشياء كثيره. فما يحتاج نتكلم عن اضرار التدخين، لان حتى المدخن اول من يعرف اضراره. آية قرآنية: وانفقوا في سبيل الله ولا تلقوا بأيديكم إلى التهلكة واحسنوا إن الله يحب المحسنين. فهذه الآية دائما المدخنين يستدلون، يقول ما في آية تحرم القرآن. فأعتقد أن ولا تلقوا بأيديكم إلى التهلكة هذه أكبر دليل أن الدخان محرم دينيا. طبعا احنا بأول المحاضرة، معليش تأخرت، بأول المحاضرة أنا قلت بنرجع للصورة هذه إن شاء الله. طبعا في عناية الفم أنت تبتوصل للمرحلة هذه إن شاء الله، وفي السوء راح توصل للمرحلة هذه. طبعا كلنا نتمنى أن نوصل للمرحلة هذه ونبتعد عن الباد اورال هايجين ومشاكل الأسنان. شكرا لكم وأنكم منحتوني استماعكم، وآسف للدكتور أني أخذت وقت زيادة.
الله يعطيكم العافية. وحقيقي وجود الدنتست with us in conference like lifestyle we can give to our patient. Welcome with me our last speaker for this session, Dr. Mohammed Al-Hakbani. He is consultant family medicine, Saudi board, and he is guiding patient to utilize and make decisions on how and when to use alternative medicine and implement these practice in their daily life. He will gonna take us on a journey and talk about phytochemicals role in chronic disease management. So welcome with me, Dr. Mohammed Al-Hakbani.
السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا في مؤتمر حائل. أشكر الدكتور صالح الراجحي حتى فرصة لي إني أتكلم عن واحدة من أهم التطورات في الميديسن. It's phytochemical medicine. طبعا إحنا we know إن fruits and vegetables are very beneficial to health. But why? Is it only vitamins and minerals, or is it something else? This mystery will be unfolded slowly as we discover as a human species how we interact with nature and make it our fountain of youth, inshallah. So when we talk about phytochemicals, we talk about the essentialities of being a plant. Point here. There. When? Point here. Okay. الأحمر؟ Okay. معليش على التأخير. So what we will talk about in this lecture is what are phytochemicals essentially? What are the types? And how we can utilize them, and how they how preparation of food affects these phytochemicals. Also, do they have side effects, and what studies will prove their benefits? So let's look at this blueberry alone, hanging from a tree. What protects it? Allah subhanahu wa ta'ala, of course. But what else? These blueberries create this darkish, purplish, bluish color. For what? It protects it from UV radiation, droughts, chemicals in the environment, and other stressors. This compound can be distilled into medicine, but we will talk in another period about this. But how this will affect us as a human being, the same benefit that phytochemicals provide to plant will provide to us too, as we talk about it in the lecture. Be mindful that a stress exposure of the plant will induce more phytochemicals, so try to take them seasonally and in open fields. So, eating the rainbow, always aim to have variety of colors inside your food. This is a general recommendation before even we go into details about how phytochemicals and what they can do. So phytochemicals are of variety of compounds. We will talk about carotenoids, we will talk about organosulfur compounds, and we will talk about phenolics, as they constitute 45% of the structure. This is a cheat sheet. We will talk about a lot of these compounds inside the lecture, but mostly we will focus on blueberries, we will focus on garlic, we will focus also on beta-carotenoids, and we will also focus on sulforaphane. So this is just a small table constituting each group and how it affects health. Also a cheat sheet on each of the phytochemicals and the color coded. You can return it after we finish the lecture. Now, you want to go back and take a picture? So phytochemicals are divided into a lot of groups, but we will talk about polyphenols. So polyphenolic compounds are very important as they exhibit multiple effects, one of which is antioxidant, anti-cancer, and even antimicrobial effects. We will talk about 3 plant compounds that exist inside the polyphenolic, and they are the most potent in managing chronic disease and health. So dietary polyphenols exert their effects by direct and indirect pathways. So let's say that you ingested one of the polyphenolic compounds, let us say be it a blueberry, or a dark chocolate, or even some of the other polyphenolic compounds. What happens? So what they do in the small intestines, they decrease digestion and absorption of intestinal carbohydrates. This also, after passing into the large intestine, modulating by the microbiome, it will produce various effects on tissues, leading to improved glucose homeostasis. All of this through genetic and expression, and also acting directly on glucose transportation to inside cells. So dark chocolate. Who loves chocolate? Exactly, everyone. But we should be very mindful when using chocolate. I will talk about it like in the coming slides. So chocolate is a very good scavenging free radical compound. It also reduces cardiovascular disease, notably by increasing nitric oxide. So nitric oxide is a very potent compound. Why? It does induce vascular vasodilation, which means that there will be a reduction in blood pressure. And this is what has been found in studies, that the most notable effect of dark chocolate is decreasing both systolic and diastolic. So systolic by 4 and diastolic by 2 milligram mercury. How about LDL? As we talk about chronic disease, hypertension, of course, increased blood pressure, increased lipid accumulation, and heart disease, and the neurodegenerative disease will be covered all in this lecture. So LDL, chocolate in a meta-analysis in 2021, and especially in those subtypes of patients who have diabetes or who have increased blood sugar, shown that it reduces LDL by 15 milligram per deciliter. This is a very significant decrease. What about stroke? In also a large meta-analysis, which examined the heights, examined those who have chronic disease, it was demonstrated a decrease by 13 to 17% in those patients with the highest category of chocolate intake. Amazing, right? So about cardiovascular disease, also 12% decrease. And this is one of the meta-analysis that has been found. So, okay, we know that chocolate is great. Let's eat all of it. But we should be very selective. It should be 75% of dark chocolate. Less than that, it will not be effective. More than that, it might be even more effective. So what is the dose? Dose is 10 grams to 40 grams of dark chocolate. This can be just a cube or 4 cubes. But we should be mindful. This can trigger some gastrointestinal discomfort. It can also cause increase in effect in antiplatelet medication and hypertension medication. Oxalate is also a permanent compound in dark chocolate, so be careful with your urinary stones. It also has caffeine, so it might impact sleep. The blueberry. It is one of my favorite foods, and I hope that it will be yours too. The blueberry has two important phytochemicals. They are involved in aging in general, especially peristalbine. But I will talk just about its effect on neurocognition. As it was, all of these are hyperlinked to links if you open the slides, and you will find the studies that demonstrate the effect. But due to time constraint, I will just be very quick about it. So it increases the neuron growth factor. The neuron growth factor is very important because it does three things. It improves the number of neuronal cells and synapses and increase the communication between them. So in seniors, blueberries, a diet high in strawberries, have demonstrated an increase in cognition, especially with those 65 and older with mild cognitive dysfunction. But keep in mind that the actual content of this phytochemical is varied in season, soil, and weather. And I told you, the more stressed the compound, the more stressed the environment, the more abundant the polyphenols. So what is the dose of strawberries? We will go with the fresh blueberries because they are the best. So you go for 6 grams per day. 60 grams per day is enough to produce beneficial effects. Just be in mind that it might, in theory, potentiate and induce hypoglycemia in those who are on hypoglycemic agents. Broccoli. Important. If I would say, like, what is the most important plant, or what was the most important plant group to be eaten is cruciferous vegetables. So why? The broccoli contains a very potent compound called sulforaphane. Sulforaphane is one of the most important triggers for NRF2. NRF2 is the parent of antioxidants. It doesn't go and tackle antioxidant by itself, but it triggers genetic factors that in turn increase everything, including decreasing inflammatory mediators, increasing autophagy, and increasing antioxidant defense. This all leads a protective effect on the neuronal system, acting by reducing oxidative stress and also enhancing DNA repair. So sulforaphane in multiple studies has been reported to prevent progression of Alzheimer's disease, dementia, also Parkinson's disease, and other neuropsychiatric disorders. And in a review article, this has been recently issued, a very extensive article. I would recommend to read this article, to be honest, on the effects of broccoli as a neuroprotective agent. So what it does, it prevents the age product, which is advanced glycation end products that exist in conjunction with diabetes. And what it does, it protects the body from retinal degeneration and improve memory dysfunction related with diabetes mellitus in animal models.
5 minutes, doctor.
Yeah. So this is a list of all the studies. Sulforaphane also helps in switching white adipose tissue to brown adipose tissue, preventing obesity, also protecting the heart from diabetes mellitus-induced cardiomyopathy. How about garlic? Garlic is important. I love garlic. But don't cheat. Don't eat it like swallow it and prevent the breath. No, you need to chew it, you need to cut it, and you need to smash it to activate an enzyme that uses alliinase to convert all the sulfur phytochemicals into their active compounds. And it will act by releasing hydrogen sulfate. Hydrogen sulfate vasodilate by 2 mechanisms, directly by acting as a vasodilator and indirectly by modifying intercellular mechanisms. So the protection from garlic doesn't end only with decreasing blood pressure, but also decreases cholesterol. And What it does is prevent calcium accumulation in also arteries. So all arteries with plaques, they will have decreased calcium content. This is shown here in a study in hypertensive patients, and it showed decrease by 8 milligram mercury. Also, aged garlic is the same effect. How about its serum lipid? Also 9 milligram per deciliter. Combine that with chocolate, we will have 27 to 30 milligram per deciliter. Aged garlic extract in 2 studies prevent platelet aggregation. This is very important, prevention MI and stroke. Direct and indirect effect. Inhibiting also the progression of calcification, as we said. We will jump quickly through the slides, as there is a lot of things, but the most important thing, don't microwave garlic. Microwave garlic and you will lose all the benefits. Crush before you cook. Crush or cut. Aged garlic is better than the normal variety because of the absence of the breath. Just be careful that it will induce hypotension and prevent aggregation of platelets, and it might also trigger asthma with the smell. Carotenoids, carrot, because it's one of the most important anti-aging compounds. Horvath, a clock of epigenetic aging, showed deceleration of aging associated with carotenoids. This is the strongest association ever. No other factor have decelerated aging more than carotenoids, because what it does is it decelerates aging by a factor of relative risk factor of minus 0.25. So this is like, he talked about it and he was very amazed, like, why? But why? We will see now. Carotenoids do a lot of things. They modify inflammatory signaling, and they act in the mitochondria to preserve mitochondria, prevent it from dysfunctioning, and also prevent dysfunction inside the cell and association with apoptosis. The fruits that contain the carotenoids make it more absorbable than the vegetables, but the vegetables, if cooked, you will have high absorption but decreased content. So cook the vegetables before eating. It will prevent macular degeneration, prevent cataracts, and it will also prevent blue light photo damage. It will protect the heart, protect the brain from oxidative damage, as shown here in these studies. The most carotenoid-rich diet will help the consumers in a very big study. This lutein and zeaxanthin, they protect the eye from macular degeneration and cataract, photochemical damage, and it will also make you see in HD. It will make you distinct colors much better. A neurodegenerative disease, a very big studies, also listed here. Cardiovascular disease and diabetes. And we here talk about the bioavailability, like we said. Yes. So lastly, curcumin. So this is curcumin. Curcumin is a phytochemical that is derived from turmeric. Curcumin is very important in battling metabolic syndrome. How does it help in preventing metabolic syndrome? I will talk about it later, but it helps majorly in inflammation. It is shown to be as potent as COX-2 inhibitors like diclofenac and ibuprofen, and less harmful to the kidney. So it helps by reducing blood pressure, but also by improving insulin sensitivity directly. Don't forget combining curcumin with its best friend, black pepper, because of the poor absorption of curcumin. Black pepper increased bioavailability of curcumin 2,000%. Thank you very much for this. Thank you for listening, and thank you for your time. Thank you, Dr. Saleh, and eat the rainbow, please.
Thank you so much, Dr. Mohammed, for this very informative and really interesting talk. Now we finish our session. Just want to conclude that Dr. Dr. Bashar, he was give us very interesting talk about inflammatory bowel disease, and he discussed with us the pure study and the ultra-processed food, how it's causing. Dr. Amuna Hafiz talk about GERD and association lifestyle, smoking cessation, weight reduction. Dr. Leila about reproductive health in relation to lifestyle, and Dr. Ibrahim about dental health, which was very interesting talk about fluoride application, smoking, and fruit and vegetables. And last not least, Dr. Muhammad talk about phytochemicals and how it's really, really important about rainbow and multicolored food. So now move to our question and answer. We have 2 minutes to take questions, and I thank all our speakers here. في سؤال هنا.
Bismillah. A question for Dr. Muhammad is about, a lot of company are making this chemical like the berries and the broccoli in form of tablet. Do you recommend any of those, and are they safe and effective as the real one when you eat them fresh? And what is your take on that, if you don't mind?
Hello, and yes, I am well aware of these compounds. But I want to highlight that all the phytochemicals have a poor absorption by themselves. So if you take, for example, just the one polyphenolic compound, it will find very difficult time being absorbed by the intestine. But if you take them in the natural form, especially sulforaphane is very degradable and it's very sensitive. So having it in tablet form, it will not be effective. I would recommend that you eat broccoli, and it will only be like 30 grams of broccoli, 40 grams of broccoli per day. But for some polyphenols, it's very effective. When we talk about other polyphenols that might be, let's say, curcumin. Curcumin is much more absorbed by black pepper. So they found the formula there. But I would stress on eating them in natural form, because some of them say resveratrol is very good. You need to take resveratrol tablets. In actuality, it's very poor absorption, and you will find a very hard time. But others like fisetin, like for example in strawberries, which is fighting zombie cells inside the body, it's very effective. If you have any specific compound in mind, I will answer you for specifically if it is recommended or not. It's very complicated, to be honest. It took me a very big while of research to find out which polyphenolics can be distilled as medicine and which cannot. Thank you very much.
Assalamu alaikum. I have 2 questions. One regarding the dental care. Is it effective to chew gums between meals if you don't have time to brush your teeth, and there is any recommendation about any kind of gum? My other question is regarding the nutrition, regarding eating the vegetables without cooking. Is it effective, like broccoli, carrots, peppers, different colors of peppers, orange, red, and green, and how much cooking lose its effect? Because if we cook, we really cook, and if we don't cook, we don't cook.
السلام عليكم ورحمة الله وبركاته. لما احنا نتكلم عن of course let's say carrots. So carrots, as I talked about beta-carotenoids, the carotenoids by themselves are poorly absorbed in vegetables. But when you take them in fruit form, it will be like more absorbable. But if you cook carrot, it will be less polyphenols, you will get less beta-carotenoids, but it will be more readily absorbed. So I would advise on making them cooked. So for carrots, cooked. For broccoli, it's a much more complicated thing because sulforaphane is a very fragile molecule. So if you cook, you lose sulforaphane. But I would advise for maybe steaming, steaming would be a very good idea. Boiling, I'm not really sure, but steaming for sure is nice for broccoli. And you will find that steaming will not require a lot of time or preparation. I don't know about other things, like if you have any specific vegetable in mind, you can maybe ask. Thank you very much.
Thank you so much for your interaction, and our speakers will be there if you have any more questions. But now we're going to move to distribute appreciating certificate. And I have only one comment regarding that fruits and vegetables, it's really important and still expensive. So after these agreements happen in first day, that we hope the tax will going to be decreased and cost of this healthy food will going to be decreased, so everyone can offer it. So we're going to move to distribute appreciating certificate. Thank you so much.
Thank you for all speakers and moderators in the first session and second session. Now, Dr. Farhan, please join us, or Dr. Saleh, or both, inshallah, to do the speaker and moderator's honoring part. We'll start now. Dr. Abdul Karim Al-Sharari. دكتورة حصة الحسيني. دكتورة سامية المحمادي. دكتور صالح الغامدي. دكتور علي قراتلي. دكتور رحاب العنزي. دكتور عبد الله الطحيني. دكتور نسرين الحامدي. دكتورة منى دكتورة منى حافظ. دكتورة ليلى العريفي. دكتور إبراهيم الزبني. دكتور محمد الحقباني. دكتور مصلح الرشيدي. دكتورة سلطانة العتيبي. دكتور آلاء القرشي. دكتور محمد تانر. We reach the visit of this morning sessions. Please, we are starting our break now for prayer and lunch. We'll see you at 1 o'clock sharp, inshallah, here again for the research session. It's a good, interesting research session. Don't miss it, please. Be there. Thank you.
Ms. Muna Said, my name is Ala Al-Qurashi and I will be your moderator today. So as you notice, in the last 2 days, our speakers and colleagues, when they talk about the importance of food, how they integrate lifestyle medicine, the guidelines, the practice, they always use research to support their talk. Why? Because research is an evidence, and it's very important to have a valid evidence before you apply or implement or use any new approach or treatment. That's why it's very important to have evidence-based of lifestyle medicine and preferable to have it from a local research. So we will have today our session to present some evidence research presented by distinguished researcher from a local research project. So just let me give you a few words about the outline of our session. It will start with a very inspiring talk given by Dr. Mohammed الثاني in regard to the essential of impactful research. Then we will have our 7 oral presentation, and we will have after that a panel discussion. During the panel discussion, you will have an opportunity to ask questions. So you can use this opportunity to know more about the research in general. You can ask the panelists any question related to research, like financial, scientific writing, methodology, and so on. And also you can ask some questions to the speakers related to their presentation. We will wrap up with the announcement of the 3 winners and the certificate ceremony. So now we would like to welcome Dr. Mohammed الثاني. Dr. Mohammed الثاني is one of the co-founder of the research center at King Fahd Medical City in Riyadh. He is also one of the best winner of the most cited research awarded in the Arab world at 2018. Dr. Tanir holds several positions at the Research Center at King Fahd Medical City. He is a chairperson of the monitoring department and a head of the strategic development section there. He has over than 83 peer-reviewed international publications, and also he's a member of many committees. Please welcome Dr. Mohammed الثاني.
Thank you, Ala, for this introduction. Thank you, the scientific committee, namely Dr. Saleh Rashhi, for inviting me for this meaningful, important conference. We will talk today about essentials of impactful research. Though the scientific committee selected the topic, but I found it very important once I thought deeply in it, because what happens for most of us when we publish just for self-esteem. We publish just to get promoted. We publish just to get cited. But very rarely, when we found what we publish is translated into real practice and real world. And this is really sad, because you all know that research demands a lot of time and efforts. So hopefully this presentation today will show you what are the steps we need to take from point 0 till we achieve publication in order to really implement our findings in the real world. So we need to really make a change based on our findings in the research that we conducted in the real world in order to get some benefits to the society or to the economy, to the health economy, or to policymakers that all pour in enhancing the healthcare of our society. I believe the presentation is not ready. So I will keep talking, it's okay. What is impactful research? Impactful research is all about that findings of research will make a real change in the real world. So to get benefits to the individuals, to the society, to the policymakers, and to work in parallel with people that are in high positions in order to enable us to make this translation. So you all heard about translation medicine. What is translation research? Translation research is really to bring up what you found into your research to the clinical side, to the bedside, to the benefits to your clinic. So we all, as I just said, we found our colleagues conducted some research, and very important research, but are not really into practice, into our daily routine practice. So the effect of the research has beyond academia. So again, I stress on this point, do not publish only to say that I have 7 publications, it has been cited 200 times, I have an H index of 14, and that's why what our institutions recognize us for, but none recognize us for if our findings have made some change for our society. So we have to stress on and make this change and ask people in in position, people in responsible people to recognize us about our research when we really make a change. I will give again an example. In 2011, a research center at King Fahd Medical City conducted a research about non-prescribed, about like dispensing antibiotic from community pharmacies without prescription. We found a percentage of about 77.6% of 325 pharmacies that they were surveyed dispensed antibiotics without prescription. What we did, we communicated with the people in the Ministry of Health, and they really put new regulation about do not dispense antibiotic without prescription. And we all noticed this. So even if we want to go to a community pharmacy asking for fusidine cream now, we cannot get it without prescription. And we conducted another study in 2020 to make sure that these rules are well implemented. We found that the percentage dropped down to 12.5%. So this is what we talk about impactful research. We do research to make a change in the real world that brings benefits to our society, because we all know the problem that we face in our hospitals, in our practice about antibiotic resistance. So this was one of the examples of impactful research. Despite a lot of research that I conducted, maybe 60–70% were not really, we did not make the right communication, we did not really implement strategies to make changes. So, achieving impact from research is and should remain a fundamental objective of clinical and academic institutions. That's why when you write a proposal, you have to keep in mind 2 major issues. What is the rationale behind your research? Why you want to conduct this research? And also keep in mind another very important objective. What are the positive expected outcomes that your research will bring to your society? If you do not find, or you didn't get convinced, really convinced about these 2 issues, you have to know that you are conducting a homework, a practice, and not a real research. Because always a research you have to add. Add means closing a gap in the literature. Closing a gap, that means you will do something to change the practice, to change the policy, to decrease the cost of health cost. So this is what you have to keep in mind always whenever you want to conduct a research and writing a proposal, whether you are seeking a fund for this proposal or not. Because you have to keep in mind that the funding agency will not really approve to give you money to fund your research if they don't convince that expected positive outcomes are coming from your research. So this is very important. And also, we have to know that this will take really hard work and persistence to create impact from research. So always keep in mind, I don't want to publish just to publish. I don't have to feel proud when only I you don't need only to feel that I want to publish for publication to get recognized, but I want to publish to make really a change in the society. What is crucial about impactful research? Ensuring that knowledge makes a difference and work with those in a position to guide and use research findings to make a change. Even if you want to conduct a simple research about satisfaction of patients coming to your clinic, to your hospital, then you have to really talk with people in higher position because you want to implement the findings of such simple survey in order to increase the satisfaction of your patient. So we should take steps to mutually build beneficial and enduring partnership which shall achieve positive outcomes. Then you have to communicate with people. Once you conduct a research, you have to go, if it's important clinical findings, go and talk to the chairperson of the department, tell him, that's what I found as a change, that's what we should put new guidelines, we should change what we are practicing, especially because everything you are talking about, it's for the benefit of your patients. So let's see here. Here what you are So you are the researcher. So what could my research change? Whom could my research benefit? Very important. We all know from start that I have to define my study population. So whom I am going to benefit from this study and what change I'm going to bring from this research. How could I make this happen? So there are 4 main routes to make this impact. I have to do dissemination of my research, not only by publication, no, but by talking to stakeholders that will really disseminate my research, as Ala said in her introduction, locally first. I know that the purpose behind publication is to share knowledge. So why to people outside and over the world might implement my findings, and I want really, and my local institution, the country where I conducted my research will not really benefit from these findings. So disseminate your research, engage key stakeholders. As we said, policymakers, people like CEOs of medical cities, chairperson, involving possible end users. So sometimes you have to really make public campaigns when you are like a researcher in a specific topic. Like when Dr. Muhammad talked this morning about the importance of the rainbow of food, so we have to really make public campaign to really introduce this to public and then let public ask for more research about this with nutritionists and with endocrinologists and so on. So this is very important when end users ask about conducting more research. We all know that people in industrialized countries like the US, they ask their congressmen to do more research in fatal disease, cancer, AIDS. They push them to do so, and they criticize them when they don't do anything about it. So even though they will take you to even affect the election of the members of Congress or of senators or of governors in the United States, when they do not really push hard to do medical research in the areas that the public asks for. So, and the co-production. So then I will uptake and use of my research outside academia. Again, I stress on this issue. It's not about index journal. It's not about the impact factor of the journal. It's not about the H-index of you as a researcher. It's not about how many times it was cited. It's about making a real impact and change in the real world. So what is the spectrum of impact for research? As you see here, it might affect many areas: technology, social, cultural, environmental, economy, and all really poor in the health of the society. So different organizations have specific types of impact they look for and particular ways of achieving it. So translating, this is a key word, translating of clinical research into real-world outcomes benefiting the health, prosperity and well-being of people and society. This should be our ultimate goal. Now let's talk about what's the difference between knowledge and impact. Once you publish, you are exchanging knowledge. That's true. But we care about impact more. Sharing the knowledge produced by research through publication is really examples that include publication, public engagement workshop, sharing your research with policymakers. Our conference today is sharing knowledge more than impactful. Once we apply what we talk about in all presentations through this conference in our daily practice, that means we are making an impact. So that demonstrable contribution that impactful research make it to society and the economy, then we are talking about impact. Knowledge exchange activities are just activities, things you do, but impact is what happens as a result of the activities, okay? So how to do an impactful research? By conducting high-quality research. How we do high-quality research? We have to select quality of idea. Once we really select a very meaningful rationale, we think carefully about the expected outcome, then the idea will be of quality. And also we have to really respect the good conduct of research. So our methodology should be appropriate, our data collection should be well conducted, and we have to be very careful here. And here also I want to make a small demand. Saudi Arabia is in a great need of biostatistician, of national biostatistician, of biostatistician with background of medicine. Because what we have currently as biostatistician, we have real mathematicians. So a biostatistician that is really conducting the analysis of my good or best research, he doesn't know if the heart is on the left side or left side. He doesn't know exactly anything about the human body or about the specific topic I'm talking about. So please, if you are in a position that you can encourage new generation to take biostatistics as a specialty in medicine, please encourage them to do so. Because we are in great need. If we really want to promote our research to a better stage, we need national biostatisticians with medical background. So, and we have, as I said, the third pillar of high quality research to share the knowledge, not only through publication, but with stakeholders.
Doctor,
researchers
5 minutes.
Researchers who fail to identify and rule out the pitfalls of research process will produce poor research. So what are the characteristics of high quality research? Systematic, logical, empirical, feasible, objective, reproducible, and has a good quality control. Let's say how to get started. Whenever we come with a research idea, I have to plan my study appropriately, conduct the study according to the high standards of good clinical practice in clinical research, and communicate the results. Communicating the result means sharing the knowledge, and as you see, there are some details. Due to time restriction, I won't be able to talk about everything. I thought the time will be better than this. So let's now talk about the pitfalls that we perform or we do whenever we are conducting impactful research. I categorize them in 5 categories: during planning a study, data collection and analysis, writing phase, submitting to a journal, and at the final stage, whenever we get rejected or the editor asks us for revision or acceptance. So planning a study. We do a pitfall when we underestimate the commitment to a research project requirement. When you are a full-time clinician and you know you don't have to do your research, this is a pitfall. When you choose the wrong research topic, this is a pitfall. When you don't consider research bias within your study, this is a pitfall. When you don't focus on which variable to collect, another one. Poor statistical analysis plan and not setting defined author roles. These are the pitfalls that you do during planning the study. That means during writing your proposal. During data collection and analysis, once you don't oversee the data collection and the statistical analysis phases. In the writing phase, when you use outdated reference or poor reference, you don't really apply a good critical appraiser of the literature. This is a main pitfall. When you do not clearly define the purpose of your manuscript, unclear methods, tables and narratives are the same. Do not duplicate your findings in text and tables and figures. One way is enough. Do not report. Once you don't report all the proposed variable data outcome, this is a pitfall. Repeating your results in the discussion section, also this is a pitfall. Make a conclusion that do not align with study objective and results. This is very important. We always see whenever you submit your manuscript that you make a general conclusion. Your conclusions should be based on your objectives and on your findings exclusively. Underestimating the effect of the title. The title is the first thing that attracts attention for editor and readers. So put time on selecting a very attractive title, and do not do your abstract at the last minute by copy-paste. No, you have to really give time and write these 250 words usually by making who reads it understand the whole story. So when you submit it to a journal, what pitfalls we can do when you choose the wrong journal? That's why you need to read what is the scope of the journal and what they are interested in before, because you might have the best manuscript, but they're not interested in such topic. And also put time and ask your colleagues to review your cover letter to the journal whenever you submit it for publication. Once you get rejected or you were asked for a major revision, do not mourning rejection too long. Don't say, oh, they really underestimate my work. You put it aside for a long time. No, work on it and address all reviewers' feedback. So, planning process for impactful research, you should identify the research need and gap, and then you come up with a strong rationale. Define your potential impact, mapping your stakeholders. Who should you involve to whom you want to make this change, to MOH people, to your clinical practice, to public directly, and develop engagement plan, piecing together your implementation plan. So this is your plan, and you see reality is not always the same. Sometimes you have some shutdowns. Identify your research need. That means you come up with a really answerable, meaningful research question. Define your potential impact. I will give this example. We all know that medical curriculum do not involve anything about lifestyle counseling. So we should make some research. We should talk to the university's board of medical schools to include this. The cancers most affected by diet and lifestyle behaviors are those of the gastrointestinal tract. We had several top presentations early this morning about it. So that decreased low fat and high fibers role in prevention of GI cancer. So we should really implement this in our practice, be specific and realistic. This is very important. Whenever you map your stakeholders, there is two major criteria to take into consideration: alignment and interest. Whenever you have high alignment and high interest, there's no problem. You can work in partnership. But when you have one of each is low, you have to develop interest and capacity when there is no interest, and you have to really challenge or persuade when your findings or your rationale do not align with the stakeholder vision.
Your 2 minutes.
Mapping your stakeholders. Whenever the key principles for stakeholder engagement, you have to communicate with them as early as possible. Relationships are the key, compromise, joint understanding. And sometimes, if it's really important, get them with you as co-investigator. Make people that are really potential stakeholders with you in your research team. This is really good. So stakeholder, objective, and how you develop your engagement plan. So you know that from co-design of research, provide data, use the outputs, identify beneficiaries of the research. Piecing together your implementation plan, so you have to do your activity and think about the output. You have multiple lines of each stakeholder, who's going to deliver, how much staff time required, budget, deadline, priority. How is impact measured? Many researchers today are incentivized by their institution to prioritize publication over impact. I said this in my introduction. We should really, the National Institute for Health Research, that there are 4 broad reasons for measuring impact: seeking support, showing accountability, project analysis, and allocation. The take-home message that I want you to have: impact for research is important because it benefits the society and health economy, rather than only sharing the knowledge. Thank you so much.
Excuse me, دكتورة آلاء, I will just announce something. نود أن نرحب معنا اليوم حضور من جامعة حائل، طلاب امتياز، وهم حقيقة حضروا معنا من أول أيام المؤتمر في مساراتهم وتخصصاتهم المختلفة، من كلية التغذية وكلية الصحة العامة وكلية التمريض وجميع كليات الجامعة. فأهلا وسهلا بكم، نرحب فيكم، وإن شاء الله راح يكون مؤتمر مفيد لكم وعند حسن ظنكم وتطلعاتكم. ممكن نرحب بهم، تفضل. أيضا نحتاج ترحيب آخر صراحة لأولادنا، وهم مستقبل هذه البلد، وهم اللي نفخر فيهم إن شاء الله. معنا مسار الثانوية حاضرين معنا اليوم من المدارس الثانوية، وهم مسار الصحة والحياة بالتعليم العام من ثانويات المنطقة للبنين والبنات. فأهلا وسهلا بهم ونرحب بهم أيضا. إن شاء الله الجميع يستفيدون، وهذا المؤتمر إنما يعزز هذه المسارات التي وضعت لكم في المدارس والجامعات، وإن شاء الله تصلون إلى ما فيه تطلعاتكم واختياراتكم في المسارات الصحية في المستقبل. شكرا لكم دكتورة آلاء. The stage is yours. And now we will start the oral presentations competitions. We have 7 speakers for oral presentations. They will speak and they will show their oral presentation, and we'll select in the top 3, inshallah. Thank you very much.
Thank you, Dr. Mish'al. So we'd like to welcome Ms. Basma Al-Aufi. Ms. Basma, she's a senior dietitian working at the Diabetes and Endocrine Center in Breda. Please welcome Ms. Basma.
Hello. I will be talking today about the thyroid disorders and iodine intake in adult females attending the Diabetes and Endocrine Center in Breda in Saudi Arabia. I am working at the center, and we have noticed that in the thyroid disorders, they are increasing in number and intensity of the thyroid disorders. For that, we wanted to see if the iodine intake is having any relationship to the intensity and increasing in number. I will be talking about these outlines, the background, the aim of the study, the material, the result, the discussion, and the conclusion, and what we recommend in future studies. For the background, we have noticed that we know that the iodine is an essential component for the diet. And because it is essential in the diet because it cannot be stored in the body and required in the synthesis of the thyroxine and the triiodothyronine. Several beverages and food, they are containing the iodine, either 3 ways, even naturally, or additive, or in some medication. The naturally, like in the seafood or the drinking water, through the additives like the iodized salt, the table salt, the iodized table salt, or some fortified milk and yogurt. The iodine daily requirement, according to the WHO, it is 150 microgram per day for the adults, female or males. For the pregnant women, they are increasing to 250 micrograms. The upper intake level is over the 1,000 microgram. The temporary excess or insufficient in dietary intake of iodine will not be a problem because it is really monitored and closely balanced through the hypothalamus pituitary gland and the thyroid gland. But what we are talking here about the toxicity and the deficiency in the prolonged time. As you could see, the toxicity is over 300 microgram per day, which is double the amount of the requirement. It could cause goiter, hyperthyroidism, hypothyroidism, autoimmune thyroid disorders, and the bipolar thyroid cancer. Like you could see here, even the excess and the toxicity of the iodine intake, it could cause also hypothyroidism, which is what we are not thinking about. About the deficiency, it could cause thyroid hypertrophy and hypothyroidism, also some kind of cancer as well. The prevalence of iodine intake among population throughout the world, it was in deficiency in 2012. In 2017, it was slightly inadequate, then it was above the requirement in some studies, especially in South Africa, in South Korea. In Saudi Arabia, the iodine intake in 2020 study, it was high in hypothyroidism patient, it was severely deficient. But in this study, they did not include the iodized salt, which is most likely the main source of iodine. The aim for this study is to determine if the dietary iodine intake has a real difference among the thyroid disorders. We included many of the thyroid disorders patients. We are including only female in this study. For the methodology, we have reached over 800 of participants or female attending the endocrine center, but we have had only 44% of the response. After applying the exclusion criteria, we have reached to 331 participants in this study. The tools, we have taken the participant consent form, and then we have applied the demographic questionnaire, and finally, the most important, the iodine food frequency questionnaire, including 13 of the food that has iodine content. For the methodology, we have distributed the questionnaire through online after reaching the participant. Responses are entered in Excel sheet, then we have applied the statistical test through the SPSS. The mean age was 41 years old. For the body weight, it was increasing after being diagnosed with the thyroid disorders in almost 58% of the participants in this research. The mean BMI was 29 kilogram per meter square, which is overweight, considered overweight. Almost half of the participants had a family history of thyroid disorders. As you could see in this graph, we have included many of the thyroid disorders. Most likely we have the hypothyroidism, which is the most known the thyroid disorders among female. Then the hyperthyroidism, the least were the thyroid nodules and the thyroid tumors. The mean total iodine consumption was 260 micrograms per day, which is considered above the required amount of the iodine during the day. The sample primary iodine intake was from the dietary sources of iodized salt and then the fortified milk and yogurt. Most of the sample were consuming adequate amount of the iodine, but also we have high numbers of above the requirement and excessive intake.
5 minutes left.
While the percentage raised to 51%, they're having inadequate amount of the iodine intake when we excluded the iodized salt of the number or the estimated iodine intake. Because of that, we are like the Saudi study that was conducted in 2020, because most of the most of the population or the sample they are having insufficient when we excluded the iodized salt. But when we have only the iodized salt, also it had a really high number of inadequate because we cannot rely only on one source of the iodine. We should include many different food sources to have the required amount. You could see in this table, we have the food sources of the iodine, including the iodized salt, the milk, yogurt, eggs, cheese, white fish, fruit and vegetable, red fish, chicken, red shellfish, and fresh juices. This is like what we reach for the sample and how much they have taken by mean. Most of the intake was from the iodized table salt, like you could see, 100 microgram of the 260 microgram they are taking in the sample. According to the diagnostic type of the thyroid disorders, we have reached to the mean intake of their iodine intake. The hypothyroidism, they are having 210, also above the requirement, as well as the hyperthyroidism. The most intake was in the thyroid nodules, which is a big problem because the nodules, when they are having the toxicity level or above the requirement level of the iodine intake for a prolonged time, it could be turned to a cancer or tumor. The thyroid tumors, they are having the least amount, but it is still above the requirement. Like we said, the mean, it was 260 microgram, which is considered above the requirement. The range was for the iodine intake between 24 to 800 microgram. 800 microgram is almost reaching the upper intake of the required amount of the iodine during the day. Studies, we are recommending to have more studies for the same group, but in male and in different regions in Saudi Arabia. Also, we want to know the effect of iodine intake on the thyroid disorders among different stages in life, like in childhood and pregnancy and lactating women, because a minor alteration in the thyroid disorders could be happened due to the iodine intake. Also, we want to reach a new recommendation after applying like cohort or clinical trials, studies for the iodized salt intake, how much we should take of the iodized salt to decrease the excess amount they are taking of the iodine to prevent the adverse health outcome in the thyroid disorder population.
2 minutes.
Thank you for your attention.
Thank you so much, Ms. Basma, for this research. I just want to share with you, حابة أشارك معلومة مع أخواننا الطلاب والطالبات. الأيودين intake is actually very important. بعد الحرب العالمية الثانية استخدموا اليابانيين اليود على مدى 3 أجيال، لأنه يعني مو بس مهم لصحة الغدة، أيضا مهم للتطور العقلي ويساعد في العمليات الحيوية. So I think this is a very rich area for future research as recommended by Ms. Basma. So the next speaker is Dr. Omar الثميلي. He is an associate professor at the Biomechanics of Human Movement. Dr. Omar graduated from Salford University in 2019, and he's the head of the Department of Physical Therapy at حائل University. So please welcome Dr. Omar الثميلي.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. قبل البداية الصراحة أحب أشكر جميع الأشخاص واللجان التي عملت على إقامة مثل هذا المؤتمر الذين ضحوا بوقتهم وجهدهم. أنا فخور جدا بإقامة مثل هذا المؤتمر في حائل. Today I'm going to talk here on behalf of my colleagues and our beloved students who worked hard to get this study done. So our study is about the quality life among cancer patients in Hail. So cancer is a serious disease affecting all ages and can have a serious impact on people's, on their families, on their lives. And according to the statistics in Saudi Arabia, we have increased in number of cancer population. And in 2023, April alone, we have over 2,000 new cases, which is a big, massive number. And although, the technology and the treatment for cancer patients has improved a lot in recent years, this has led to an increase of the survival rate of the patient up to 50%. However, those patients suffer from complications, suffer from complications affecting their quality of life due to two reasons: the disease itself and the treatment, chemotherapy and radiotherapy, therefore affecting their function, physical, emotional functions, leading to reducing their quality of life. So, and very limited study have conducted, a research to see how is the quality of life among those patients. They are really important patients. Do we care about them, or just we give them treatment to enhance their, the duration, the lifespan duration? So, and as well, one aim of the 2030 vision of Saudi Arabia to enhance the quality of life among the population. This is one good reason to conduct the study. So therefore, our objective was to measure the quality of life among cancer patients. So we conducted a cross-sectional study with Basma Center. Therefore, I would like to thank جمعية بسمة لرعاية مرضى السرطان for helping us conducting this study. They gave us the access. So we contacted the patient. We collected 132 participants above the age of 18. We eliminated those with the severe problems, and we used a questionnaire called EORTC, which is the European Organization for Research and Treatment of Cancer. So this questionnaire is validated, reliable, even in Arabic version. So we used it. The scale contained several outcomes. So it contained 5 functional scales, subscales, and 3 symptoms, 6 items, and the global health scales. Each scale can be scored after calculation from 0 to 100. If you can see, I've just add half of the questionnaire. It contains 30 questions. So the participant answered the question based on not at all, a little, quite a bit, and very much. Okay, and then we included several types of cancer patients as lymphoma, breast cancer, GIT, and spine, thyroid, and other different cancer. So what is the main finding? Our mean age is 45.21, more than half of the sample female. What is the major things we found? First, most of the patients received chemotherapy and radiotherapy. So we found that a reduction in physical function scale, all the scale reduced, especially the physical function scale, because we focus on this more as a physiotherapist, okay? And the second most important thing is the measure of the symptom scales item were reduced, ranging from 26 to 56. And as well, the global health status was reduced. I will show you what is the optimum level for these scales in the next slide. So therefore, we have moved further, one step further. I asked myself a question. I said, then we have the global health scales. How we improve this global health scale? So we moved to we took the regression analysis to know which among of these items can affect the global health status. So we found that physical function and emotional function and fatigue, if we focus on them, we can raise the global health status. Therefore, this is a good finding from the study. So if you look, so we have the mean, and then I looked for another study which has conducted a normative data among healthy population. This population from Dutch population, I couldn't find a normative data from Saudi Arabia. Therefore, I cannot directly compare, but just I kept it so you can see it. So the final column contained the optimal. For functional, we aim for 100. It's normal. And then for symptoms, we need no symptoms. There should be 0. And then the global health should be 100. As you can see, most of the scores are low and the symptoms slightly high. Okay? Therefore, this is the same, but in a bar chart. So what we should do now? That's the main things, okay? So the finding is the quality of life is significantly reduced among those patients. So what about quality of life among cancer survivors? Do we care about them? Do we care about them? Or just we do treatment? We just treat the cancer itself and leave them there. Are they happy in their life? Are they happy? Or just living sad in their homes? We should take care of them. So we focus more on life duration. We need to focus more on enhancing the quality of life, plus the extending the life span. So what we need to do, we need to add something called cancer rehabilitation centers. So we conducted further study to see, do we have a cancer rehabilitation center? So we conducted a survey to see if how is our physio knowledge, attitude, and practice toward the cancer. So we found that our physiotherapists, they have a good knowledge, okay, and attitude. However, they are missing the patient. So they have never received a patient. No single physiotherapist received a patient, okay? So we need to talk to the doctor to refer those patients to the rehab center. So the rehab center should contain a multidisciplinary team: nutrition, psychologist, physiotherapist, occupational therapist, and so on. So what is the recommendation? Provide rehabilitation screening, incorporate objective assessment of the functional status, utilize national report to guide the survivorship care, offer pre-rehabilitation when appropriate, assist current clinical tools and metric for their reliability and validity, and create a centralized electrical interface to facilitate the data collection, and this is really important, and as well to develop practice guidelines. We don't have practice guidelines for cancer patients, especially I'm talking about physiotherapy. And then expand education and training and raise awareness among the doctors and patient as well, and other staff member. And then identify research gap, and in conclusion, I would thanks. It is the same thing that we found the quality of life of the cancer patient reduced. We need to help them to get a better life and to live there and enjoy their life. Thank you.
Thank you, Dr. Omar. That was a well-designed research. And of course, our cancer patients need more attention, especially in terms of quality of life. So now we would like to welcome our second speaker, Ms. May Al-Shammari. Ms. May Al-Shammari, she is a clinical pharmacist. Please welcome Ms. May.
السلام عليكم ورحمة الله وبركاته. أول شيء أحب أشكر المنظمين والمسؤولين لهذا المؤتمر على إعطاء الفرصة لإلقاء هذا البحث. وإن شاء الله منطقة حائل تبدأ من تطور إلى تطور. Before I start, I want to ask you a question. What are the most important diseases that can make chronic pain and can lead to depression as a result? طبعاً اللي عنده إجابة يقدر يجاوب، يتفضل. لا طبعاً الإجابة تحتفظون فيها إلى آخر الليكتشر. إجابة أخرى. السؤال كالتالي: What are the most important diseases that can make chronic pain and can lead to depression as a result? تمام. في نظرك أي من الأمراض يعني في نمط الحياة تسبب آلام مزمنة وتؤدي إلى اكتئاب؟ فهمتوا السؤال؟ إن شاء الله نشوف آخر الليكتشر. So the subject of my talk is connection between depression and chronic pain, a cross-sectional study for individuals with chronic pain disease in high region. Okay, I would like first to give you idea about chronic pain. So, chronic pain is physical disorder and a critical factor in determining depression. Their synchronicity tends to worsen the risk of both disorder. The patient suffering from chronic pain-induced depression show a weaker assessment than these with chronic pain only. Chronic pain and depression are closely correlated in terms of appearance and spread and common proportion their severity progress. طبعاً في هذا البحث المريض لما يكون عنده آلام مزمنة يختلف عن المريض لما يكون عنده آلام مزمنة ما يقدر يتحمل الألم، بالتالي يندرج له إلى اكتئاب. In this study, we further explore relationship between chronic pain and depression in specific community sample. More specifically, we determine the disease responsible for pain and symptom of depression and the degree association between chronic pain and physical condition and symptom of depression. طبعاً في هذا البحث حددنا الأمراض المسؤولة عن الآلام المزمنة، حددنا أعراض الاكتئاب، حددنا الحالة الجسدية المؤلمة المزمنة. Concerning the objective of this study, this research aimed to provide new insights into understanding relationship between chronic pain and depression among the residents of Hail City. Now, let us to move to methodology. This cross-sectional study we conducted online for a patient with depression and due to chronic pain who had already been diagnosed and had visited clinic in حائل Hospital for this purpose between January and March 2020. Data we collected through online response to a questionnaire, patient either gender and 18 years of age or greater were included in the study. Okay, now let's move to the result. In table 1, as we see that 103 patients who participated in present study, 23.3% were male and 76.7% were female patients diagnosed with depression due to chronic pain. Of the 103 participants, 52.4% were in age group 20-29 and 44.7% were in age group 30 to 60 years. And diploma holder, 64.1% held baccalaureate degree and only 2.9% held either master degree or PharmD.
You have 5 minutes.
Okay, in table 2, of the 103 patients who participated in the study, 34% has been first diagnosed with depression due to chronic pain in previous year, and 39.8% has been first diagnosed with 1 to 5 years. In addition, it was found that most frequently used antidepressant drug by patient were selective serotonin reuptake inhibitor, A, used by 49%, and benzodiazepine 10%, B, and tricyclic antidepressant 5%, and 36 did not take any medication for depression. In table 3, most participants has suffered from depression complication due to chronic pain, which varied from drowsiness, stress, and anxiety, and severe depression at beginning overweight. One of either had, it was found that type pain reliever, which they had used to relieve chronic pain, the most frequently used were non-steroidal anti-inflammatory drugs and painkiller used by 71%. In table 5, we're finding as shown 68.9% of respondents report that pharmacists had complained with the time required to produce prescription following patient request. Furthermore,
2 minutes left.
Furthermore, the majority of pharmacists were found to have dispensed the medication and given sufficient and necessary information. And before ending, I would like to conclude that chronic pain is one of essential component of depression determination and their association, while generally increased risk for both illness. Depression and chronic pain are linked, and demographic, risk, lifestyle, and cognitive variable can be used to evaluate the issue. According to our finding, the kind chronic pain, chronic disease, and its link to the patient gender, education level, and pain relief drug include, and the most effective drug determine this association. Finally, I would like to thank you for listening to me. In the end, it's not the years in your life that count, it's the life in your years. في النهاية ليست عدد السنوات في حياتك هو ما يهم، بل الحياة في تلك السنوات. طبعاً حابة أذكر نقطة مهمة. هذا البحث سوينا له نشر في مجلة علمية وهي International Journal Life Science and Pharma Research in November 2021. شكراً لكم.
Ms. May, we'll try to be on time. So our next speaker is Dr. Sayed Amir Ashraf. Dr. Sayed is an academician and researcher in food science and nutrition, working at the Department of Clinical Nutrition at the College of Applied Medical Science at the University of Hail. Dr. Sayed had published more than 60 research articles in esteemed international journal, and he has also a 5-book chapter. Please welcome Dr. Sayed.
Assalamu alaikum. First of all, I would like to thank all the dignitaries present over here and all the researchers. And I would like to thank all the panelists and convener who give us opportunity to present my research work here. So my title for research is Phytochemical Analysis of Eureka sativa and its anti-cancer potential activities against the colorectal cancer cell. And this study was conducted at the Department of Clinical Nutrition, University of Hail, by the team members of clinical nutrition staff. And as a food professional, here we try to investigate, or here we are looking to identify the food bioactive compounds, which are or which can be helpful in preventions of various metabolic disorders such as cancers. So as we know that cancer is one of the leading cause of death around the globe, okay? And there are reports which suggest that around 10 million people has just died because into 2020 just because of cancers. And according to the reports which is published by international agencies for research on cancer, they predict or they estimate that by 2040, the cancer cases will increase by 27 million cases, new cancer cases, and the death rate can reach to around 16 millions, which is going to be very huge. At the same time, what we have found that the incidences of cancer cases in Saudi Arabia has also increased in the last 20 years, which has been increasing, and there are data which suggest that by reaching 2030s, that the new cancer cases can increase to 63%. So according to the IARC, that is International Agency for Research on Cancer, they suggest that, or they published a data which suggests that there are increasing or upsurging the number of colorectal cancer cases in Saudi Arabia. So here, what we are thinking, colorectal cancer is nothing but a outgrowth of cell in colons or rectums. And we all know that for cancer, or the primary risk for these cancer is nothing but the tobacco use, low intake of fruits and vegetables, then a high BMI. These are the few things that are considered as a primary risk to participate in the cancer disease. So here what we are trying to how to prevent this disease, and what are the vegetables, what are the fruit or foods item that and its bioactive compound can be helpful for managing or for treating the disease. So this is one of the famous, I think, the vegetables here we use as a salads, and this belongs to the Brassicaceae family, and it has many phytochemicals that has been reported. As per my knowledge, this is the first study what we conducted on the LCMS studies and related to the colorectal cancer cells. Our objective for this study was to screen out what are the phytochemicals present in this Eureka sativa, that is also called jarjir, and to find out what are the chemical or phytochemicals or bioactive compounds that are present in this extract. Then we perform the antibacterial activities, antioxidant activities, and anti-cancer activities. And thereafter, we perform the computational approach that is called, by using bioinformatics technique. We applied here to understand the solubility or absorptions of these screened bioactive compound in the human bodies. So this is regarding the methodology. You can see here we have applied that for screening of chemicals or bioactive compound, we use HRLCMS. This is one of the machine or apparatus we use to screen out what are the food bioactive compounds present in different food items or extractions. Then we perform the antibacterial activities on 2 gram positive and 2 gram negative bacteria, that is Pseudomonas, Bacillus, E. coli, and Staph, using the agar-well assay diffusion techniques. Thereafter, we perform the antioxidant activity using the DPPH and H2O2 methods. Then we perform in vitro anti-cancer activities using the MTT-SSL. And thereafter, we perform the pharmacokinetic activity using the software tool, that is Swiss ADME and PKCSM. These are the software which is used to identify the absorptions of compound and its physiochemical properties before putting into the in vitros or further research. This is how we perform. We make, this is the result of our experiment.
5 minutes.
Here what we do, we take a plant of this jarjir or Eureka sativa, we dry it. After drying, we make it into the ethanolic extract. And after making an ethanolic extract, we run over the HRLCMS. And this is the chromatogram what we found over there. The peak, it is indicating the presence of some of the bioactive compounds. These are some of the screened compound what we analyze through HRLCMS. We have actually identified around 42 compounds, but I have just mentioned here just 10 compounds to just showcase how the names and the compounds look like when we do the analysis. Thereafter, we perform the antibacterial activities. As you can see from the graph, that extract, ethanolic extract of jarjir or Eureka sativa, it has a very potential effect in reducing the inhibition zone or killing the inhibition bacteria of all these gram-positive and gram-negative bacteria. Thereafter, in antioxidant activity, we use these two methods, DPPH and H2O2 method, and we find that it has a very good potential in killing or scavenging the free radical molecules. And we calculated that IC50 for these two methods. We found for DPPH, the IC50 was around 66.16 microgram per ml. And for H2O2 method, we recorded the results, that is 76.05 microgram per ml. Thereafter, the third point, what we experimented, that is the anti-cancer cell. This is the results what you can see from the control, we treated the cell line from 1 microgram, 50 microgram, and 100 microgram, and how the cell viability of these compounds are able to inhibit the zones of these SCT cell lines. These are some of the results what we have get from these two cell lines, that is SCT and CACO2, where we found that the IC50 was 64.91 and 83.98. This is the last, the computational tool we applied on this extract, what we have obtained. If you can see the egg yolk plot, where you can find the red, yellow yolk and white portion. These two indicate that if whatever the molecule we have obtained, if we apply into the real situation, whether it will be absorbed in GIT or blood-brain barrier. The yellow yolk, it indicates that the absorption of drug will be on blood-brain barrier, and the white indicates it will absorb in GIT. And the other, that is the radar plot, it is indicating that the physiochemical property of identified compound. So based upon this result, we find that Eureka sativa has a very good potential in terms of inhibiting the bacterial growth, in terms of possessing the good antioxidant activity. At the same time, it shows a very good anti-cancer activities. So in the same time, Eureka sativa could have a potential role in developing a nutraceutical product. As a food professional, in future we will be try to isolate those compounds which are responsible for inhibiting these colorectal cancer cells, and further we will improve into developing a nutraceutical products. Thank you. Thank you, sir.
Thank you, Dr. Sayed. This is a very interesting result, and we will keep the questions for the panel discussion because we need to move on. We'd like to invite Dr. Sultan Al-Saleh. Dr. Sultan has a PhD in public health, and he has experience about 10 years of work and scientific research experience to improve public health and food safety inspection. Welcome, Doctor.
السلام عليكم. For good nutrition presentation, and before I go into the presentation, I'd like to ask you a question to actually gain your attention regarding the differences between the food safety and nutrition. And the question is actually, what is the point of a healthy food full of nutrients, proteins, minerals, vitamins, if that food was handled during storage or preparation at restaurant in unsafe manner, and then you eat it, so it's full of nutrients and pathogens. So I will leave the answer to you to think about the difference between the nutrition and food safety. So the overview of our presentation today, first we will talk about numbers and facts about the foodborne illnesses, FBIs, as well as we will talk about the two type of food safety inspection. Then we'll move to the study method before we talk about the findings and results, and we'll end it up with the recommendation and conclusion. So each year worldwide, eating unsafe food causes about 600 million cases of foodborne illnesses or FBIs, and more than 400,000 deaths. The total productivity loss and the medical treatment cost is estimated to cost as high as $110 billion each year due to unsafe food. Also, in the United States, for example, roughly 1 in 6 Americans fall ill after eating unsafe food. Each year, about 128,000 are hospitalized, and 3,000 people die of FBIs. In Saudi Arabia, one important point to talk about here is in 2017, about 841 foodborne illnesses outbreaks were reported in the United States, and over half of them, accounting for about 64%, were associated with eating at restaurants. So, as we can see here, the food production chain from farm to fork, it starts from the farm to the transportation, then to the factories and packaging, to the end of the food production chain. And one of the critical points along the food production chain is eating at restaurant. In Saudi Arabia, even the reporting system is not reliable or sensitive, actually, to record the FBIs. However, the number of the reported FBIs outbreaks has increased from 254 outbreaks in 2014 to 358 in 2018. So there are two types of food safety inspection around the world. The first is the traditional or the classical food safety inspection, and the risk-based inspection as well. So the main and critical difference between the two types of inspection is that the classical approach is actually focusing on corrective actions. So they deal with any associated food safety issues on reactive actions, while the risk-based approach is more proactive nature, whereby it attempts to identify and address food safety issues before they actually become a public threat. So the risk-based inspection is more efficient in minimizing foodborne illnesses, and developed countries are moving toward the risk-based inspection. For example, Canada, Australia, United Kingdom as well. However, moving from the classical inspection practices toward the risk-based practices needs the inspectors to possess some knowledge and skills to be able to conduct the risk-based inspection. So the aim of this research was to investigate and identify...
5 minutes left.
To investigate and identify the skills and knowledge needed for the inspectors to conduct the risk-based inspection. Just go quickly over. So there are some contextual factors also related to the Saudi Vision 2030, why we need to improve the food safety inspection system in Saudi Arabia. This is because the current, for example, rate for restaurants is about 2,000 restaurants per 1 million, and we are aiming to increase this number, I mean the restaurants numbers, to be 3,000 restaurants in 2030. That means 50% of the current rate. Also, some relevant KPIs to the relevant government bodies, which is increase in population satisfaction index with the food safety and decrease in food poisoning cases. Female workforce, so increasing the women engagement in labor market, which will decrease actually the cooking at home rating and increase the rate of takeaway and eat outdoor as well. Also the tourism objectives, this one, and the food is one of the main important factor for the tourism section. So a quick look at the study design. It was a mixed method study design, starting with the qualitative and then to the quantitative, utilizing the sequential exploratory study. So we start with the qualitative interviews, then the findings and interpretation of this VASE was used along with the Food and Agriculture Risk-Based Inspection Manual. This manual identified about 9 areas of knowledge and skills for the inspectors to conduct the risk-based inspection. Then from both resources, we developed the survey to survey all health inspectors in Riyadh. And along the whole process of the research, we actually use the knowledge to action framework. This framework helps to guide the research process to produce implementable and actionable recommendations. So the study was conducted in Riyadh, Saudi Arabia. Why Riyadh? Because it is the most populated cities, and it has the largest number of health inspectors.
2 minutes.
Comparing to, if you allow me extra 2 minutes, I will appreciate that. Thank you. And also it has the largest number of the health inspectors in Saudi Arabia. I will just run quickly through the study result. So we distributed the survey. So I will, for the time constraint, I will only focus on the survey result. So we surveyed all health inspectors in Riyadh, about 502, 301 completed, and resulting in 60% response rate. So the qualification here, another important point, which is the secondary, the highest number of participants were holding a secondary diploma in health inspection. We'll talk here, we actually, the results of the research were divided under 4 main themes, and we'll talk quickly about the knowledge and skills, challenges and obstacles. So there are actually another 9 areas that I did not mention in this presentation. We just want to go through the main 3 areas of knowledge and skills. So the law and regulations, generally the inspectors reported being confident in the knowledge and skills, and only regarding the HACCP, which is stand for Hazard and Critical Control Point System, only 48% of the health inspectors were confident. The HACCP component or area of knowledge and skills is actually the main area of knowledge and skills that the inspectors should possess to be able to conduct a risk-based inspection. I will leave just some. Group comparisons also were conducted. So the only significant difference were identified between the males and females health inspectors, with males displaying significantly higher level of confidence in their knowledge and skills. And this is due to, because we don't have females graduated from the health inspectors qualifications, so they came from different background, nursing, so their knowledge of in food safety are low. So I think this is the main reason for this association. The study results.
I think you can conclude now.
Okay, so I will conclude with the key recommendations. So moving toward the risk-based inspection approach is critical. And if we don't move today, we'll move tomorrow. This is the health qualification curriculum needs to be improved to meet the knowledge and skills requirement for the risk-based inspection. In-depth training of current health inspectors regarding the existing food safety laws and regulations, the HACCP principles, and also enabling the food businesses through the public-private partnership is very important to provide third party that enable the food establishment to to follow the regulations. Thank you for listening. And
Thank you, Dr. Sultan. The food inspection area, it's a growing area. I think it can be improved with a good research. Okay, I would like to call Ms. Halima Sanani. Ms. Halima, she's a clinical nutrition. She has a bachelor and master with honor degree. Ms. Halima, you're welcome to come to the stage.
السلام عليكم ورحمة الله وبركاته. الصلاة والسلام على أشرف الأنبياء سيدنا محمد وعلى آله وصحبه أجمعين ومن اتبعهم بإحسان إلى يوم الدين. First, I would like to thank everyone who participated in this wonderful event and express my gratitude for the opportunity to be here. And I would like to introduce myself. My name is Halima from Jazan. Today in my research, I will talk about the effect of honey consumption on vitamin D in human body, and how it affects and the extent of it affected. The topic of my research study on the effect of honey on the vitamin D. I will start with the ayah from Quran of Surah Al-Nahl that is inspired me to do this study and an attempt to collect information as much as possible about the benefit of honey. بسم الله الرحمن الرحيم وأوحى ربك إلى النحل أن اتخذي من الجبال بيوتا ومن الشجر ومما يعرشون إلى نهاية الآية الكريمة إن في ذلك لآيات لقوم يتفكرون. Introduction. Nutritive advantages in addition to therapeutic possibilities are connected to the consumption of natural honey as a nutraceutical mediator. Honey is becoming more prominent on healthy food buying lists. This rise in request of natural honey can be attributed to its prominence of honey by way of the result of many medical applications. Cedar leaves have been shown to have antibacterial, antiviral, and anti-diabetic properties in biological and pharmaceutical tests. Honeybees rely heavily on its flowers for nutrition as ascorbic acid, riboflavin, pantothenic acid, and niacin, beside other vitamins, as well as many minerals, including iron, copper, calcium, phosphorus, potassium, magnesium, and manganese, and also zinc. Apart from the 9 essential amino acids, honey in turn also including all of the non-essential amino acids with exception asparagine and glutamine. Cedar honey is commonly used as medicine to treat liver condition, stomach ulcers, lung function, and the effect of malnutrition. Cedar honey is said to be effective in treating and even curing bone cancer when taken 3 times daily. Honey contains flavonoids which support immunity, enhance, and anti-cancer properties. Breast cancer, liver cancer, pancreatic cancer, brain tumors, and other cancer can all be treated with cedar honey. Study hypothesis. Null hypothesis, there is no effect of honey on vitamin D, and the consumption of honey doesn't rise the amount of vitamin D in human body. And alternative hypothesis, there is an effect of honey on vitamin D, and the consumption of honey raises the amount of vitamin D in human body. Study question. This study began by asking some question in order to ability to collect the information in orderly and optimal way to get the most result about the effect. This question, is there an effect of honey on vitamin D? Is the consumption of honey rise the amount of vitamin D in human body? The objectives, this study aimed to find out if there is an effect of honey on vitamin D and whether consumption of honey rise the amount of vitamin D in human body. Specific objective to shed the light on the health benefits of honey and the importance of vitamin D. To explore if the consumption of honey rises the amount of vitamin D in human body, to study the role of honey in the absorption of vitamin D, as well as to study the relationship between honey and vitamin D. Methodology, study design, accused experimental design was followed. This study employed a quantitative research design. It now as the procedure of gathering and analyzing numerical data. It is typically used to identify patterns, averages, forecast, as well as causal connection between the variables under investigation.
You have 5 minutes left.
Okay. This research design using questionnaire, experiment, and observation to collect data from 45 participants in Jizan, Saudi Arabia. The data collection tools include questionnaire, the questionnaire including socio-demographic information, anthropometric data, health study, physical activity, and experiment and observation was by data collection sheet to collect or record participant vitamin D, iron, CBC result every 10 days over the period 31 days. The way to conduct the research and study was to take a vitamin D and iron analysis and a blood picture of 45 participants before starting the trial, and then participants were divided into 3 groups. Group 1 was given only honey. Group 2 was given honey and vitamin D supplement. Group 3 was given only vitamin D supplement according to their level of vitamin D in the body at baseline. And this analysis repeated every 10 days. Result, socio-demographic characteristics of participant, age, gender, education, material status, income, all of this didn't affect or nor was affected by honey consumption. Also, smoking and weight status didn't affect nor was affected by consumption of honey. Average sleeping hour per day. At the end of this of the
2
trial,
minutes left.
we will go to a conclusion. There is a result of differences between groups, vitamin D level based on intervention group. After statistical analysis, p-value result 0.008, this more significant, and we will discuss this in the next slide. The result of study indicate the vitamin D levels were highest for group 2, which is the intervention group. The intervention group took honey and vitamin D supplement. Result of the study suggests that taking honey and vitamin D resulted in the highest absorption of vitamin D. The second highest group was group 1, which is the group to which only honey was administered for the period of the study. For this group, the absorption of vitamin D was simply from a normal diet without any supplement. considering that group 3 had the lowest score for vitamin D and that the group was administered only vitamin D without honey, it can be concluded that patients who take vitamin only have better vitamin D absorption from a normal diet than patients who take vitamin D supplement. It's better to take honey with vitamin D supplement. If a patient was to take only one of the two, then honey results in higher levels of vitamin D absorption. Conclusion, this research aimed to determine whether regular intake of honey is in a given method and in a certain amount affect vitamin D level in the body, and whether the honey intake is associated with a high vitamin D level. This study found that natural honey can increase and maintain vitamin D. Daily honey consumption improve vitamin D levels in people with normal, low, insufficient level. Even if honey increases vitamin D level, it doesn't replace supplementation for persons with low or insufficient level. But honey can be used together with vitamin D supplement instead of vitamin D supplement only. The limitation, main obstacles and limitation. Okay. Thank you for listening, and I hope you like my research and presentation.
Thank you, Ms. Halima. Our last but not least presentation by Dr. Tatiana Cope. Tatiana Cope, she's a primary care physician and lifestyle medicine advocate and a global health professor at Northeastern University, Boston, USA. She has more than 20 years of experience in multidisciplinary team, developing business strategies and healthcare policies across Europe and Middle East and North America. Dr. Tatiana, please come to the stage. Thank you.
Assalamu alaikum. Distinguished guests, dear committee and organizers of this exceptional event that is taking place in Ha'il, in the Kingdom of Saudi Arabia. I have to express first my privilege and gratitude for being given the opportunity to address the audience, where we have today also many of the students of the local university. It's a pleasure to open the conversation in a research that we have started to conduct with my colleague and dietitian, Sana. Probably I need to start using the slide. It is important to understand, as we have previously heard from Dr. Mohammed, that when we are conducting research, we are understanding what is the reason for this research. We are understanding who are we targeting in the conversation that we'll need to follow. What else we need to understand, where are the pitfalls, and how we should not be discouraged if we are not really going to be able to publish our research, but on the contrary, to be those of us that contribute to opening new topics, going deeper into conversations that are relevant to inform the stakeholders that are taking strong decisions to lead not just the Kingdom of Saudi Arabia with the Vision 2030, but the world in these changes that are very necessary in this time when we are practicing lifestyle medicine, and for some of us, continuing the education of our students and supporting them to understand where they are in this journey in their studies and how we can support them better. We opened the research topic on female hormonal health. Why we were interested in female hormonal health? First of all, because in the region and globally, there is a use of nutrition to support the health of human beings, of course, to keep our health and well-being, but it's used with herbal medicine in some of the countries as well, more regularly and more often than others. We need to not neglect the importance of herbs and their contribution, and not to exclude the side effects as well. So we need to have informed patients, but first of all, informed future healthcare professionals as well. I will continue with giving another reason why we wanted to do this research. The second reason was not only to discuss the needs of understanding better of female hormonal health, but also to understand what else we have as an opportunity to include in the education of the future healthcare professionals, for them to be empowered in the first year of their studies to think about prevention. We don't want to have patients that we need to cure while they are in their medical studies, while they are in their studies for nurses, physiotherapists, allied health professionals, or public health professionals. We can start from us, and I'm taking this as, let's say, with the medical students. The objectives of this may be too broad, and we need to address the pitfalls of our research that we've realized, because when you are having an ambition to understand better a topic, and when you are going deeper into the conversation with relevant stakeholders that are already leading the dialogue and the actions, you need to be ready that you will come to a conference half a year since you start your discussions and research, and you will limit at this time as a literature review and recommendations that will come from it. But that doesn't mean that you will not be able to continue and progress and open collaborations. I'm expanding a little bit more the conversation just for the sake of everyone that is a colleague like myself as a physician, but also for everyone else who is from the other professions and for the students and the research community. Because we need to keep in mind that we have borrowed the planet from the future generations. We need to keep in mind that the determinants of health and well-being in human habitation are not related only to our objectives, how we want to live our daily life, and for us women, as Professor Ali, the psychiatrist this morning mentioned, to be more aware and care about how do we look and be stressed about it and pay more attention to that. But first of all, not to go beyond the stresses and care about our health and well-being and keep on the agenda that we have. In the case of the females, keep on the agenda that we are mothers, that we are wives, that we are contributors to our society, and we keep our connection in our society. We contribute in the connection of the community because other people are connected to us, and this connectiveness is part of the pillars of the 6 pillars of the lifestyle medicine. We cannot forget this while we are studying medicine. In my case, I was studying, working, and I was a mother when I was in medical school. That is the case for many of the Saudi women as well. So speaking of this, I would like to say that keeping in mind our healthy habits for eating, sleeping, decreasing stress, being connected, we will be able to progress better in our studies in the university and become health professionals that in the meantime also inspire some of our colleagues to change their habits. But let me go back to the methods of our systemic review. And continue with the conversation. I'll leave a space for the questions at the end, and I'll be concluding within the time. Our systemic review was conducted via PubMed, and we followed the PRISMA guidelines. Of course, we've included the keywords that are necessary. You might see some of the keywords related to lifestyle medicine that are missing here. That's one of the things that you can include if you are further developing the research and going deeper into the 2 areas that we've been discussing as our topic. But our initial conversation was
discussing the topic of nutrition and herbal medicine and using the outcomes to address better the conversation with the stakeholders for the need of education in the first semester of medical studies on lifestyle medicine. The methods that we used, as you may see, exclusion criteria were the studies not on humans, and they focused on hormonal imbalances as secondary rather than primary outcome. In the results that are presented here from our literature review, you've heard a lot more from many of our exceptional speakers during the conference on nutrition, and some of them in gynecology and obstetrics, a professor that was speaking on the polycystic ovary syndromes, and so on. So I will not take more time on bringing the evidence deeper on the findings that we have in regards to the nutrition and the herbal medicine, and I will move forward to the next part, which is very crucial for what we are intending to bring today in this conversation with my colleague Sana. Our conversation is about the discussion on the limited research that it is in the area of nutrition and herbal medicine in the region and internationally, and in same time the focus on the need for giving guidelines for better education on the 6 areas of lifestyle medicine for the students. So I will continue with emphasizing some of the points that you've already understood well in the past few days, and you can go deeper into these areas. And we'll continue with the couple of slides on how we need not to take care of the patients only in the future, but first of all, we need to survive the medical school and all other universities that students are involved in order to practice, because we need to take better care of our health. The programs for medical student health and well-being exist in some of the universities within the Kingdom of Saudi Arabia and internationally, but there is a lack of guidance in regards to the 6 areas of lifestyle medicine. So I would encourage the stakeholders who are relevant for this policy making to pay attention on the importance of including these in the already existing curriculums that have been included or in the clubs that are for health and well-being, and find a way how to move forward and make it a policy where it can start only as a workshop, but it can continue as a full-time course in the first year of the studies. And we don't have to be very ambitious to go further in all the students. We can start only with the medical students. I would like to draw the attention on the importance for the education institutions to be receptive to this, for further studies to continue to be conducted, and in the academic settings, the students not to be discouraged to do research. And second, but not least important, to promote healthier behaviors, to prevent chronic health conditions, and improve the overall health and well-being in the medical schools. Because the essence of life is not only aiming for tomorrow, it's living today. And sometimes it might look like a marathon, but we need really to take a step and move ahead. This is not a self-promotion slide. It is a motivation for every one of you to take the lead within the community where you feel connected, and one of your pillars of the 6 areas of lifestyle medicine touches somebody else. Maybe create a local initiative, maybe bring your students to places where they are relevant, maybe ask a colleague what else he can change in their life, or start a craft class together where people will open up in the discussion about mental health and well-being. So let's continue this prevention together and live a fuller life. Thank you again. And once more, thank you for everyone who has participated in this exceptional conference, and I look forward to coming back next year. Thank you again.
السلام عليكم. الآن رح نترك وقت للأسئلة. Now we will have as we promised you from the beginning, that we will have time for questions. If you have any questions you would like to ask the presenters, or any question and related to research in general, because we have our panelists. إذا في أي سؤال متعلق بالأبحاث عامة عندنا، تفضل.
This is just a comment. This is the first time in lifestyle medicine conferences we do research presentations. This year is a pilot, and we have today with us Dr. Mohammed Tanir, and he's one of the leading top research educators and appraisers in Saudi Arabia and also in the world. And also we have Ms. Salah Al-Qurashi. She's one of the leading epidemiologists and researchers also here in Saudi Arabia. And we have with us Dr. Farhan, Dr. Marwa, and we have Dr. Mashal Al-Nais. Thank you, everybody. Just a comment. I don't have any questions. See if Dr. Farhan has any comments.
السلام عليكم ورحمة الله وبركاته. السعداء طبعا أن هناك يعني استلام أبحاث نوعية من جميع القارات. التحكيم صراحة لجنة التحكيم بهروا يعني المجموعة من الأبحاث اللي قدمت، وسعداء أننا أخرجناه بطريقة مختلفة. أخرجناه من قاعات الفنادق، من المناطق المعزولة عن المستهدف وهو إما المجتمع أو المريض، لتكون في متناول الببليك. فوجوده في منتزه السلام هو أن نستطيع أن نقول ثورة جديدة في عالم المؤتمرات. يستطيع المواطن والمقيم أن يطلع على هذه الأبحاث، يقرأ، يستفيد وهي مترجمة. أيضا يحق للباحثين أن يقفوا بجانب أبحاثهم ويفخروا بهذا المنتج الكبير، ويستطيعوا أن يتحدثوا مع المجتمع عن هذا البحث والجهود التي بذلت والتوصيات أو النتائج. أيضا سعداء بما قدم من الأبحاث التي حولت إلى oral presentation. كما أؤكد أن الجميع فائزين بقبول هذه الأبحاث في المؤتمر بحد ذاته، فائزين بنشر هذا العلم على مستوى oral أو poster. سوف يستفيد من هذه الأبحاث مئات بل آلاف الناس في منطقة حائل وزوار المنطقة، ويكفي أنهم أول باحثين تعرض أبحاثهم في منطقة مفتوحة للجميع. أسأل الله التوفيق الجميع، شاكر ومقدر.
سعد الله مساء الجميع. بس في اقتراح. طبعا شاهدنا قبل شوي محاضرة الدكتور سلطان، وكانت عن السيفتي فود والهاندلينج، وكانت صراحة يعني وضعت اليد على جهة. أغلب المحاضرات كانت عن الفود يعني والهيلثي فود، ولكن أيضا الهاندلينج نقطة مهمة جدا أيضا. فأقترح أنه تكون أحد الريكومنديشن من المؤتمر إيجاد مختبرات أيضا، خصوصا تخص ممكن وزارة الزراعة أتوقع، خصوصا اللي تفحص المواد الزراعية اللي تباع بالأسواق. تعرفون بعض العمالة أحيانا يستخدمون بعض المبيدات الحشرية اللي يكون التحريم فيها أكثر من 20 يوم، وللأسف ينزلونها بالسوق بعد يومين ثلاثة، وهذا يسبب كانسر وأيضا يعتبر من نمط الحياة الصحي أنه يكون فيه مراقبة. ومثل ما ذكر الدكتور صالح، جهات كثيرة تشترك في التخطيط وأيضا الريكومنديشن لهذا المؤتمر. أتمنى التوفيق للجميع إن شاء الله.
عن إذنكم احنا سوف نتداول الأبحاث التي عرضت لمدة 5 دقائق، نختار أفضل 3 أبحاث معنا، وزي ما تفضل دكتور فرحان هو اللي قدموا واللي قبلوا كلهم ما شاء الله أبحاث جميلة، ولكن كمسابقة احنا we want to select and nominate by the journey panel the top 3 research. Just give me 5 minutes inside and we will come back. لا تتحركون 5 دقائق بس نجي إن شاء الله. إيه ممكن تسوون رياضي ما عندك مشكلة. بس
Stand
لحد
up for
يطلع.
5 minutes. Thank you.
السلام عليكم ورحمة الله وبركاته. نستغل الدقائق هذه ما دام اللجنة في عمله. طبعا في مؤتمر حائل الدولي الثاني لطب نمط الحياة نحن فخورين وسعداء بهذا الحدث العظيم الذي لم يكن إلا بتوفيق من الله عز وجل، ثم بدعم من حكومتنا الرشيدة التي جعلت الإنسان أولا، ورأينا ذلك في جائحة كوفيد حينما وجهت كل القوى وكل الإمكانيات وتم التنازل عن يعني أشياء اقتصادية كبيرة لسلامة الإنسان. ثم بعد ذلك باهتمام وزارة الصحة بالجانب الوقائي وهو برامج التحول الصحي. ثم بعد ذلك صحة حائل بالتعاون مع شركاء النجاح. شركاء النجاح هم الدكتور صالح الراجحي، هم الأمانة، هم التعليم، هم أمير منطقة حائل، هم أنتم كمشاركين وكحضور. في منطقة طبعا احنا تعلمنا من سمو ولي العهد أن طموحنا عنان السماء. يعني في النسخة الأولى للمؤتمر ربما نرجع خطوة للوراء، احنا فكرنا أن نكون في الهواء الطلق، نكون في منطقة يعني بيئية. كان هناك تحديات، ربما يكون في مشكلة في الكهرباء، في النت، في ربما أن يفشل هذا المؤتمر لأنه في خطوة غير مسبوقة، الريسك عالي جدا. لكن الشجاعة هو جزء مهم أيضا من تحقيق الطموحات، وخصوصا بطبيعة هذا المؤتمر. فكانت الخطوة الأولى بتوفيق الله ثم بتعاون الجميع مع يعني جميع القطاعات التي شاركت. نجحت أول خطوة في نقل المؤتمر من القاعات المغلقة إلى القاعات المفتوحة. أيضا كان هناك جانب آخر، يعني الجميع يحضر مؤتمرات دولية، دائما يكون المؤتمر في منطقة محددة، في قاعة فندق أو قاعة جامعية أو إلى آخره. هناك مستهدفون محددون المسجلين في المؤتمر، لذلك طبيعة المؤتمر هي مختلفة. نحن نستهدف المجتمع، فإن لم يكن المجتمع شريك لنا فلن نحقق المستهدف مهما جلسنا في هذه القاعات ومهما نشرنا من الأبحاث. حتى المجلات العلمية الأكسس لها دائما محدود، فالترجمة اللغة. لذلك حرصنا أن نطلق هذا المؤتمر ليطير كالصقر يحلق في السماء ليصل إلى محافظات المنطقة. في منطقة حائل 8 محافظات. طبعا أن تقوم بمؤتمر في مقر رئيس هو جهد كبير وتحدي وقلق لنجاح هذا الحدث، فكيف لما تطلق 8 محافظات في نفس الوقت؟ طبعا المحافظات هي محافظات نائية نوعا ما، يعني تبعد 250 كيلو 200. فتوجهنا يا سمو أمير منطقة، يا سمو الأمير عندنا احنا مشروع كبير جدا، لكن ترى الريسك عالي، وترى يعني تحدي، وترى لا يوجد شيء نقارنه مسبقا، لا يوجد حدث مشابه. نحن نريد أن نصل إلى المجتمع في المحافظات، وعندنا خطة سبيكرز جاهزين، يعني أنهم متطوعين أنهم ينتقلون. فقال سمو الأمير أنتم بس وش تحتاجون ونحن نسهل كل الإجراءات. فوجه سمو الأمير جميع المحافظين في المنطقة في المحافظات بدعم هذا المؤتمر. المحافظ وجه جميع القطاعات في المحافظة بدعم هذا المؤتمر. المجتمعات في هذه المحافظات لما سمعوا أنه في حدث دولي وجزء من الحدث راح يكون في المحافظات، وراح يكونون على لقاء مباشر مع علماء واستشاريين واستشاريات، يعني قضوا سنوات من العمر في الكد والتعب والبحث والغربة ليحصلوا على هذا العلم اللي أحضروه للوطن. فكانوا يعني متشوقين أنهم يحضرون لهذه الندوات اللي راح تقدمها الزميلات والزملاء في هذه المحافظات. فانطلق الاستشاريون والاستشاريات إلى المحافظات العام الماضي، فكانت تجربة يعني رائدة جدا. حتى يمكن أقول الشغف اللي كان في المحافظات ربما يوازي الشغف في منطقة حائل أو أكثر. هذه التجربة وضعت لنا حجر أساس أنه لن يكون شيء لحائل دون محافظاتها. وطبعا هذه ليست لحال، نحن الآن كنا في تجربة، الآن نحن في واقع يعني ولله الحمد ملموس ومقيم ذا جودة. لذلك المحافظات هي جزء لا يتجزأ من مؤتمرنا. طبعا هذه خطوة، الآن مستقبل ربما نخطو خطوة أكبر من ذلك إن شاء الله. صحة المرأة يعني نظرنا لها من منظور مختلف. تعرفون الآن في حراك كبير، وفي يعني عمل المرأة أصبح الآن بحجمه أكبر. طبعا يعتقد الناس المرأة اللي ما تشتغل إنها ما تشتغل. المرأة هي أكبر من يعمل، يعني يكفي أنها تربي وتعتني في منزل وتبني أسرة وتعلم، هذا كل الجهود داخل البيت يعني، لكنها ليست وظيفة رسمية حتى نقول أنها موظفة. فما بالك لما يكون عندها وظيفة وعندها يعني عمل إضافي وجهد المنزل. فقررنا أن يكون في هناك برنامج خاص لصحة المرأة سميناه تعزيز صحة المرأة. وضعناه أيضا في مكان خاص حتى نعطي بعض الخصوصية للمرأة حينما تلتقي في المرأة العالمة والمختصة، حتى يكون هناك حوار مفتوح، تبادل يعني أسئلة، ربما يكون في مساحة لكل فيما يجول في خاطر السيدات مع الزميلات الاستشاريات. لاقينا الحمد لله نجاح واسع العام الماضي، وأكدنا ويعني من هذا الانطباع أنه يجب أن يتكرر هذا اللقاء وبشكل يعني أوسع وأجمل. ولله الحمد تكرر أيضا هذه السنة وحقق نجاحاته. طبعا هناك مبادرات مصاحبة مثل ما يعني طلعت عليها ما يخص مثلا المبادرات الرياضية وإلى آخره. حرصنا على إشراك الجمعيات ذات العلاقة. الهايكينج، دعينا جمعية الهايكينج من خلال يعني المنصات ذات العلاقة، المشاة، السعودية الخضراء، المعاقين ما يكتب اسما وهو ذوي الهمم، يعني في الواقع ذوي الهمم، كلهم كانوا شركاء معنا في المؤتمر، لم يكونوا جمعية فقط تجي يعني تشارك معهم، شركاء في صنع المبادرة بحد ذاتها. فإشراك كل هذه القطاعات وضع المؤتمر يعني في حجم كبير جدا، هو من جانب تحدي ومن جانب إنجاز أن يكون فريقك ذو اختصاص. فبدل ما نفرض حنا نوعية هذه المبادرة وآليتها بطريقتنا، لا، نعطيها أهل الاختصاص حتى يهيئوا الخطة متكاملة ونحن معهم في الإطار العام. والله الحمد كلها يعني صارت بالطريقة اللي يعني كنا نخطط له وبطريقة أجمل بفضل الله. انتقلنا إلى السنة هذا المؤتمر اللي تشرف بوجودكم معنا ونجاحه بعد فضل الله ثم وجودكم وتعاونكم. أمانة المنطقة تبذل جهود كبيرة طبعا بتوصيات المؤتمر الأول، كانت توصيات كبيرة بأنسنة المدن، بوجود مماشي قريبة، بوجود مسارات آمنة للدراجات، مسارات آمنة لذوي الإعاقة أو ذوي الهمم. أحيانا السيدات مثلا اللي ما مع سيارة وتبي تمشي غير آمن أنها تمشي في شارع في سيارات، وغير قادرة ممكن تروح الممشى مثلا على بعد 10 كيلو، ولو راحت اليوم ممكن ما تروح بكرة يعني. فالأمانة عملت يعني جهد رائع جدا بإنشاء ممشى في كل حي في المنطقة. كنت أنا جالس مع الأمين نتحدث عن مؤتمر النسخة هذه، فقال ليش ما نغير ثقافة أنه المؤتمر في فندق أو العام يعني كنتم في بيئة خارجية تكون في منتزه، نغير ثقافة المنتزه وليس حديقة أنك تجلسوا مثلا أولادك يلعبون أو تفرش فرشة وتتقهوى، ليش ما تكون حاضنة لحراك علمي مرتبط أيضا بنتائج هذا الحراك. فاتفقنا أنها تكون في منتزه السلام وباركها سمو الأمير، فيعني سهلت كل الإجراءات لتكون في منتزه السلام. بعد ذلك جت فكرة أنه كيف ممكن ننقل الأبحاث العلمية من الصالات المغلقة إلى الصالات المفتوحة، من المختصين فقط إلى المستهدفين. الآن المجتمع مختلف عن المجتمع قبل مثلا 20 سنة، الآن الجميع يقرأ ويكتب، الجميع عنده ثقافة، الجميع يصل عبر السوشيال ميديا وعبر الإنترنت إلى المعلومة التي يريدها، لكن حرصنا أن يصل إلى معلومة دقيقة، إلى مصدر مختص. هذه الأبحاث أولا قاموا عليها أنتم عالمين وعالمات ومختصين، ثانيا مرت عبر لجان تحكيم دقيقة جدا، ترجمت بلغة يعني تتناسب مع الببليك كأبستراكت. أتيحت الفرصة للمجتمع أنه كل واحد يجي يقرأ عن الجانب الغذائي، يطلع على الجانب، يشوف التوصيات. وحرصنا أيضا أن الباحثين، دائما الباحث يبذل جهود ربما أشهر أو سنة أو سنوات لإنجاز بحث علمي، لكنه يعني لا أحد يعرف التفاصيل، الناس تقرأ الأبستراكت في نص دقيقة وهالجهود المبذولة. فيعني ارتأينا الباحثين يقفون أمام أبحاثهم بفخر رافعين الرأس ويتحدثون للناس عن هذا البحث والجهد اللي بذل. وتكون أيضا ثورة في علم المؤتمرات اللي احنا نتشاركها الآن. وصلوا اللجنة أخيرا، المؤتمر لا يقف على مدير عام الشؤون الصحية أو رئيس اللجنة العليا أو اللجان الفلانية. المؤتمر نجح بعد توفيق الله بتضافر الجميع، بدعم سمو المنطقة، بحرص وزارة الصحة، بحضور المهتمين، وأيضا التكامل مع القطاعات ذات العلاقة. وهذا راح يضمن لنا بأمر الله أن راح نكون في النسخة الثالثة أكبر والرابعة أكبر بكم ومعكم بعد توفيق الله. شكرا لكم.
Now the result coming. So Dr. Farhan, Dr. Saleh, please join us on the stage. راح نعلن نتائج اللجنة وإعلان الفائزين الثلاثة توب 3 في الأبحاث التي تقدمت إلى مؤتمر حائل الدولي الثاني لطب نمط الحياة. راح نبدأ مع the third place. We will start with the third place winners. Will announce? ولا wait? Okay, دكتورة حليمة, please come third place. المركز الثالث. في المركز الثاني second place دكتور عمر. المركز الأول متى تبون نقوله؟ الحين ولا بعد شوي؟ بعد البريك؟ ولا مستعجلين؟ استاهل. المركز الأول the first place abstract in the conference دكتور سيد عمر. الآن الجزء الأخير من نشاط اليوم اللي هو توزيع الجوائز والشكر للباحثين، لجميع الباحثين المقبولين في مؤتمر طب نمط الحياة في حائل. We'll distribute the honoring for all the researchers accepted for oral and poster presentations. We'll start with Dr. عمر الثمالي. Please join. استاهل. دكتور ندى الناجي. دكتور ندى, are you there? Okay. دكتورة أسيلة الميمان. دكتور ثاني القرني. دكتورة سلمى اليعقوب وتستلمها نيابة عنها دكتورة مي شمري. دكتور تيتيان كاب. دكتورة بسمة العوفي. دكتورة حليمة السناني. صنعاني، سوري، حليمة صنعاني، تفضلي. دكتورة داليا المزيني. دكتور ياسمين الهمزاني. دكتور عفاف الرمالي. دكتورة هند الحربي. دكتور رحاب العنزي. ما شاء الله. دكتورة أسماء الشمري. دكتورة سوزان جيلاني. Thank you, دكتورة سوسن. دكتورة فاطمة الطاهر. دكتور سيد أمير أشرف. and دكتورة أفنان آلي حسين. طلع السلام. يعطيكم العافية جميعا. وصلنا إلى نهاية برنامج هذا اليوم. Thank you very much for all. We finish the activity for today and we'll see you tomorrow inshallah. Thank you very much. The bus, all the bus waiting for you. If you want to join the group to Jubba and will hiking activity. They are waiting for you in the lobby.
Now, please. Thank you very much.
Recording stopped.